Okay, so hi, evening friends, evening everybody, evening everybody. I guess we know each other pretty well. I'm Dr. Sushant Soni, MBBS MAMC, MD Pathology, Resident Hemat-Oncology, AIMS Delhi. And today was our INI exam. I mean, all of us know this well. And Diwali na thoda sa unhone pehle foda hai, bomb thoda sa pehle foda hai. I'll say so because before I start with the pathology recall, let us quickly have a look at overview of the paper for the juniors also. Now the paper was divided into 4 sets. I'm sure that all of you who gave the paper as well as the juniors know this. Now, hi, evening Dipesh, evening Dost. Now the problem becomes that in set 1, anatomy bhar ke tha. There was lot of anatomy questions which were lengthy also. So majority of the students had slight issues in completing the set 1. Set 2 and 3 were absolutely okay. That is path, pharma, micro, medicine, and for that matter, surgery also was sort of doable. These were doable, though the questions were tricky, but at least they were not as mind-boggling as anatomy. There were a lot of anatomy as well as pharma questions. देखो बच्चे, what we are seeing in the previous papers is the examiner gives undue importance to few subjects as compared to others. So anatomy and pharma, I know total set हो गया था. So anatomy and pharma were slightly more. The 4th set had slight factual questions, and there were about 50 images in the whole paper. So this was the overview of the paper. Firstly, the paper was doable, and the bottom line or the carry home messages, we can under no circumstance underestimate the first and the second year subjects. They are the ones which actually, you know, जैसे हम बोलते हैं हिंदी में कि नैया पार कराएंगे. So let us start with our pathology recall. Now starting with our first question, इसको हम फटाफट से देखते हैं. Match the following with respect to the options. You very well know JAK2 V617F mutation is seen in PV. It is seen in PV, polycythemia vera PV, ET, PMF, most commonly seen in PV. That is JAK2. ALK mutations are associated with adenocarcinoma lung. Most common with adenocarcinoma lung is EGFR, ALK, adenocarcinoma lung. CKIT with GIST versus KRAS, that is pancreatic neoplasms. Next, transferrin saturation is reduced in. See, some of the questions with respect to pathology were extremely straightforward and easy. You know that transferrin, hi evening months, evening bache, you very well know that transferrin saturation is reduced in iron deficiency anemia. In case few of my questions have slightly different language or any additional option is there, do not hesitate to tell me this right now. We'll take care of it. Next, sickle cell as compared to normal RBC has. Examiner here is talking about osmotic fragility and mechanical fragility. देखो बच्चे, 2 terms were used. I always find it easier कि you first think of the answer and then go to the options. Sickle cell anemia has reduced osmotic fragility because sickle cell is a dehydrated RBC. First water enters, it becomes normal, then water enters, it undergoes hemolysis. It has reduced osmotic fragility with increased mechanical fragility. That is why it is a hemolytic anemia. So the answer was 4. The answer was 4. Next, which of the following is found in the image given? Now I was told that this was the exact image which was given to you in the exam, and the minute I see this image, I am clearly able to see the presence of multinucleated giant cells having a horseshoe shaped appearance. That is, these are Langerhans giant cells associated with TB. I am not even interested in telling you that these are the granulomas in the background. All these are the granulomas. So it was a case of tuberculosis. Which of the following is the cytokine associated? TB will be associated with chronic cytokines. That is interleukin 2, interleukin 12 and interferon gamma. This was TB. Next question. Now you will be able to answer both these questions just on the basis of bulla which is seen. You are clearly able to make out that this is the bulla which is suprabasal in location. It is a suprabasal bulla, that is pemphigus vulgaris. It was a suprabasal bulla. Let us have a quick look at the types of bullae. Suprabasal bulla, it is present above the basal layer as is seen in pemphigus vulgaris. This was the image that was given in the paper. Next is the presence of a subcorneal bulla below the corneal layer, seen in pemphigus foliaceus. And lastly is the subepidermal bulla, which is seen in bullous pemphigoid or dermatitis herpetiformis. So there are three main types of bullous lesions: suprabasal, subcorneal. Suprabasal was this one that was given in the paper. You had a basal layer above which there was presence of a bulla, pemphigus vulgaris. Next is the subcorneal bulla, pemphigus foliaceus, and lastly is subepidermal. Hi, evening friends, and for everybody, please do keep on telling me the answers that you marked or any particular question which you found to be slightly tougher. Do tell me, because till now all the questions that I have covered are sort of simple and okay. We have had two controversial questions in pathology. We'll see that. What do you see in this image? This is that of direct immunofluorescence, and this is a direct immunofluorescence of dermatitis herpetiformis. This is the IgA mediated picture which we see at the dermal epidermal junction, IgA deposit seen in dermatitis herpetiformis. This was not fishnet. All of us know that fishnet pattern looks like this. That is, fishnet is seen in pemphigus. This is a prospective NEET PG question. This is what fishnet pattern looks like. This was direct immunofluorescence, dermatitis herpetiformis. Next question, straightforward again. 30 female on a strict vegetarian diet has low hemoglobin, MCV is high. The minute the examiner is talking of a vegetarian, that means he is pointing you towards vitamin B12 deficiency, megaloblastic anemia. B12 deficiency, megaloblastic anemia. Next. Now, this was tricky. Patient comes with nephrotic syndrome. His creatinine was 4.25. Which of the following is true? FSGS cannot be diagnosed with biopsy alone. It can be diagnosed, so this is false. If hematuria is there, then it is suggestive of hematoma. This is obviously out. We had confusion between option B and C. 24-hour observation after renal biopsy. Dekho bache, now there are two thought processes. Some articles say that an 8-hour observation period is sufficient to be extended to 24 hours if there is history of flank pain or hematuria. Whereas few articles say that 24-hour observation period after renal biopsy is a must. So I will put plus minus on option B. Now let us have a look at C. Renal biopsy must be done in amyloidosis. No, this is false. It depends upon the type of amyloidosis, and if it is limited to kidney or if you are looking for prognosis, then it is a must, not otherwise. So the answer was B. Best answer in this case was B. Next is Anugya Bache. If there is any change in the options, please do tell me. I know the recall with respect to this was slightly tougher. We had a group of students who gave the paper and we did the recall with them. In case there is any difference in options, tell me right now. Next, cystic fibrosis, CFTR gene mutation associated with increased chloride transport in sweat. Most common presentation is salty sweat. Most common being salty sweat, which is detected by kissing in children. That is, it is a disease of infancy and childhood. Next, this was the exact recent NEET PG previous year question also. HPV vaccine is by the structural proteins, that is L1, versus carcinogenesis. Carcinogenesis is by early proteins. HPV, cervical pap smears. There were two questions on pap smear in your this INI exam. We'll have a look at that. First was HPV vaccine. It is made from L1. Versus carcinogenesis is by E2. When integration of viral DNA with host genome occurs, E2 reduces, E2 increases, as a result of which E6 and E7 increase. Increase in E6 and E7 inhibits P53 and RB gene. E2 reduces, so E6 and E7 increases. Next, there was increase in sweat chloride and decrease in pancreatic secretions. Okay, so there was increase in sweat chloride with decrease in pancreatic secretions. Decrease in pancreatic chloride. Perfect. Both. Anugya agreed, bache. Because you know that in sweat ducts, CFTR, there are two proteins associated with cystic fibrosis, CFTR protein and ENaC. The function of both reduce. As a result, there is increased sodium and chloride in sweat ducts. Opposite role in pancreas. In pancreas, sodium and chloride are increasing in the cell. This was cystic fibrosis. Next question, seminoma, the marker is. Now there was actually a lot of confusion with respect to options in this, whether it was a multiple option 1 2 3 4 1 2 3 and so on. So OCT, PLAP and NANOG are the seminoma markers. These are the seminoma markers. If I have to choose one out of these, the best answer was PLAP. We do not consider HCG as a seminoma marker, though it can be seen in less than 15% cases of seminoma, but we will not be marking it as a seminoma marker. So the answer was 1, 2 and 4. It is not HCG. Next. Now in this case, preservative for light blue vial, aim is glucose estimation. But when we talk of glucose estimation, we do not use a light blue vial. And no image was there. I don't know why the examiner wrote it as light blue vial. I cannot explain that. Glucose estimation is performed by gray top. This is the gray top where potassium oxalate is the anticoagulant used. We have sodium fluoride in it also, but it is to inhibit glycolysis. So answer was potassium oxalate. Next question. HBs antigen negative, anti-HBs antibody negative, only anti-HBC antibody was positive. The minute HBs antigen is negative, now think of it yourself, the minute HBs antigen is negative, chronic or acute hepatitis as options are fully out. The minute anti-HBs antibody is negative, vaccinated individual is out. So what was left was the last option. Now again, whether window period was given in the options or not, or some people said that it was a healed period or something like that, some other word was mentioned, that is the answer. If window period was given, that is the best answer. Presence of IgM, anti-HBC antibody. Next question. Now inheritance was given to you. It was match the following: cystic fibrosis, autosomal recessive; Duchenne's muscular dystrophy, X-linked recessive; Leber's hereditary optic neuropathy, Mendelian inheritance; versus myotonica dystrophica, that is autosomal dominant. This was the match the following questions. Next, again a simple straightforward question. Now with respect to pathology, actually the questions other than two, they were simple and straightforward. That glucose thing was slightly dicey. Luminal A is ER positive, HER2 negative, low proliferative breast cancer. This is the most common, best prognosis. You know this extremely well. Most common, best prognosis. Versus ER positive, HER2 negative, high proliferative is luminal B. This is the one which is associated with BRCA2. Which familial gene mutations? BRCA2 gene mutation. So the answer, plain and simple, was A. Triple negative is BRCA1 gene mutations. Next, window period was in the option. Perfect. So if window period was there in that liver wala question, then the answer, simple, straightforward, becomes window period. Next question. Basal cell carcinoma image was given to you. So I want actually you to tell me whether it was exactly this image or something else was given. So what we see here, this is the normal stratified squamous epithelium, which is showing the presence of a tumor with peripheral arrangement of basaloid cells. The cells are basaloid with peripheral palisading of the nuclei, along with presence of a clear white retraction cleft. This is retraction cleft associated with basal cell carcinoma. Done, bache. Absolutely and absolutely done. Achha, we have 3 more questions. Next is protein electrophoresis. It was a written MCQ. We do not have the proper recall of the same, but what I was told was albumin was reduced along with reduced globulins. If you can give me, it was a skin lesion of BCC, basal cell carcinoma. Agreed. Now protein electrophoresis, if you can give me the recall, beta 2 globulins were increased. This was the question that was recalled as nephrotic syndrome. In nephrotic syndrome, obviously it is associated with hypoalbuminemia, hypogammaglobulinemia with increased beta 2 globulins. That was nephrotic. Acha, another question that was asked was with respect to Rehnke's crystals. Rehnke's crystals, if the question was it is associated with which of the following tumors, it is seen in Leydig cell tumor of the testis. Leydig cell tumor of the testis. Next. So, protein electrophoresis was an image given or was it a written MCQ? I mean, I'll be very glad if you can tell me the written MCQ in this. Albumin, alpha-2 globulin and gamma globulins are reduced. Albumin, alpha-2. एक बार tell me बच्चे कि उसमें क्या reduced and increased लिखा था, and I'll take care of this question. Done. So on this note, see, there is absolutely no doubt about this. An image was given. Actually, Anugya, there was a lot of difference ki whether protein electrophoresis image was given, it was not. I don't know. So we'll come back to that question with, I know some majority told me it was a written MCQ. Majority told me that only. But one thing is certain, that we are in this journey together. There is absolutely no doubt about it. The purpose of the recall is not to give you any anxiety or something. It is just to tell you that these are the answers, and much more importantly, these are the topics. Topics are always repeated. You had questions from sickle cell anemia, recent NEET PG topic also. The topics are repeated. You had 3 questions from dengue, 2 questions from acid-base imbalance. There were 2 questions from sickle cell anemia. One sickle cell anemia question I have catered to, that reduced osmotic fragility, increased mechanical fragility, reduced OF, increased mechanical fragility, and the next was which therapy? Hydroxyurea and methotrexate. So the topics are repeated. So have, needless to say, bestest of luck for this paper, and let's hope for the best. Take care. Take care, and I'll hand over the mic to our next faculty. Thank you.
Hello and welcome to this INI-CET recall session for this November 2023. Hope every one of you is fine and the paper went well. Now one thing is for sure, means looking off about the questions that were asked in this orthopedic examination 2023 November session in INI-CET, that everything is going to be asked from your notes or what you are studying. You know, repeatedly they are asking the similar concept again and again, with slight change in the language of the questions, with slight change in the options which are about to be marked. The questions were relatively simpler, they were straightforward as far as this orthopedic session was or is concerned. Now, starting with the first question, that 3-point relationship in the elbow joint is likely to be affected in all of the following cases except. Now, this is a kind of the question, it is a primitive kind of a question. It is not asked for the first time. These are the kind of the questions which they have asked right since 80s, right? 80s, 90s, these are the kind of the question they are asking. And in between somewhere, there was loss that these kind of the questions were not very frequently asked. Today, they have asked this question again, that 3 bony point relationship is likely to be affected in all of the following cases except. So first of all, what is 3 bony point relationship? As we have very thoroughly discussed in our sessions also, like if you know that the distal end of the humerus has got the medial and the lateral epicondyle. So there is a medial and the lateral epicondyle, and it is articulating, you know, the trochlea is articulating with the olecranon process of the ulna. So the third point is the tip of the olecranon. Now these 3 structures are related in a manner that when you flex the elbow to 90 degree, all right, when the elbow is flexed to 90 degree, this is medial epicondyle, this is lateral epicondyle, and this is the tip of the olecranon. They are responsible for creating an isosceles triangle. So medial epicondyle, the lateral epicondyle, and the tip of the olecranon, they are responsible for creating an isosceles triangle. Isosceles triangle is the triangle which has got two same sides. All right. So they are creating an isosceles triangle in 90-degree flexion of the elbow. Now, if the elbow is extended, when the elbow is extended, then all these three bony points, they form a straight line. So with the extended elbow, the medial epicondyle, the olecranon and the lateral epicondyle, they create a straight line. And this is what is known as three bony point relationship in a normal individual, where the range of movement is normal, where the range of movement is not affected, where the patient is not suffering from a fixed flexion sort of a deformity or a stiffness of the elbow, right? So this is what the three bony point relationship is. As it is very easily depicted in this image itself, like one of the structure is medial epicondyle, the other one is the lateral epicondyle and the tip of the olecranon. And these three structures, so the lateral epicondyle, the medial epicondyle and the olecranon, they are creating a straight line when the elbow is extended with the extended elbow, and they are responsible for creating an isosceles triangle with the elbow flexed to 90 degrees. This is what the three bony point relationship is. Now, imagine if the structure that is medial epicondyle is fractured, if there is a fracture in the medial epicondyle, then obviously there is going to be a change in this three bony point relationship. If another of the component like lateral epicondyle is affected, there will be a change in the three bony point relationship. Even if the intercondylar region of the distal end of the humerus is fractured, if there is a fracture in the intercondylar region also, then also it is going to be affected. If there is a fracture in the olecranon, even if there is a fracture of the olecranon, then this thing would be affected. So anything which is involving or being a part of this three bony point relationship, then it will result in the affection of this three bony point relationship. For example, if the patient on the left side is having a normal elbow, on the right side there is a malunited medial condylar fracture of the elbow, then it will result in a change or asymmetric three bony point relationship, right? So you have to compare it with the contralateral elbow of the same patient. Now, as you can very easily identify now that the supracondylar fracture means, supra means above the level of the condyles. So here somewhere the supracondylar fracture is happening above the level of the condyles, right? Which is not directly involving the medial epicondyle and the lateral epicondyle. So this becomes the identification criteria for supracondylar fracture of the humerus, that if a malunited supracondylar fracture, if the patient comes to you, then three bony point relationship is unaffected. It is maintained. All right. So answer for this question is obvious. That is supracondylar fracture of the humerus. So three bony point relationship not affected in which of the following elbow fractures? Answer for that question is supracondylar fracture of the humerus. Now there are some prerequisites though, that the range of movement should be absolutely normal. Range of movement means the flexion and extension should be absolutely normal. All right. Imagine if the patient is presenting with the fixed flexion deformity of the elbow, then you cannot fix it into 90 degree of flexion and you cannot bring it into extended position. So the moment you cannot bring it into flexion or extension with the required categorization, then in that case, you cannot do this three bony point relationship. All right. So this is how you are going to mark the correct answer for this particular question. And that was asked, a very basic question on three bony point relationship asked, and the answer for that question is supracondylar fracture of the humerus. So many times this question has been repeated, right? Okay. Next is Hawkins classification. Again, it is extremely surprising to us. You know, we used to teach this classification system. It is for the first time the question was asked, that Hawkins classification. We used to teach it, and by the time we used to teach it, you know, there is a thing that we used to say is that, you know, although we are talking about the name of the classification, we are asking you to learn the name of the classification, but we are not going deep into this classification system, because once the question is asked for the first time, imagine if the question is asked for the first time that what is the name of the classification for talar fracture, Hawkins classification, then subsequently we will start teaching the details of the Hawkins classification. And you know, today the question was asked. For the first time the question was asked that Hawkins classification is for, answer for that question is talar neck fracture. It is for the talar neck fracture. And now because the question become obvious that they have started asking about this Hawkins classification, then we have to talk about it. Before we talk anything related to this Hawkins classification, why the talar neck fractures are important? Why? Why the examiner has decided to give you the question out of talar neck fractures? Why? The reason is because of its complications. You know, every time you get a patient with a talar neck fracture, then the likely possibility of complications are too high. And the specific complications that we have to talk about are, the first one, secondary osteoarthritis. You know, if the talar neck is fractured, then the degenerative changes in the ankle joint are inevitable. It will happen. And you have to counsel the patient before performing surgery, before performing the management, that, you know, even if the bone unites successfully, even if the bone does not go into avascular necrosis, even then the patient would be having pain which might persist throughout life because of the degenerative changes in the ankle, which are inevitable, which are bound to happen. All right, so that is a complication. Another complication is osteonecrosis, body of the talus. You know, osteonecrosis body of the talus, why does it happen? Because of the non-union at the fracture site. So these are the three complications which you have to understand. And as I'm again repeating, that while teaching this topic, that is talar neck fractures, we used to teach about the name of the classification, although it is the time where the name of this classification has to go into a deep study, that what are the characterizations, what are the classification criteria. Now, why this fracture is more bound to go into non-union or osteonecrosis? Because the vascularity to the body of the talus is not direct. The vascularity to the body of the talus is primarily dependent on the vessels coming from the head and neck to the body of the talus. So imagine, if there is a fracture in this region, that is neck of the talus, then there is a likely possibility that there will be a cut in the vascular supply to the body of the talus, as a result of which it is more likely to go into osteonecrosis. So talar fractures, you know, for talar fractures, Hawkins is the very important word because of two reasons. One is Hawkins classification and the second is Hawkins sign. And what is Hawkins sign? That you tend to look for osteonecrosis, head of the femur, 6 to 8 weeks after the fracture, that whether it is happening or not, looking at the dome of the body of the talus on the x-rays. So Hawkins sign is also important. Now if we talk about this classification system, that, you know, Hawkins has divided the fractures into 4 different types. The type 1 is the talar neck fracture without any subluxation or dislocation around the ankle or the subtalar joint. So type 1 simple is, there is a fracture neck of talus with no dislocation. So this is the simplest type of the fracture, and you know, the possibility of the non-union or osteonecrosis head of the femur are less likely in these cases. Now the type 2 is going to be relatively more severe, because not only there is a fracture, but there is going to be a subluxation at the subtalar joint. So there is a fracture in the fracture neck of talus, and there will be a subtalar subluxation. Now it could be either subluxation or slight dislocation, right? So this is type 2 fracture, as it is very clearly evident in type 1. Now in type 1 there is only a fracture in the neck of the talus region, while in type 2 there is not only a fracture but slight amount of subluxation also at the subtalar joint. Now coming on to the type 3. Type 3 is the fracture along with subtalar as well as tibiotalar dislocation. That means there will be a dislocation of the tibiotalar as well as subtalar joint. That is type 3 injury to the ankle joint or to the neck of the talus, as it is very clearly evident over here in this case. Like, there is not only a fracture, there is a subtalar dislocation as well as tibiotalar dislocation. That is type 3. So obviously the moment you start from type 1 to type 2 to type 3, the moment you go towards type 3, there is worsening of the prognosis. All right, the outcomes are getting more and more complicated. The complications, the possibility of complications is getting higher. And finally, the type 4. The type 4 injuries are identified as not only the fracture, there will be subtalar as well as tibiotalar as well as the talonavicular dislocation or subluxation, talonavicular instability. So here what is happening in this case? There is a fracture, there is subtalar dislocation, there is tibiotalar dislocation, and there is a talonavicular subluxation too. So that is type 4. Hopefully everything is clear related to this particular question. That is, Hawkins classification is for fractured neck of talus, to be very specific. Point number 2, this is the detail of Hawkins classification. Point number 3, what are the important complications that every one of you should be knowing about? That secondary osteoarthritis, osteonecrosis body of the talus, and non-union. Now, because of osteonecrosis is a kind of a complication which will persist throughout life in a patient, it is very important to identify whether the bone is going into necrosis or not. In order to identify that, you are having a Hawkins sign. Now, Hawkins sign is basically the x-rays taken 6 to 8 weeks after injury to look for the sclerosis, or there is a radiolucency in the dome of the talus. If there is a radiolucency, that means no osteonecrosis. If there is a sclerosis, that means beginning of the osteonecrosis in the body of the talus. Alright, so as you can very clearly identify that the word Hawkins, as far as orthopedic question is concerned, is clearly a key word, alright, to the answers for the talus, because of the classification system and because of the sign. So this is what you have to remember for this question number 2. Now coming on to the question number 3, and again, as I'm saying, I used to say this, persistently we are pressing you so that you have to learn about this Trendelenburg thing, because now the examiners have started asking this question. The question was asked in 2014 JIPMER, and then there was a gap. No such question was asked for a long duration of time, and since last year, they have started again asking a question based on Trendelenburg test, because it is slightly or directly related to the examination of the hip joint, right? Now, first of all, before we jump into the Trendelenburg mechanism or the test, just try to understand it over here. If this is the head of the femur, this is neck of the femur, this is greater trochanter, lesser trochanter, and these are the two muscles which are at abductors, the primary abductors of the hip joint, having some assisted action of extension, flexion, as well as rotation of the hip joint. And these two interesting muscles are gluteus medius. They are gluteus medius and gluteus minimus, right? And both of them are supplied by superior gluteal nerve. They are supplied by superior gluteal nerve, as you already know about this. Now, there is a abductor mechanism of the hip joint that when you stand on one hip, imagine you are standing on this right hip of the patient. When you stand on one hip, then the force which is generated by these two muscles will be transmitted, and it will try to pull the other side of the pelvis up. You know, if you are standing on one side, then the weight bearing has to be shifted towards one side. The center of mass of your body has to be shifted towards that weight bearing side, on the side on which you are bearing the entire weight of the body, in order to attain the stability. Now, what is that mechanism which is pulling the body to get inclined towards the weight bearing side? That mechanism is abductor mechanism of the hip joint. And how the abductor mechanism works, that the gluteus medius, the gluteus minimus, they contract, they generate force which get transmitted and try to pull the other side of the pelvis towards the weight bearing side, right? So the body gets inclined towards the weight bearing side. Imagine if these two muscles are injured, or if there is a nerve injury which is supplying to these two muscles, then obviously what will happen, that when you try to bear weight on that affected limb, then the force is inadequately generated or not generated. When there is no force generated, then there will be a failure to lift the pelvis onto the weight bearing limb. As a result of which, the side which is hanging off the ground will be dropped down. All right, there will be drooping of the pelvis on the normal side. So this is exactly what the Trendelenburg test positive is. Now, if you go back to the question was asked that there are several structures which are mentioned in the options, and they have asked that multiple options could be correct. Some of the options are not contributory to this abductor mechanism of the hip joint. Now, if you look at the question, that while bearing weight on the right lower limb, now when the patient has started bearing weight on the right lower limb, the pelvis dropped down towards the left side. That means abductor mechanism of the right side is inefficient. Now, which of the following structures are likely to be affected? As you know, the superior gluteal nerve, yes, because it is responsible for supplying the gluteus medius and minimus, the generators of the force, which is responsible for lifting the other side of the pelvis towards the weight-bearing limb. Gluteus medius, yes, it is a component. Gluteus minimus, yes, it is also a component. And you know, gluteus maximus is not a component. It is the major extensor of the hip joint, which is supplied by inferior gluteal nerve. The sciatic nerve is not at all a component because it is responsible for supplying the muscles lower in the lower limb. So sciatic nerve is not a component. So multiple options correct means option number A, option number B, and option number C. So these are the three options which are correct in this particular situation. So wide bearing weight on the lower limb, the pelvis drop down towards the left side. That means right-sided abductor mechanism is at fault. And you know, last time the question was asked that which of the following nerve is likely to be affected: right-sided superior, left-sided superior, right-sided inferior, or left-sided inferior gluteal nerve palsy. So again, the same thing they are asking regularly about the Trendelenburg test, Trendelenburg gait, Trendelenburg components, the abductor mechanism, and next time they are going to ask about the contraindications. The next time they will be asking about the options, that in which of the following condition the Trendelenburg test is positive. So for that you just have to learn very thoroughly what exactly the Trendelenburg mechanism is, because it's not like that in one patient who is suffering from tuberculosis, for example, one patient can perform Trendelenburg where the Trendelenburg test could be identified as negative, and the other patient who is also suffering from the same disease, tuberculosis of the hip joint, Trendelenburg test could be positive. So there are multiple requisites which are required to be understood in order to identify and mark the answer related to the Trendelenburg test. So this was obviously a very obvious question with a very obvious answer. All right. Another very practical question, the Bankart lesion. You know, dislocation of the shoulder joint is a kind of the topic which they are asking again and again, and now this time they have asked a complication which is related to the shoulder joint dislocation. So what is that? A Bankart lesion. Now just try to understand. Imagine this is a bone, that is glenoid bone. Over to that there is a fibrocartilaginous structure which is known as glenoid labrum. So this is glenoid labrum. Now every time there is a trauma which is responsible for thrusting the head of the humerus to move out of this glenoid labrum. All right, when the head of the humerus is thrusted out of the glenoid labrum, then there is a likely possibility that it could lead to a stretched injury, it could lead to an impacted injury onto the antero-inferior part of the glenoid bone as well as to that of the labrum. So if you look at this glenoid bone over here, and which is corrected by this, covered by this fibrocartilaginous structure. So here, if there is a lesion over here in this region, antero-inferior part of the glenoid labrum, not only labrum, there could be a affection of the glenoid bone also. Like some region of the bone could be detached because of the acute traumatic event. So this is known as Bankart lesion. So it could be a complication of the shoulder dislocation, or it could be just impactful injury for the first time that is happening. So that is known as Bankart lesion. All right. It is considered to be a pathological identifying lesion for the dislocation, recurrent dislocation of the shoulder joint. So what is Bankart lesion? As you know, antero, once you have understood that every time the shoulder is getting dislocated anteriorly, so obviously the anterior part of the glenoid labrum would be affected, and inferior part. So it is the avulsion from the antero-inferior part of the glenoid labrum. So that is what the Bankart lesion is. Now if you look at the other option, you know, other options related to the dislocation of the shoulder joint are the Hill-Sachs lesions. What is Hill-Sachs lesion? This is another complication for recurrent dislocation of the shoulder. Now every time there is a shoulder which is dislocated anteriorly, the anterior rim of the glenoid will impact onto the posterior surface of the humerus, and this impact on the posterior surface of the humerus will create a depression. And if you want to be more specific that where on the posterior surface, then on the posterolateral surface, because the head of the humerus, it glides medially. So the posterolateral surface is exposed to the anterior rim of the glenoid. So that is all the what is Hill-Sachs lesion is. So if you look at the option number C, the depression on the posterolateral part of the head of the humerus, it is actually the Hill-Sachs lesion, which is a feature of recurrent anterior dislocation of the shoulder. On the other hand, the depression on the anteromedial part of the head of the humerus is a reverse hill sac lesion, which is a lesion of recurrent posterior dislocation of the head of the shoulder or head of the humerus, right? Or the shoulder joint. Because when it is getting dislocated posteriorly, the posterior rim of the glenoid will be having an impact onto the anterior surface of the head of the humerus, and that is specifically on the medial side. So there will be a depression on the anteromedial surface head of the humerus, which is known as recurrent which is a result of recurrent posterior dislocation of the shoulder and is known as reverse hill sac lesion. So hopefully everything is clear related to this, a very, very easily identified kind of a question that is known as Bankart lesion, right? So although we can say that the questions were not exactly a direct sort of a question, but nothing was not there in your, that you haven't read about, right? Everything you already know about it. Bankart lesion. All right. Hopefully this question is also clear. And finally, again, they are asking this question, foot drop they have asked. Name of the nerve which is likely to be injured with this particular case they have asked, right? The name of the splint which might be required in the management of this condition they have already asked. And you know, we have taught this with the hope that one day they will start asking about these gait abnormalities. That means how the patient walks with these weak muscles, with the paralyzed muscles. What are the compensatory mechanisms that the patient takes in order to walk forward, right? So they have started asking about the gait, and the name of the gait with this kind of an injury is going to be a result of a common peroneal nerve injury. Now just try to understand. The name of the fracture over here is the fracture in the proximal aspect of the fibula. So it is the proximal fibular fractures. Now as you know very, very, very clearly that you know this common peroneal nerve is lying in closed approximation in the proximal aspect of the fibula. So if there is a fracture in the head, fracture in the neck, fracture in the head-neck interface, that means anywhere in the proximal aspect of the fibula, then common peroneal nerve is likely to be injured. And you know, this common peroneal nerve is responsible for supplying, this common peroneal nerve is responsible for supplying one of the muscle, that is tibialis anterior. Tibialis anterior. And what is the major function of this tibialis anterior? It is responsible for causing dorsiflexion of the ankle. And you know, if there is a loss of dorsiflexion of the ankle, then the patient would be having a foot drop. So as a result of which, the outcome of this loss of dorsiflexion of the ankle, it will result in foot drop. Now, imagine how the patient with the foot drop will walk. Normally how you walk, you are having the ankle joint in extension, and this is how you walk. This is how you will perform a heel strike. After heel strike, there will be mid stance, then there will be heel off, and finally there will be toes off. So these are the phases of the stance phase of the gait cycle. Now imagine if the patient is having a foot drop, he won't be able to perform the heel strike. And once he is not able to perform this heel strike, the heel would be kept in plantar flexion. So he will walk by dragging the toes on the ground. Now in order to prevent this drag injury to the toes, he will take a higher step. In order to have a clearance of this foot, he will take a higher step in comparison to the normal because of the plantarly flexed foot. So this is what is known as high stepping gait, because he is taking a compensatory higher step to prevent the dragged injury or dragging injury to the dorsal surface of the toes. High stepping gait. So high stepping gait is because of the common peroneal nerve injury. So fibular fracture causes high stepping gait, right? As far as waddling gait is concerned, it is bilateral Trendelenburg gait. As far as extensor lurch is concerned, it is because of gluteus maximus abnormality. As far as broad base gait is concerned, it could be anything, right from the coxa vara up to the bow legs, right? So, or the, genu valgum. So many of the components, means these are the kind of the questions which the examiner will ask again and again now, because these are very practically seen on day-to-day basis in your OPDs. So fracture neck of fibula, it will cause a high stepping gait. You came to know the reason. Common peroneal nerve is likely to be injured, leading to the paralysis of tibialis anterior, loss of dorsiflexion. How the patient will walk? With a high stepping gait, in order to have a better clearance on the ground, because he won't be able to perform the heel strike of the stance phase in the gait cycle. So hopefully everything is clear. One more question was there, which was related to the anterior cruciate ligament injury on the MRI. The sagittal view was provided, but it is going to be better covered under the radiology section, where the, sir is going to teach you everything related to the aspect of identifying on different weighed images, right? So hopefully everything is clear. If we go back to the question, what new we might have learned in this particular session was that three bony point relationship is something that you already are aware of. Name of the classification is ever taught, but this time we are talking about the complications, we are talking about the detailed classification system, and we are talking about the this sign which is related to the prognosis of the talar fractures. Trendelenburg gait, Trendelenburg test is something which they are asking every year in regularly for the last 1 to 2 years. Then Bankart lesion, very obvious answer for this particular question. And then finally the fracture neck of fibula. It will cause a high stepping kind of the gait abnormality. Hopefully the session was helpful. Hopefully you have performed the paper well. All the best for your future examinations. Thank you very much for
ये कहाँ दिखेगा वो? अभी इसमें आ नहीं रहा है. Alright, hi guys, I hope the exam went well, and I got roughly around 22-23 question of pharmacology. So let's quickly discuss and see what all questions were asked and what are the possible answers according to these recall questions that we have got. At any point of time, if you feel that this question or this option was in a different form or different shape, feel free to give your feedback in the comment section. So one question that we are having is about a patient with history of dementia, or they were talking about Alzheimer's disease. Which of the following acetylcholinesterase inhibitor is used if patient is not able to tolerate the oral drug? So if you are not able to give oral drug, remember acetylcholinesterase inhibitor, I have told you that we are having GRD, that is known as your galantamine, rivastigmine and donepezil.
galantamine, rivastigmine, and donepezil. Undoubtedly, donepezil being the drug of choice, whenever students will see donepezil as an option, they tend to mark. But the question examiner has given here, not able to tolerate. So rivastigmine के बारे में मैंने बताया था, it's available as a transdermal patch also. So why not give a agent that is available by the transdermal patch rather than waiting for the oral drug. Oral तो वैसे भी ये tolerate नहीं कर पा रहा है, so it's better to give a transdermal patch, right? So I hope कि all of you guys have got this one. Rivastigmine is going to be the correct answer for this one, right? Next one. About a 26-year-old patient with a history of Mycobacterium tuberculosis was started on anti-tubercular agent. 6 months later, the patient presented with symptoms like neck swelling. Okay, so neck swelling, increased TSH level, that is actually a characteristic feature of your hypothyroidism. In simple word, अगर examiner चाहता तो पूछता which of the following anti-tubercular causing hypothyroidism. तो दो ड्रग के बारे में मैं मेंशन करता हूँ इन द क्लास दैट इज एक्चुअली एसोसिएटेड विद द हाइपोथायरॉयडिज्म. दे आर एसोसिएटेड विथ योर इन द एंटी ट्यूबरकुलर ड्रग बाय द नेम ऑफ इथियोनामाइड and another agent is para-aminosalicylic acid. The first ever anti-tubercular drug is para-aminosalicylic acid. वो भी कर सकता है ethionamide. Among the given choices, guys, ethionamide is the correct answer. Cycloserine, if you see, cycloserine, many of you have marked cycloserine, cycserine. मैं कैसे लिखता हूँ क्लास में इसको, जानबूझ के मैं इसको लिखता हूँ cycserine, जो आपको साइकेट्रिक बना दे. ये ऐसा है सेरिन, साइक्सेरिन. पायराजिनामाइड, प्यारजिनामाइड, एंड प्यार से रिलेटेड आई हैव टोल्ड यू 5-6 पॉइंट दैट प्यार का डोज इज ऑलवेज हाईएस्ट. सो अमंग द फर्स्ट लाइन ड्रग द डोज इज हाईएस्ट. सेकेंड थिंग they used to tell you that pyar should be avoided during pregnancy में इसको avoid करना है according to FDA. Third thing they used to tell you that pyar is very very toxic in life, most hepatotoxic agent. pyar दर्द भी देगा, that is another thing that I used to tell you, that means they are going to increase the uric acid level, can precipitate gout, है ना. And apart from that, I also used to tell you that pyar Priyanka से करना है तो PNCA gene will be causing resistance of the pyrazinamide. Rifampicin, red orange urine discoloration, hepatotoxicity are the important side effect. Flu-like symptom again on the intermittent dosing can be seen. Among the given choices, ethionamide is the correct answer for this question. Next one. A patient was started on doxorubicin, cardiotoxicity can be seen. So doxorubicin, daunorubicin, in fact जितने भी एंथ्रासाइक्लिन वाले ग्रुप हैं, they all can cause cardiotoxicity, है ना. एंड उसको प्रिवेंट करने के लिए वी आर गोइंग टू यूज एन आयरन चीलेटर एजेंट, एंड द आयरन चीलेटर दैट वी आर गोइंग टू यूज इज नोन एज डेक्सराजॉक्सेन. अगर आपको याद होगा तो कीमोमैन वी यूज टू डिस्कस इन द क्लास, एंड इन दैट कीमोमैन आई यूज टू टेल यू दैट देर आर डिफरेंट टाइप ऑफ ड्रग दैट इज कॉजिंग टॉक्सिसिटी. डॉक्सोरुबिसिन, daunorubicin will be causing cardiotoxicity, and to prevent the cardiotoxic event we are going to add dexrazoxane. So you can easily see dexrazoxane is the correct answer. So this one question is directly taken from this chemoman. In the previous examination of 2022, they have asked bleomycin or busulfan mediated pulmonary fibrosis, which drug is used to prevent. तो परफेनिडोन was the answer for that one, right? अगर आगे क्वेश्चन ये पूछ ले साइक्लोफॉस्फेमाइड, आइफॉस्फेमाइड, दे विल बी कॉजिंग हेमोरेजिक सिस्टाइटिस, राइट, और हेमोरेजिक मायोकार्डियल नेक्रोसिस. इन दैट केस सिनेरियो आईवी मेसना विल बी यूटिलाइज फॉर हेमोरेजिक सिस्टाइटिस प्रिवेंशन के लिए. आईवी मेसना वी आर गोइंग टू यूटिलाइज, राइट. ल्यूकोवोरिन, फोलिनिक एसिड विल बी यूटिलाइज फॉर रिड्यूसिंग द टॉक्सिसिटी ऑफ methotrexate. I hope all of you guys have got this one, but this question was very very easy. Let's look at the other option here. Aprepitant, rolapitant, netopitant, what are they? They are the neurokinin or substance P antagonist, right? They are given for delayed nausea and vomiting. Amifostine, they are nephroprotective agent. They are also radiosensitizing agent. They are used to prevent the nephrotoxic event by your cisplatin. Leucovorin, as I told you, also known as folinic acid, is going to prevent the toxicity of methotrexate. I hope all of you guys are getting this one. Please feel free to mark or please feel free to comment at any point of time if you feel वो क्वेश्चन का लैंग्वेज अलग था, बिकॉज ये सारे के सारे रिकॉल बेस हैं. और एक बात मैं आपको और बता दे रहा हूँ कि मतलब जब से आपका एग्जाम खत्म हुआ, वी आर कंटिन्यूसली इन टच विद द स्टूडेंट, एंड दिस इज द बेस्ट फॉर्म ऑफ क्वेश्चन दैट आई कुड कम अप विथ फॉर ऑल ऑफ यू गाइस. ओके, चलते हैं अगले क्वेश्चन के बारे में. सो दिस इज वन कीमोमैन, इज ऑलवेज ऑल टाइम फेवरेट एंड ऑलवेज वेरी इंपॉर्टेंट. अ पेशेंट इज ऑन मूड स्टेबलाइजर, नाउ प्रेजेंटिंग विद द रेड हेपेटिक एंजाइम्स एंड हाइपरअमोनीमिया. कभी भी मोस्ट हेपेटोटॉक्सिक, एंटी एपिलेप्टिक और मूड स्टेबलाइजर की बात करेंगे तो इट्स ऑलवेज गोइंग टू बी योर सोडियम वैल्प्रोएट. सोडियम वैल्प्रोएट अनडाउटेडली इट्स वन ऑफ द एंटी एपिलेप्टिक ड्रग. Do you guys know in a patient with a rapid cycler it is also considered as a drug of choice? So जो bipolar disorder वाले patient होते हैं, in that rapid cycler phase, if the episode is more than 4 in 1 year, we call them rapid cycler. उसमें भी drug of choice है and it's highly hepatotoxic. So anti-epileptic drug causing hyperammonemia or CNS like symptom because of the increased liver enzyme, है ना, definitely it's going to be your sodium valproate. Next question, in a female with a history of bleeding manifestation, okay, so there is a bleeding manifestation, petechial rashes, heavy menstrual bleeding and easy bruising. This was the language that many students have said. Now if you guys feel that ये इसका language थोड़ा अलग था या इसका language should be different, then please feel free. I am just checking your comments here also. And feel free to reply in the comment section. There is a live chat option that you guys can actually utilize to give your feedbacks here. Which of the following tyrosine kinase inhibitor? So actually the possible diagnosis here where the examiner is asking ITP. I am not pretty sure whether ITP was directly given in the option, but अगर ये clinical manifestation के बाद पूछ रहा है कि कौन सा tyrosine kinase inhibitor यूज करेंगे, तो we are going to use fostamatinib. Fostamatinib is the one that we are going to use. Bosutinib, guys, it's a second generation tyrosine kinase inhibitor that can be utilized in a patient with the CML. ठीक है. Isolated thrombocytopenia, again अगर thrombocytopenia दिया हुआ तो again it is again going to be idiopathic thrombocytopenic purpura. Isolated thrombocytopenia, ठीक है. Fostamatinib, right, we have discussed in hematology chapter. अगर आप देखोगे तो जहाँ पे मैंने hematology का last blood forming drugs बताया वहाँ पे मैंने इसको डिस्कस किया. Fostamatinib can be utilized. Now what is romiplastim? It is one of the romiplastim. It is one of the platelet stimulant. रोमिप्लास्टिम इज द प्लेटलेट स्टिमुलेंट. तो कीमो इंड्यूस अगर थ्रोम्बोसाइटोपेनिया तो उसमें यूज करेंगे. एग्जामिनर ये पूछा है विच टायरोसिन काइनेज इनहिबिटर. देखिए जितने भी टायरोसिन काइनेज इनहिबिटर होते हैं उनके नाम में देयर विल बी निब. So as soon as you know this information, two options are already ruled out. Oprelvectin, it's one of the interleukin 11 agonist. We can also utilize this one, romiplastin or oprelvectin, to increase the level of platelets, but they are not tyrosine kinase inhibitor, right? Interleukin 11 agonist, and romiplastin, they are the thrombopoietin receptor agonist. Thrombopoietin agonist. All right. So correct answer for this one is going to be fostamatinib. Which of the following anti-diabetic agent is approved for the heart failure patient with reduced ejection fraction? Now, was this question in the same language or there was some different language? Feel free to give in the comment section, guys, all of you guys, Dr. Tikhi Puri, Medicos, Anugya Rima and all the other students, है ना, feel free to reply. Because अगर ये question है कि anti-diabetic agent and option में liraglutide है, D-glutec है, D-glutec actually is a insulin. इट इज़ द लॉन्गेस्ट एक्टिंग इंसुलिन. मैं कैसे बताता हूँ, देर तक चलने वाला इंसुलिन, देर तक चलने वाला इंसुलिन D-glutec है, लॉन्गेस्ट एक्टिंग, कैन लास्ट फॉर अप टू 42 आवर्स. तो अगर कोई पेशेंट आपके पास आता है जिसमें आपको लंबे समय के लिए इंसुलिन का लेवल को मेंटेन करके रखना है, प्लेटू मेंटेन करके रखना है, तो वी कैन यूटिलाइज दिस वन. Canagliflozin, dapagliflozin, was it there? Canagliflozin, dapagliflozin, इट इज़ वन ऑफ द SGLT2 इनहिबिटर. एक और SGLT2 इनहिबिटर है जिसका नाम होता है एम्पाग्लिफ्लोजिन. गाइस रिमेंबर, एम्पाग्लिफ्लोजिन इज वन ऑफ द एजेंट दैट हैज़ बीन ऑल्सो अप्रूव्ड फॉर कंजेस्टिव हार्ट फेलियर पेशेंट. ये CHF पेशेंट में ये भी अप्रूव हुए हैं, ठीक है. लेकिन क्या ये ऑप्शन में था, ये ऑप्शन में था कि नहीं था? और डॉक्टर तीखापुरी, लीराग्लिप्टिन नहीं होगा, अगर होगा तो लीनाग्लिप्टिन होगा. लीराग्लिप्टिन कोई ड्रग नहीं होता है. और पायोग्लिटाजोन, रोजिग्लिटाजोन, अगर रोजिग्लिटाजोन था तो अगेन दैट इज नॉट अप्रूव्ड फॉर द हार्ट फेलियर पेशेंट. वाज लीराग्लुटाइड इज देयर इन ऑप्शन और नॉट? लीराग्लुटाइड, जस्ट गिव मी टू ऑप्शन. अगर लीनाग्लिप्टिन था तो लीनाग्लिप्टिन विल नॉट बी प्रिफर्ड फॉर हार्ट फेलियर पेशेंट. लीराग्लुटाइड है तो मैं आपको इन्फॉर्मेशन दे रहा हूँ, आप खुद डिसाइड कर लेना. अगर एंटी डायबिटिक ड्रग की बात करता है, एंटी डायबिटिक एजेंट फॉर हार्ट फेलियर, दो ड्रग का नाम सबसे ऊपर आता है. एक का नाम आता है लीराग्लुटाइड, GLP-1 एनालॉग लीराग्लुटाइड, और दूसरे का नाम सेकंड नंबर पे आता है एम्पाग्लिफ्लोजिन. अगर इन दोनों में से जो था, दोनों ऑप्शन में तो हो नहीं सकते, दोनों में से कोई एक होगा. अगर लीनाग्लिप्टिन था तो भी ऑप्शन आंसर नहीं होगा. ऑन द टॉप आई हैव रिटन एंटी डायबिटिक एजेंट दैट इज अप्रूव्ड फॉर द हार्ट फेलियर, लीराग्लुटाइड, एम्पाग्लिफ्लोजिन. दोनों नहीं होगा, दोनों में से कोई एक होगा, और जो भी होगा वो करेक्ट आंसर होगा. नाउ सम ऑफ यू आर टेलिंग मी हियर दैट एम्पाग्लिफ्लोजिन वाज देयर इन द ऑप्शन, सो दैट इज गोइंग टू बी द करेक्ट आंसर ऑल्सो. अब जितने बच्चे इसको रीनल फेलियर वाले से कंफ्यूज हुए हैं उनको मैं बता दे रहा हूँ, उनके साथ इशू ये हुआ है बिकॉज PYQ में एक क्वेश्चन आया था कि विच ऑफ द फॉलोइंग DPP-4 इनहिबिटर that is going to be safe in renal failure. DPP-4 inhibitor safe in renal failure. देखिए उस कंडीशन में योर आंसर विल बी नन अदर देन योर लीनाग्लिप्टिन, उस कंडीशन में योर आंसर विल बी नन अदर देन लीनाग्लिप्टिन। सो यहाँ पे तो सेफ इन रीनल फेलियर सिर्फ डायबिटीज के लिए नहीं पूछ रहा है ना, यहाँ पे हिस्ट्री डायबिटीज के लिए था या क्वेश्चन पूछा हुआ था कि हार्ट फेलियर में यूज करेंगे। वॉज इट फॉर हार्ट फेलियर, वॉज देयर हिस्ट्री ऑफ हार्ट फेलियर? अगर हार्ट फेलियर है तो उसका आंसर नन अदर देन एम्पाग्लिफ्लोजिन होगा। आई होप इट इज मेकिंग सेंस टू ऑल ऑफ यू गाइस। लीराग्लूटाइड, जैसे कि सारे बच्चे बोल रहे हैं सर लीराग्लूटाइड नहीं था, देन आई एम कंसिडरिंग लीराग्लूटाइड नहीं था तो डेफिनेटली लीनाग्लिप्टिन होगा। लीनाग्लिप्टिन इज गोइंग टू बी द नेक्स्ट बेस्ट। मैं लिख दे रहा हूं यहां पे लीनाग्लिप्टिन अगर था तो ये आंसर नहीं होगा। अगर हार्ट फेलियर के लिए भी पूछ रहा है, हार्ट फेलियर के लिए कौन सा यूज करेंगे विद रिड्यूस्ड इजेक्शन फ्रैक्शन, प्लीज गिव मी ए क्विक कंफर्मेशन, क्या रिड्यूस इजेक्शन फ्रैक्शन था या नहीं था? बस इतनी सी बात है। अगर इतनी सी बात है और एम्पाग्लिफ्लोजिन ऑप्शन में है तो ये करेक्ट आंसर होगा, इसका कोई अल्टरनेटिव नहीं है। हार्ट फेलियर विद रिड्यूस इजेक्शन फ्रैक्शन विद रीनल फेलियर, एम्पाग्लिफ्लोजिन विल बी द प्रिफर्ड वन। ठीक है। एंटी डायबिटिक ड्रग फॉर हार्ट फेलियर में दो ड्रग का नाम हमेशा ऊपर आता है, लीराग्लूटाइड, एम्पाग्लिफ्लोजिन। जो बच्चे कंफ्यूज हुए हैं वो उसमें DPP-4 इनहिबिटर, CFR इन रीनल फेलियर, उस कंडीशन में लीनाग्लिप्टिन इज द करेक्ट वन, लेकिन हार्ट फेलियर में वो उसका अप्रूवल नहीं है। आई होप इट इज मेकिंग सेंस टू ऑल ऑफ यू गाइस। Sorry if it is getting wrong, but this is the best way to get this one. Okay, next one. Which of the following is not seen with TCA toxicity? TCA, amitriptyline, imipramine, trimipramine, है ना? TCA toxicity में confusion होगा। They are having anticholinergic effect, because of that there will be blurring of vision भी होगा, तो pupillary dilatation can lead to blurring of vision. They are also having alpha-1 blocking property, because of that there can be arrhythmia as well, but hypothermia तो reported नहीं है ना, hypothermia reported नहीं है। Next upcoming examination में they can ask you what could be the possible antidote, तो इसका कोई antidote तो available नहीं है। Then since this is going to cause metabolic acidosis, it will be associated with the metabolic acidosis, we are going to cause फोर्स्ड अल्कलाइन डायूरेसिस। अगर आपको याद होगा तो 2022 का ये क्वेश्चन था, है ना, कि फोर्स्ड अल्कलाइन डायूरेसिस विल बी डन इन विच ऑफ द फॉलोइंग। सो क्वेश्चन टॉपिक ऑलमोस्ट सेम है, बस थोड़ा सा लैंग्वेज को चेंज कर दिया। तो फोर्स्ड अल्कलाइन डायूरेसिस यूजिंग सोडा बाइकार्ब विल बी द करेक्ट आंसर फॉर दिस वन। हाइपोथर्मिया विल नॉट बी वन ऑफ द सिम्टम हियर। नेक्स्ट वन, which of the following protease inhibitor can maximally produce hepatotoxicity? Was there a question something like this, that जितने भी protease inhibitor होते हैं they are all ending with the navir? Please give a quick confirmation, was this question there or not? Protease inhibitor ending with the navir, और जितने भी नावीर होते हैं, मैं आपको एक सिंपल सा स्टोरी भी सुनाया था कि जब भी GI पे HCl आता है, GI यूजुअली ब्लीड करता है, GI bleeds with HCl. GI related side effect is the most common side effect where the patient will have nausea, vomiting, diarrhea. Bleed मतलब there is gonna be bleeding risk. Bleeding risk that is going to be maximally with your tipranavir and ritonavir in the same order. Tipronavir and ritonavir in the same option. ठीक है। Was there a history of headache also and confusion, some symptomatic कुछ CNS effect थे क्या patient को in this one? Even if the option is having let's say lopinavir, ठीक है, क्या ये ऑप्शन सही है? टिप्रानावीर, सेक्विनावीर, अटाजानावीर, नेल्फिनावीर, लोपिन चार ही होंगे कोई भी? Ritonavir was there. Hepatotoxicity. Yes, I'll be using English. Sorry, vision mission. Yes, I will be. Hepatotoxicity, cardiac conduction abnormality is going to be the another side effect. Cardiac conduction abnormality. This is going to be maximally seen with your sequinavir. And they can even lead to lipodystrophy syndrome. Lipodystrophy syndrome, metabolic derangement, these are going to be the important side effect. Okay, so some of the students are saying ki sir there was ritonavir also. All right, ritonavir is the most potent enzyme inhibitor that we have. And was there tipranavir, ritonavir both? Was there tipranavir, ritonavir both? If ritonavir was there in the option, I hope all of you guys have got with ritonavir. If ritonavir was there in option, please go ahead with the ritonavir. If it was there, then ritonavir, it's the one that is having maximum enzyme inhibiting property. Also, it is having maximum risk of hepatotoxicity as well. Ritonavir ke saath please proceed with ritonavir. Next one. Now look at this question very carefully. This question was discussed with many students here. There is a patient who is on multi-drug resistant TB therapy. He is presenting with multiple joint pain. So multiple joint pain, I just gave you a story of pyrazinamide, and I told you PAR is very toxic. Most hepatotoxic is pyrazinamide. Then I told you PAR dard bhi dega, PAR will give you pain as well, so they can precipitate gout. So that is exactly what has happened. Most hepatotoxic and pain inducing is going to be your pyrazinamide, pyrazinamide, and they have also altered liver enzyme, but the liver enzyme is not altered that much. Liver enzyme is not altered that much, increased hai. Let's say if the liver enzyme is considered up to 35, 38 normal, there is slight increment for up to 55, है ना? Up to 33, 34 या up to 35 it is considered normal. ठीक है? Next line of management. Now in a country like India, where the most important problem is going to be TB, look at the other option. Stop all and monitor uric acid and start the level once the level become normal. See, in any mycobacterium treatment, be it leprosy or be it TB, stopping the therapy is not advised initially. Whenever we are trying to give multi-drug resistant therapy, or whenever we are trying to use any TB therapy, always and always remember that stopping the drug is not the option. We always ask to follow up. Kabhi bhi, whenever there is any problem, ask the patient to follow up. Stop only pyrazinamide and monitor uric acid and AST, ALT. Stop all hepatotoxic and monitor liver enzyme. Continue all and add uric acid lowering drug. Do you guys think that option was there? These options were there, the option that I have used here. The option, do you think these options are correct in the same order, or there were some language changes? The question says here next line of management. I hope it was same, next line of management. In the given scenario, when the examiner is asking what will be the possibly next line of management. Now, if you are going to look for the international guideline, and according to Goodman-Gilman, whenever they are saying, let's read what Goodman-Gilman has to say. Let's read what Goodman-Gilman has to say. This is the screenshot for from the Goodman-Gilman. They are telling something very important. Along with me, please rewind. Prior to pyrazinamide administration, all patients should undergo hepatic function LFT test. Next line it's saying, if there is evidence of significant hepatic damage, therapy must be stopped. Therapy must be stopped. This is according to the international guideline, and this is also according to our Goodman-Gilman. Pyrazinamide should be avoided in individual with if there is alteration in hepatic baseline enzyme. Let's say your patient is coming today and you are going to start anti-tubercular drug, and you found out that okay, the hepatic enzyme is already altered from the baseline. In that case scenario, you will not be starting. But they have not mentioned anything like this. They are telling ki you have already started the therapy, and after starting the therapy, now there is a precipitation of the gout. The main problem here is the precipitation of the gout here. Pyrazinamide should be avoided in individual with baseline hepatic dysfunction. If pyrazinamide cannot be used at any point of time, if you cannot use it, short course of rifampicin, isoniazid and ethambutol can still be successfully used, but here the duration can be prolonged from 6 months to 9 months. If it is first line drug, you can increase the duration from 6 months to 9 months. Okay. Next line it's saying, in almost all the patient, in almost or nearly all patient, pyrazinamide exhibit excretion of urate inhibits excretion of the urate resulting in hyperuricemia, which may cause precipitation of the gout. What is the main problem here for your patient? The main problem for your patient here is the precipitation of the gout, and in that case scenario it is always advised usually to add a urate lowering drug and continue the same. In a country like ours, in a country like India, we do not ask the patient to stop a drug, so continue all and add uric acid lowering drug if that is the option that is given here. Because again, if there is a concerning level of, or if the level is very much high, let's say the level is going 500 or 800 or 1000, in that case scenario we are bound to stop. But ALT AST is just slightly high, so we are going to continue the drug that we have, and after continuing the drug we are going to add the uric acid lowering drug. I hope it is making sense to all of you guys. Next one. A 55-year-old male patient with history of hypertension and occasional spikes of blood glucose. Which of the following is the most preferred agent? Was there a question something like this, guys, that there is a patient of hypertension coming to you, age is 55. So according to the NICE guideline, whenever we try to start the anti-hypertensive drug, we look for the age, right? And whenever the age is less than 55 or more than 55, more than or equal to 55, right? If the age is less than 55, we start A or A. A or A means either ACE inhibitor or ARB. This is what we are going to start, A or A, either ACE inhibitor or ARB. If the level is more than 55, then age is more than 55, then we are going to start C or D. C or D. What is C? C is calcium channel blocker, D for diuretics, right? So in this case scenario where the patient is coming to you with the 55 year and there is a history of hypertension and you have to start one drug, you have to start one drug. So first line drug हमेशा start करेंगे ना usually. What is the first line drug that we have? The first line agent that we are having, C or D. C is the calcium channel blocker. C is calcium channel blocker. D is diuretic. Diuretic preferably thiazide. These are the first line drug. So exercise plus amlodipine is something that you can start actually. Exercise plus calcium channel blocker. ठीक है? Was there an option something like this? या option थोड़ा ऊपर नीचे था? ऑप्शन ठीक है इन द क्वेश्चन लाइक दिस. अगर ऑप्शन में कुछ चेंजेस हैं, इफ यू फील द ऑप्शंस आर समथिंग एल्स, प्लीज फील फ्री टू मैसेज. आई विल टेक अप ऑल द क्वेरीज. लेट्स टेक द नेक्स्ट वन. दिस इज वन ऑफ द PYQ. पुराना क्वेश्चन से उठाया हुआ क्वेश्चन है ये. ऑल ऑफ द फॉलोइंग आर साइड इफेक्ट. ऑल ऑफ द फॉलोइंग साइड इफेक्ट आर मोर कॉमन विथ कार्बामाजेपिन देन ऑक्सकार्बाजेपिन एक्सेप्ट. ठीक है. All of the following side effects are more common with carbamazepine than oxcarbazepine except dilutional hyponatremia. Do remember dilutional hyponatremia that we have. Dilutional hyponatremia is going to be more common with oxcarbazepine, right? More common with oxcarbazepine. Jayaprakash is asking why not C. डॉक्टर मैंने जैसे कि बताया ना कि जब भी whenever you are going to start anti hypertensive drug, we start according to guideline. So if the age is less than 55 or more than 55, that is our cutoff for according to NICE guidelines. So we are going to start either ACE inhibitor, ARB. If the age is more than or equal to 55, we are going to start either calcium channel blocker or diuretics. So metoprolol is one of the beta blocker, and beta blocker is among the second line anti-hypertensive drug. Is among the second line. So if you have to start one, I would say start with amlodipine. If this is the exact question of the examiner. ठीक है. Now let me just give you what Goodman-Gilman has to say here. Goodman-Gilman very clearly says that although most adverse effects are similar to those of the carbamazepine, oxcarbazepine, although most side effect of oxcarbazepine is pretty similar to carbamazepine, hyponatremia that we have may occur more commonly with oxcarbazepine. And other side effect, dilutional hyponatremia is more common. Other side effect is lesser. जो oxcarbazepine है, it is having lesser, let's say, bone marrow suppression, and it's having lesser CNS effect, है ना. Apart from that, lesser risk of rashes, hypersensitivity reaction, but oxcarbazepine has more risk of dilutional hyponatremia, and they are more common in elderly population. They are more common in elderly patient. So this is one of the direct question. Option is only hyponatremia. Agar hyponatremia, then it's still same. If dilutional was not there, then there is nothing to nothing to worry. Hyponatremia again going to be more common with the oxcarbazepine. right? So D is the correct answer. Hyponatremia, the word is hyponatremia is more common with the oxcarbazepine. This hyponatremia is because of the ADH only, so isliye I use the term dilutional hyponatremia. Okay, so Dr. Harish, you are absolutely correct. Next one. A 60-year-old farmer presented with the fever, body ache and cough. So there were some non-specific symptom. Upon examination, there was a black spot on the chest as shown in the image. The image is not here, I think due to some PowerPoint setting the image is removed from here, but even if there is no image, look at the line of the question. There is a positive evidence of IgM for scrub typhus. Positive evidence of IgM. तो already diagnosis हो गया ना, there is already diagnosis that there is diagnosis already scrub typhus. So in that case scenario, the best drug अगर आप देखने चाहते हैं और the drug of choice if you are going to see, then we are having doxycycline, right? Preferred treatment. Now if you have to choose between doxycycline alone or doxy plus azithro, remember there are a certain group of people who are actually resistant to doxy. In that case scenario, you cannot just rely in this patient and you just give doxy alone. I would strongly recommend that go ahead with the doxy and azithromycin combination. Okay, doxy and azithromycin combination is the best. Now look at the language of the question. Does it say best treatment modality, preferred treatment modality या सिंगल बेस्ट ड्रग ऑफ चॉइस पूछा था? आजकल के टाइम पे इन टूडेज टाइम दे आर नॉट यूजिंग द टर्म ड्रग ऑफ चॉइस बिकॉज अगेन ड्रग ऑफ चॉइस इज कीप ऑन चेंजिंग. नाउ द मोस्ट better term is P drug. P drug is preferred drug, and on the term of P drug already there was a question in the previous NEET PG examination and FMG examination as well. In this scenario, if there is a question like this, I would strongly say I would be going ahead with the doxy with azithromycin. There are a group of people, those who are resistant to doxy, so we cannot just give doxy and rely alone. If both are given, preferred is always going to be a combination of both. Okay? Preferred is always going to be a combination of doxy plus azithromycin. Definitely, if it is INI-CET, it is supposed to be tricky and it cannot be just easy. 1 to 2 question definitely are very easy, जैसे कि that oxcarbazepine वाला question. Next one. Ceftriaxone is not effective, doctor. If IV ceftriaxone is given, ceftriaxone is not for scrub typhus, a cell wall inhibitor, it's not effective for your scrub typhus. Scrub typhus के लिए single drug if you are going to choose, single drug it's going to be doxycycline. But if you have to choose doxy alone and doxy plus azithro both, I would be saying that according to the recent treatment guidelines also and the clinicians also, they are preferring more doxy plus azithro का combination because of the different pattern of resistance. A 28-year-old male presented with altered sensorium and pinpoint pupil. So pinpoint pupil, I always used to say that remember pinpoint pupil will be seen in POMP. So pinpoint pupil can be seen in pontine hemorrhages. It can also be seen in organophosphate poisoning, carbamate poisoning, carbamate poisoning, morphine poisoning. Sometimes they use the term opioid, again opioid, morphine is opioid only. Also in the phenol poisoning. So this is a very direct question, guys. You can consider this as a forensic question, consider this as a pharma question, it's hardly matter, and I'm pretty sure all of you guys have marked morphine here. Cocaine, it is a SERT inhibitor, NET inhibitor, NET, norepinephrine reuptake inhibitor. So it is going to increase the level of norepinephrine. So there will be mydriasis. Amphetamine is also sympathomimetic. Likewise, dhatura will be causing your mydriasis also. So among the given choices, opioid, opioid ka nasha, definitely morphine will be causing pinpoint pupil. Next one. Okay, now this was a little tricky one and it took some time for me to formulate this question, and thank you very much for all the students for staying in consistent touch and completing all this question. All thanks to all the students, those who are listening to me, watching me, or even those who are going to watch me later on the recorded session, that you guys have been consistent and have been patiently replying to all the queries that I have been raising here. So site of action of valproate, was there a question something like this, boys and girls? Was there a question something like this, site of action of valproate? A, B, C, D. So there are 4 sites here. A here is given only at the GABA transaminase. B here is given SSA dehydrogenase and GABA transaminase both. C here is possibly GABA reuptake inhibitor, and D here directly at the GABA a receptor. If there was a question something like this, and they are asking what is the site of action of valproate. See, valproate directly, it's one of the voltage gated sodium channel blocker. Okay? It's a voltage gated sodium channel blocker. In addition to that, it is also having GABAergic property, so they can increase the GABA level as well. The GABA level increment by valproate is by two important mechanisms. The correct answer here is this one, B. Let us see what Goodman-Gilman has to say about this one, right? That how valproate can increase the GABA. Here there is a quick screenshot from Goodman-Gilman that valproate can stimulate the activity of GABA enzyme, right? Valproate can stimulate the activity of GABA synthetic enzyme, glutamic acid decarboxylase, and inhibit GABA degradative enzyme. They are going to inhibit the degradative enzyme of the GABA by the name of GABA transaminase and SSA, that is succinic semialdehyde dehydrogenase. So they are increasing the level of GABA by two important mechanisms, and one is GABA transaminase inhibition, definitely a specific drug that is GABA transaminase inhibition, right, is known as vigabatrin. Vigabatrin पे भी question आ चुका है 2020 एम्स में. Vigabatrin, it's one of the GABA transaminase inhibitor, but valproate can also increase GABA by two important mechanisms. One is GABA transaminase and also SSA inhibition. SSA मतलब your succinic semialdehyde dehydrogenase. SSA is succinic semialdehyde dehydrogenase. I hope all of you guys have got this one. And here the arrow, look at the arrow how they have given. A only targeting at GABA transaminase, B targeting succinic SSA dehydrogenase and GABA transaminase B, C is inhibiting the reuptake, D is directly acting at the receptor. I would say go ahead with the B. B का जो है, right, B का site is the most appropriate, that they are inhibiting SSA dehydrogenase, succinic dehydrogenase and GABA transaminase. Yep. Yes, Dr. Metroid, definitely you are absolutely right. Okay, next one. A child was brought with history of iron tablet intake. Treatment of with desferoxamine is started. So iron poisoning is all time favorite, है ना? So they are always asking. Previously they asked that oral क्या देंगे? So oral antidote is known as deferriprone and deferasirox. Last time they asked. Topic is again going to be same, guys. Deferasirox. This time they didn't ask. They asked at which iron level will be starting the treatment. So we are going to start the treatment in level beyond more than 500. Treatment of deferoxamine is started at this level. More than 500 pe we will be immediately starting the treatment. So this was a direct forward, not direct question, number based question. Next one, diabetic neuropathy and spinal cord injury. So if there is a neuropathy, guys, pregabalin, gabapentin. Pregabalin, gabapentin, it is one of the N-type calcium channel inhibitor. Pregabalin, gabapentin, N-type calcium channel blocker. They are considered the drug of choice in all the neuropathic pain. They are the drug of choice in neuropathic pain. It can be post-herpetic neuralgia. Post-herpetic neuralgia. It can also be diabetic neuropathy. In any type of neuropathic pain we can utilize, including sciatica. Remember, it's also preferred in a patient with the restless leg syndrome. RLS matlab restless leg syndrome में भी also we can utilize. It's also a drug that can be utilized for the prophylaxis of migraine. Since I discussed this in epilepsy chapter, we remember it can also be utilized in focal seizure as an add-on drug. Focal seizure or partial seizure maybe also we can utilize them. So correct answer for this question is going to be your pregabalin. Do you guys remember the other option here? Do you guys remember other option here? Sumaya Fatima, deferriprone, deferasirox, you are going to use orally. They are the orally effective iron chelators. So whenever there is a patient with a history of thalassemia with the recurrent blood transfusion, look at the term, patient with thalassemia history, recurrent blood transfusion, in that case scenario, we will be continuously adding deferriprone, deferasirox so that we can prevent the iron overload. Emergency scenario mein we are always going to use deferoxamine. Okay. If you guys remember other option here, dark night, was there carbamazepine option here? Post herpetic neuralgia यहाँ लिख दिया मैंने. If carbamazepine was option there, carbamazepine can be utilized, but again preferred is drug of choice is always going to be pregabalin or gabapentin. Next one, let's see. Which of the following pathogen is not sensitive to the shown drug? So they have given different pathogens here like Aspergillus niger, Candida krusei, Candida glabrata and itraconazole. This is a question also directly taken from Goodman-Gilman, and this is a PYQ also. It's one of the PYQ also, it's a previously asked question as well. Do remember that. Amitriptyline was given in the options. Amitriptyline definitely can be used in neuropathic pain, but if you have to prefer one, I would say go ahead with the pregabalin. If amitriptyline was given, still pregabalin will be the correct answer. Neuropathic pain mein we can use amitriptyline, है ना, but we are going to use the most preferred, that is pregabalin. Okay. Alright, so as I was telling to all of you guys, aspergillosis mein the drug of choice is voriconazole. Voriconazole is the drug of choice. Drug of choice for candidiasis, guys. Drug of choice for candidiasis is going to be fluconazole, but two different species of candida is known as Candida krusei and glabrata. Look at what Goodman-Gilman clearly said, and paragraph se directly उठाया question है. They have taken the question directly from the paragraph that Candida glabrata and krusei are considered intrinsically resistant to fluconazole. End of conversation. They are resistant, and whenever there is a fluconazole resistant, in that case scenario, in resistant cases, we are going to prefer amphotericin B. In that case scenario, fluconazole will not be utilized, amphotericin B is going to be preferred agent, right? So, Candida krusei, fluconazole, again they are not sensitive, Glabrata, amphotericin B, yes, we can utilize. Itraconazole, sporothrix, again they are the drug of choice, है ना? Itraconazole is the drug of choice in HSB. B stand for your blastomyces, S stand for your sporothrix and histoplasma. ठीक है. So HSB में your itraconazole is the drug of choice. It's one of the azoles. Okay. Candida krusei and glabrata, they are resistant to fluconazole. For all others Candida, fluconazole is the drug of choice. We can take one more question here. We are having 75-year-old patient with congestive heart failure and cardiac enlargement. Please vouch here. Give me a quick feedback. That was there a question about a patient? Was there a question about a patient having congestive heart failure and cardiac enlargement? Which of the following will decrease the mortality and reduce the further enlargement? Was the language something like this, or was the language something else? Options are digoxin, furosemide, captopril, carvedilol. About a 75-year-old patient, congestive heart failure. Now, drugs reducing mortality. I used to tell you that, remember, like as simple as we are having ACE inhibitor, ARB, aldosterone receptor blocker. ARB matlab all the sartans. Tell me sartan, losartan. All the pril like ramipril, lisinopril. ठीक है. Then we are also having ARNI. ARNI is a combination of ARB, है ना, telmisartan plus neprilysin inhibitor. Telmisartan plus neprilysin inhibitor. Telmisartan plus neprilysin inhibitor, that is sacubitril. So they are not used alone. Sacubitril को हम alone नहीं use करते हैं. We are going to use them in combination with telmisartan. We collectively call them ARNI. ARNI is this one, a combination of ARB plus neprilysin inhibitor. Then we are also going to use beta blocker, है ना. Beta blocker में याद रखिएगा, low dose में we are going to start, low dose beta blocker. And then we can also use some of the important dilators. For example, your potassium channel opener hydralazine, nitrates, they are the dilators. And currently they are telling that your drugs like your SGLT2 inhibitor like empagliflozin can also have this, empagliflozin can also have this reducing mortality property. Now in this scenario, if you are going to look at this one, I am telling you that lot of A are there, no? Lot of A are coming, B is coming, dilators are coming, right? Now in this scenario, definitely there is one option that is by the name of captopril and carvedilol. Two options are there given here, guys. Look at the language of the question. Very tricky question. Decrease mortality, in that case scenario, decreasing the mortality can be done by both C and D. But the problem is, are we using captopril? Captopril, guys, is a prototype drug. We are not using captopril clinically. We are using other ACE inhibitors. Now, even if it is not given, even if you are going to consider, sir, have to ACE inhibitor, theoretically to karega, definitely karega. But look at the other option, reduce further enlargement. Reduce further enlargement. The only drug, if you are going to compare between the both, that can reduce further enlargement. In fact, beta blockers, they have shown to reverse the remodeling. They have shown to reverse the remodeling. Hai na? So in one group of people, they give ACE inhibitor only. In other group of people, they give ACE inhibitor with the beta blocker. In the group where the beta blocker was added, there was reversal. Hai na? Carvedilol have multiple benefit. One is definitely it's a beta blocker. It's a alpha 1 blocking property. Therefore, they are having vasodilating property. Right, and they are also having antioxidant property. So among the given choices, if you have to choose one, I would strongly say that go ahead with the carvedilol rather than going with the captopril. We are not clinically using captopril, no. So this question will definitely be out of the scene, and we are going to utilize a drug here, carvedilol. Carvedilol is the one that is having antioxidant property, vasodilating property. Therefore, preload and afterload will decrease, and we are also going to utilize carvedilol because it's a beta blocker. They will inhibit the activation of the entire RAS system. Okay, oxygen consumption ko bhi they will also reduce. So if you have to choose one, I would say go ahead with the carvedilol. S3 Gallop and Rails mentioned. Okay, and Rails in this system. Okay, Dr. King Ella, S3 Gallop and Rails still going to be carvedilol. Because captopril again we not use clinically. Now next one that we are having is drug binding to ATP binding cassette. So P glycoprotein, if you have read, you already know that there are some agents that are inhibiting ATP binding cassette, जिसको हम ABC भी बोलते हैं. And correct answer for this one was very straightforward, verapamil. There are many drugs that can inhibit this ATP binding cassette, drugs like your amiodarone, clarithromycin, verapamil, quinidine, ketoconazole. So these are again the same drug that are coming from the list of enzyme inhibitor. Remember the enzyme inhibitor drugs like peacock wala aayega, inhibit karke jayega. They are coming from the same like clarithromycin, amiodarone, verapamil. They are all, and also valproate. Valproate can also be acting as an inhibitor of the P glycoprotein. So among the given choices, I would say strongly go ahead with the verapamil. In addition to that, remember cyclosporin can also be one of the inhibitor. Cyclosporin is also one of the inhibitor, not tacrolimus, but cyclosporin is also an inhibitor. Not the, they both are calcineurin inhibitor actually. They both are calcineurin inhibitor. We are having tacrolimus is not an inhibitor, but cyclosporin yes. Okay. Next one. Which of the following is avoided in a patient with a thyroid storm? Thyroid storm mein propranolol is the first drug. Propylthiouracil is considered the drug of choice. Lugol iodine, definitely they are going to inhibit the secretion of the thyroid hormone. Inhibit the thyroid hormone secretion. So in a patient with the thyroid storm, definitely we can utilize Lugol iodine as well. Add-on drug we can utilize. Aspirin that we have is not going to be utilized. Aspirin will be causing dissociation between the thyroid, hormone with its binding protein. H for hormone, B for binding protein. So if you are going to give your drug aspirin, aspirin is going to create a dissociation between these two. Now this one will be further causing worsening of the problem. Worsening of the problem. So if the examiner is going to ask you what is to be avoided in the given choices, I would say that aspirin, PTU not, they give paracetamol. Okay, so let us say that there was paracetamol. If there is paracetamol, remember paracetamol is not avoided. Paracetamol is not avoided. The drug of choice, if the examiner is going to ask you drug of choice for thyroid storm, we are going to use propylthiouracil, PTU, propylthiouracil, thyroid storm के लिए drug of choice होगा, right? And if paracetamol is given, paracetamol is not avoided. Aspirin is something that is going to cause dissociation from the hormone and its binding protein. Triangle one is the binding protein. So if the hormone will be free, they will be causing worsening of the problem. So we should be avoiding them. Okay. Okay, was there a question on ampicillin therapy and pseudomembranous colitis? A patient is presenting and coming to you, he is on ampicillin therapy. So ampicillin therapy or cephalosporin therapy amphitherin, cephalosporin, they are going to be associated with the risk of pseudomembranous colitis. And in that condition, fidaxomicin is the most preferred agent. In the upcoming examination, examiner they can ask you which class of drug is fidaxomicin. So they are macrolides. Examiner asks, what are the other agent? What are other agent? Medicine, dog, aspirin हर जगह दिक्कत देती है. Definitely aspirin will inhibit the uric acid excretion as well, and aspirin सबसे ज़्यादा दिक्कत देती है वाइवा में. If you are one of the second year student and sitting in the viva and you said that I read COX inhibitor or I read aspirin, the examiner is going to now take the huge advantage of yours. So say everything I have read but never say aspirin, because aspirin is a topic from where examiner loves to ask question. So it's the most troublesome drug I have so far I have experienced in viva as well. Okay? Other agent that we can use is per oram vancomycin. If it is mild cases of pseudomembranous colitis, we can still use metronidazole. If you remember recently on my Insta as well, I posted a question about a monoclonal antibody, which is possibly going to be the next exam question, because pseudomembranous colitis is repeatedly being asked. So next exam question the examiner can ask, which is the recently approved monoclonal antibody. So recently approved monoclonal antibody is going to be your bezlotoxumab. Bezlotoxumab, you check out this bezlotoxumab we have discussed already in our lectures as well, and in our question answer series as well we have discussed, right. So this is one of the monoclonal antibody against Clostridium difficile toxin B, against Clostridium difficile toxin B. Bezlotoxumab is one of the monoclonal antibody against Clostridium difficile toxin B. This could be your next question. So again bezlotoxumab, toxin B के against, toxin B of what? Clostridium difficile, right? So correct answer, I think other option if you guys can remember, can you guys give me the other option if you guys can recall? Most preferred drug, can you guys give me other option if you can recall? Other option was there metronidazole, okay. Dr. Sumaya Fatima, metronidazole was there in the option, I am considering this as an option. Other option? Alright, so I would just wait for your comment here for the other option, and we are done here. I have one last question here, and this question, that last question that I saved here is actually not supposed to be asked, because it's not a part of your usual discussion. We usually do not discuss, because this is something which is given to pharma postgraduate resident for inducing the inflammation. So it is a inflammation causing drug, carrageenan. It is one of the inflammation causing agent, that is causing your paw edema, है ना. तो peripheral kind of pain inducing के लिए इसको use करते हैं. We use it for peripheral pain. So you guys can let me know what was the option here. There is a lag between what I am saying and what you guys are commenting. That's why there is a issue here. Some of you are telling, sir, novobiocin was the option. Okay. Let me remove metronidazole and tell you that novobiocin, okay, novobiocin is one of the option. Other option you guys can let me know. Okay, so I'll take last 60 seconds and I'll take all the 24 or 25 question luckily I got here. So एक बार quickly देख लेते हैं क्या 24 question था. जितने लोग last में join किए, all the students those who have joined late, you are not going to miss anything. Just stay for 60 seconds and we are quickly going to go ahead with all those questions. Noxious acute stimulus. So this is one inflammation causing agent, so definitely they are noxious only. They are mainly used for inducing paw edema in the animal model of inflammation. ठीक है. If this was the one, then this is going to be the preferred answer here. This is going to be the preferred answer. Dr. Sumaya Fatima, if this is the one, this is going to be the correct answer. peripheral pain, peripheral or deep pain, this is going to be the correct one, right? So let me quickly go ahead with all the 25 questions that we are having. 60-second quick recap. Carrageenan causing peripheral deep pain, this is one of the question. Then fidaxomicin, it's one of the agent that is a most preferred drug for pseudomembranous colitis. Next question was there about avoided in thyroid storm. Aspirin we are not giving in thyroid storm, aspirin is avoided in patient with the thyroid storm. Next that we are having is ATP binding cassette के साथ bind करके the drug that will be working is known as your verapamil. Next that we are having is about congestive heart failure patient with cardiac enlargement which can reduce further enlargement. Among captopril, carvedilol, I would say prefer your carvedilol. It's most noble drug and definitely AIMS and INI-CET में तो multiple paper, multiple conferences में, multiple studies में, multiple time ये discuss हो चुका है इनके institutes में, ठीक है. Then about not sensitive, remember Candida, glabrata and crucei not sensitive to fluconazole. If it is anything is not sensitive to fluconazole, then we are going to prefer amphotericin B. Next that we are having diabetic neuropathy. What we are going to use is your pregabalin. A child with history of iron, if the level is more than 500, we are going to start the management. Site of action of valproate, it will be inhibiting SSA dehydrogenase and GABA transaminase. That is how they are going to increase the level of your GABA. Next that we are having is pinpoint pupil, morphine will be the correct answer. IgM and scrub typhus, I would strongly recommend go ahead with the doxy and azithromycin if both combination are given. Then we are having more common with oxcarbazepine compared to carbamazepine. So hyponatremia is more common with the oxcarbazepine as compared to carbamazepine. Then 55-year-old with hypertension, first drug that you are going to start, I would say that you start with ACE inhibitor, ARB, or if the age is 55 or more than 55, you are going to start calcium channel blocker. So here calcium channel blocker is amlodipine that we are going to start. Next that we are having MDR TB, next line of management. So TB is the bigger problem here. So we are going to continue the anti-tubercular therapy and add uric acid. However, if the hepatic enzyme is significantly very much high, then in that case scenario, we would always recommend to stop pyrazinamide and continue the therapy of your isoniazid rifampicin for 9 months. Isoniazid rifampicin ethambutol for 9 months. The screenshot of Goodman-Gilman I have given here already. You can check it out. If there is slight change in the language, you can correct according to what was the language of question. Okay. Which of the following protease inhibitor maximally? So ritonavir, as I have given you already. If ritonavir is there, nothing will be the answer. TCA में hypothermia नहीं होगा. TCA poisoning में there can be all others but no hypothermia. Then we are having here anti-diabetic agent approved for heart failure with the reduced ejection fraction if empagliflozin was in the option. So empagliflozin will be the answer. Don't be confused with the DPP4 inhibitor safe in renal failure. In this question also according to a student they said sir renal failure का component था. I agree, but examiner didn't ask which anti-diabetic drug is used in a diabetic patient in renal failure component. They ask for the heart failure patient which anti-diabetic. So two drug always come into our notice, liraglutide and empagliflozin. Empagliflozin was in the option. This is going to be the correct answer. Fostamatinib for idiopathic thrombocytopenic purpura, I already told you this one. Next one is going to be sodium valproate, is going to the most hepatotoxic one. It can be utilized as an anti-epileptic, definitely it's a mood stabilizer agent as well. Cardiotoxic agent hai, if you are going to prevent the cardiotoxicity, I told you dexrazoxane, they are the iron chelating agent. Other option I have already explained in more detail. Ethionamide is something that will be causing hypothyroidism, anti-tubercular drug, two drug causing hypothyroidism, ethionamide and para-aminosalicylic acid. And the first question that we are having is which of the following drug is going to be preferred in a patient who is orally not able to tolerate the drug. Rivastigmine available by the transdermal patch, we are going to prefer this, right? So with this one we are done with our pharmacology session. Thank you very much. For any more doubts, for any more query, feel free to message and you can search out, you can tag in all the social media platform as well if you want to get any of your queries sorted. You can also download the PDF of this one on the Telegram group of NExT. Thank you very much to all of you. Have a great day.
लिखिए भी तो क्या पाऊंगा. Fan. Hi friends, how's the paper today? कैसा रहा पेपर? सुना माइक्रो के क्वेश्चंस आए हैं काफ़ी. तो देखो ऑब्वियसली दिस इज़ अ रिकॉल सेशन और प्रॉपरली वी कुड नॉट एबल टू गेट ऑल द चॉइसेस एंड ऑल. तो जो भी तुम्हें पता लगे और जो भी तुम बताना चाहते हो कि मतलब लाइक सर इट वाज देयर, इट वाज नॉट देयर, सो यू कैन टेल मी अप. एक प्रॉपर सेशन ऑफ ऑल दीज रिकॉल क्वेश्चंस विल बी डूइंग अप सून. ओके, तो द चैट नथिंग इज कमिंग. चैट में कुछ नहीं आ रहा. अपने फ़ोन में भी स्टार्ट कर लेता हूँ ज़रा. These recall questions will be doing up soon. Okay. तो yes please, थोड़ा बताओ फर्स्ट वाले का आंसर. व्हाट्स द आंसर ऑफ इट? दीपेश, डार्क नाइट हैव टोल्ड इट डी, एप्स्टीन बाय वायरस. Yes, anybody who have done it? And obviously these are there in the notes also, in the lectures also we have discussed of this particular thing. So yes please, what's the answer? Immunosuppressive patients having white patches cannot rub the lesion. Exactly, I don't know what have come. So Deepesh is telling Candida. Okay. Dyke Knight told D. Yes, please. First of all, please tell me up like what is regarding the question. Is it in this way only, the immunosuppressive patient having white patches and cannot rub the lesion, or something else was given up in the question? The previous guys like Sumaya, Fatima, Jayaprakash, Lakshmi, Medvision. Yes, anybody? Yes, please. So the question which have come to me, as per that, it was written like HIV or immunosuppressive patients there having the white patches over the tongue, if it is tongue. Okay, because on the lateral side of the tongue, this lesion is there, and this particular one, they cannot able to rub it off, and this is typical of Epstein-Barr virus infection, and I suppose they are talking up in this regarding oral hairy leukoplakia. Okay, they are talking about what? Oral hairy leukoplakia. Yeah, Dark Knight have told lateral to the tongue it was. So oral hairy leukoplakia is typical of it, and that's what the answer here in this particular one. Fine. Jayaprakash, Epstein-Barr virus, yes. So it was written up the virus name, not the disease name like. So this is actually oral hairy leukoplakia. We have done it in this image-based discussion of ours, this particular one, and this is being done by Epstein-Barr virus, and it is common in HIV positive patients. Okay. The same question was there that Ling Arrow was telling. HIV patient, it's clearly written HIV patients with white patches lateral side with the photo of oral hairy leukoplakia. Okay, Ankit. Okay, then it's done. It's done. It's like oral hairy leukoplakia done by Epstein-Barr virus. Can you tell me Epstein-Barr virus? What is the name of Epstein-Barr virus? It is HHV4. Okay, it is HHV4 and affects of which particular cells? B cells. Because of which particular receptors? CD21 CR2. Another question which is likely to come in future. Okay, CD21 CR2. Complement receptors too. Now coming to the next one. Yeah, tell me regarding this guys that all the following test is to be done in dengue except it was, or
what was there in that particular one? Yes, tell me about this. Matt Vision, HHV4, very good. Dipesh, very good. HHV4. Yeah, tell me about this particular one. All the following test is to be done in dengue except it was, or what was the exact question? Yes, if somebody can throw some light over it, that what was the exact question here? Yes, please. In the chat box, please tell, what was asked. Was it given up the time of the fever, like first 2 days of fever, which should be done, and PCR was there in the option or not? Okay, was it regarding the NS1 antigen only? Was it regarding IgM, IgG? What was there? Within 3 days, it was asked. Okay, within 3 days, it was asked. 3 days history was there. Fine. Can you tell me the options, guys? What was the options given up, Chetan and Vamshi? What was the options given up in this particular one? RT-PCR was there. NS1 antigen testing was there by ELISA. Acha, Aedes albopictus inoculation option was also there. So that is obviously not feasible. Okay, IgM was also there. Okay, IgM was also there. So remember guys one thing, that IgM comes up to 5 days. So that will be not the answer here for sure. IgM dengue ELISA will not be the viable option. So this is gone. Okay, if it is except, then this is what is except is IgM. Xenobiotic test done. Acha, xenobiotic test. But up to 3 days of things, xenobiotic and Aedes albopictus inoculation, they are like research based test. So nobody will be doing them for sure. Okay. IgM ELISA, no. IgM ELISA, dengue antibodies, they come on the 5th day. So IgM ELISA for 3rd day history is not there. Can you tell me, was there an option RT-PCR? Was there an option of NS1 antigen testing? And NS1 antigen testing by what method? Card method or ELISA? What was there in the option? So NS1 after 3 days. What was specifically being asked? Like, was it this way, all the following tests to be done in dengue except? Yes, please. Within 3 days or after 3 days? What was exactly? So one thing is for sure, that xenobiotics and these xenobiotic testing and albopictus inoculation, they are out of the scene. Now you tell up, what is the other ones? NS1, RT-PCR, acha, it's what? Except only. So obviously these are out, na man. Then these are out. Xenobiotic albopictus is out of the list. They are research based tests. Nobody have time to do all this inoculation and all in this particular one. Okay, it was yes sir, I accept, Dark Knight was telling. So this is answer. History of fever of 3 days. NS1 definitely can come positive in that, no problem. RT-PCR if it is there, that will come positive. And up to 5th day, the IgM antibodies they come, and obviously these, if they are options, definitely they will go and accept this particular one. And what you have marked up for this then, guys? What you have marked up? Accept, what you have marked up in this? So as per me, the xenobiotic and albopictus one should be going into exceptions. Except this, you can go for any of the other tests for this particular one. But there is a slight doubt about the IgM dengue ELISA also, because for that we do a capture ELISA, and the capture ELISA mostly comes positive on the 5th day of the fever. Okay, so that is also one of the things. So let's sort it out, and in the options, if we are getting up the relevant choices, you marked NS1. Like NS1 can come positive, na? It comes within 2 days of fever, okay, and it remains there, na? It is not going anywhere. So it can be positive, na? NS1 can be positive along with these IgM and all that, which is possible. which is not possible. Okay, tricky question, which is not possible. This is possible. This is possible, not done or possible, so it have changed the wordings of the question. So good question, I suppose. Then yes, IgM, because IgM comes positive for this dengue on the 5th day of the fever. Might be other, so it might be a tricky one. Yes, please. Can anybody tell regarding this? The scrub typhus image, and that was given a black eschar. As you know, the black eschar is coming in the DD of 3 important things at least. One is in the Bacillus anthracis, that is cutaneous anthrax. One is scrub typhus, and one is in the COVID-19 one. That is, there is a black eschar formation in the infection of these rhizobus and mucor, the rhinocerebral zygomycosis and all that. In that also the black eschar is there. So yes, please tell me about this. What was given up? Was it just an image, or somebody was telling regarding pneumonia also there was something? That pneumonia is also there along with that. Everybody knows the scrub typhus drug of choice is doxy. Okay. So there was cough and fever there in this. Okay. Cough and fever there in this along with that. Okay. Options. What were the options? Options are correct, dark night. Were these the options there? The best treatment for about disease, this was asked. So for most of the rickettsial disease, we use doxycycline. And if cough and fever was also there, patient with pulmonary symptoms also. So what you have marked up? Dark night, Vamshi and Azhar, what you have marked up in this? And was these are the options or something different? Yes, please. Options are correct, Vamshi is telling. Okay. And you have marked up A, dark night. Azhar, what you have marked up in this particular one? A. C. Vamshi is telling C. And Azhar, I think Siraj sir is perfectly right in this, that it is with doxy, AZI, it should be used. It will cover up this atypical pneumonia along with this doxycycline covering up the scrub typhus. Okay. And as you know that the scrub typhus is done by what? Aurantia susugamosi, and zoonotic tetrad and all that particular things are observed in this. And fluorescent testing is one of the gold standards which is being used in the scrub typhus along with the PCR. And another important thing for the NEET PG is wheel phalanx test, and OXK is strongly positive in this particular one, that is the wheel phalanx test. Okay, so these are the important ones. So this image given, but alone with clinical history of pharma. So this doxy plus AZI is the best answer for this scrub typhus one, because it will take care of the doxy, will take care of the scrub typhus, and AZI will take care of these particular atypical pneumonias which are happening to that particular fellow. Okay. So if these are the options, then the answer is A. Now tell me about this question. I could not able to get any of the options, but this seems like a one-liner, that HIV positive with capsulated organisms, CD4 count of 200, that is there, or below 200 was given up, Indian ink was given up. So obviously, was it there? No. These all, Vamshi, they all does atypical pneumonias, not the typical ones. Yes, please. HIV positive with capsulated organism. What was the exact question? Yes, please throw some light on this. Gentlemen, throw some light on this. So obviously, if this is there, then we are talking about Cryptococcus neoformans. And what was being given in the question? It is regarding meningitis, or what was given up? Yes, please. What was given up in this? Was it cryptococcal meningitis, pneumonia, what? What was given up? Yeah, tell please. Tell guys. Nobody is telling up anything. Lingaro Bura, you said yes, sir. So was it meningitis? Was it pneumonia? What was there? Indian ink preparation CD4 less than 200. Treatment was asked. Okay, okay. LAMP. Liposomal amphotericin, meningitis features were given. So LAMP with flucytosine. So it is adequately covered up in the exam. Multiple options were there, sir. Okay. No clinical diagnosis was given up. Somebody have made it meningitis. Newly diagnosed. This question was more various treatments in, yes, various treatments in HIV. Nuclear rigidity and all. Vamshi is telling nuclear rigidity and all. So obviously towards the meningitis. So this is what is the answer for this, guys. You already know that LAMP, liposomal amphotericin B, along with flucytosine. That is in this particular one. Okay. And we do two types of tests in that, if you remember of. One is Indian ink preparation, this is there, and another one better than this is latex card agglutination test. So this was also the previous AIMS question, that which one is better to go for, Indian ink or latex card agglutination. So answer is latex card agglutination is better than the Indian ink for cryptococcal antigen detection. Okay, Sunil. Okay, fine. Wonderful. So answer is LAMP plus flucytosine. Now, tell up regarding this. A person recently recovered from COVID-19 was treated with steroids. After 3 weeks, complaints of nasal discharge, swab collected, okay, and following image is seen. So first of all, swab is not collected. One thing is there. You go for biopsy, nasal biopsy. Okay. You go for what? You go for nasal tissue biopsy, and in this nasal tissue biopsy you put up the 10% KOH, or you just prepared up a KOH preparation, or you can put up H and E stain, and what you can get in that, you can get wide angled aseptate hyphae, that is observed up. Okay. So answer obviously is towards what? Mucormycosis. Okay. Aseptate hyphae. So was it there in the exam? Blood tingled discharge. Okay. Blood tingled discharge is there. Blood tingled discharge is there in this. Fine. Swab or nasal tissue biopsy, because in nasal tissue biopsy only you got able to see this aseptate hyphae, which are obtuse angled and right angled. Okay, obtuse angled and right angled. Favorite question of examiners. Yes, it's a favorite question of examiners, and this I suppose everybody must have done. Okay. Another thing is like other than COVID-19, what they can write up other things like diabetic ketoacidosis, diabetes mellitus, diabetic ketoacidosis along with this COVID-19. They are also the features which predispose to this mucormycosis. And again the drug of choice is what? LAMP. Okay. Again the drug of choice is what? LAMP for this. Now, was it elongated factor 2? This is given up in the form of image or what? What was being given up in this? Elongated factor EF2, which is there. What particular thing was being asked in this? Was it the toxin action or was it the image given in this? What was exactly there? If you can tell up, guys. Yes, Medvision, Sunil, Nikhil, Azhar, tell up, like what is there in this? Options were given, okay. Options were given, mechanism of action given, elongated factor 1, elongated factor 2, it was given up. Organism and multi options were there. Was this given up? This particular picture was given up? Or just like they have asked up elongation factor 2, that particular one. So you know this, that diphtheria toxin is having two components, A and B. B helps in binding to the cell and A does ADP ribosylation of this elongation factor 2, which inhibits the protein synthesis and thereby causes the cell death. Okay, and we already have remembered it by this mnemonic, That is A, B, C, D, E, F. No image was there. Okay. Chandranshu has said no image was there. Darknet is telling image was there. Okay. Straight question. So other than that, what edit point I like to tell you this, elongation factor also plays a role in S and P. So DSP, Dr. Sonu Pamar. S is Shigella, guys. Okay. Shigella also acts through elongation factor stuff. And P, this particular one, pseudo. They all, in fact, inhibits the protein synthesis. Okay. Inhibits the protein synthesis of the cell. Fine. Image was there. Nikhil is telling image was there. Okay. It was a line diagram, colorful, not this colorful. Okay. So you got this now. Obviously, this is correct of yours. This is diphtheria one, and others which are acting by inhibiting the protein synthesis, they also should be remembered up. One is Shigella and one is Pseudomonas. Okay. Fine. Now, this is again a controversial one. Was it there in the exam? Have they asked about the nocardia? This filamentous form was there in the exam? Yes, anybody? This filamentous form was there in the exam or not? Yes, if anybody can tell up. Yes, sir. Dark Knight have told, yes, sir. So this filamentous form of nocardia, as you know, how much percent acid fast it is? 1% acid fast. Okay. And other than acid fast stain, which other you can use for this nocardia? You can use gomori methamin silver also for the histopathological finding of it. Okay. Vamshi Naidu, no sir is telling. Dark Knight is telling yes sir. No sir. Dark Knight, now you are telling no sir. Before you were telling yes sir. I don't remember. Okay. Okay. So if it is there, then it's fine. Otherwise it can come. This is filamentous one. It was previous. Okay. So it was not there actually. Fine. No problem. Now, tell about this one. Which of the following viruses needs reverse transcriptase PCR? Was it there, guys? Which of the following viruses needs a reverse transcriptase PCR? TSS was asked. Toxic shock syndrome. Okay. Like a super antigen azar, it was asked. Tell me about this. Which of the following viruses? First of all, discuss and then miscellaneous ones we'll discuss up later. Yeah. Was it there in the exam? Yes, please. Chandranshu, Dark Knight, Vamshi. Can you tell me up that was it written up for RT-PCR, reverse transcriptase PCR? Ye to tha. Sunil is telling up. So obviously, guys, you know that for the RNA viruses, you do reverse transcriptase PCR. And those which are RNA viruses, for them you have to do this. And which of the following is RNA virus? You already know that we have a mnemonic, happy. And happy fellows are DNA viruses, rest of others are what? RNA viruses. So answer is obviously RSV. Okay. The answer is what? The answer is RSV, which does what? Acute bronchiolitis. Which does what? Acute bronchiolitis. And drug of choice also, you know, ribavirin. And it is not having any of the hemagglutinin and neuraminidase. Another favorite question of examiner. कोविड के लिए हाँ वो तो है ही. देखो जो भी आरएनए वायरस होंगे ना उनके लिए करना पड़ेगा ना. सी नहीं होगा आंसर. सार्स भी था क्या? सार्स वाज आल्सो देयर. Medvision, as you're telling, SARS was also there in the option. If these are the options, EBV, CMV, HHV, these all are what? These all are DNA viruses. For them, you don't need RT-PCR. I think SARS nahi hoga. Right. Dark Knight, you are right. Answer is RSV, which does acute bronchiolitis. Fine. Okay. No SARS, no? That's what. Now tell about this, guys. Regarding this, CNS features and paralysis was there, or it was like PAM features, primary amoebic meningoencephalitis. What was asked and what was given Yes, please. Instead of EBV, parvo virus था. तो parvo is also DNA ना. तो obviously वंशी no problem. Answer उसका RSV है. Okay. Tell about this. What was there? Rural area feature was there. Then CNS features were there. क्या swimming की history थी इस question में? There was a history of swimming in the clean water pond. No swimming history. Okay. था क्या exactly question क्या था फिर? Rural area CNS symptoms ऐसे थोड़ी आ गए उसको, कुछ तो हुआ होगा. इलेक्ट्रॉन माइक्रोस्कोपिक पिक्चर दी थी किस चीज़ की? EM फीचर्स किस चीज़ के? इलेक्ट्रॉन माइक्रोस्कोपी यहाँ पे क्यों करेंगे? क्या वायरस भी लिखा था क्या कोई? हिस्ट्री ऑफ पॉन्ड स्विमिंग, सुनील इज टेलिंग हिस्ट्री ऑफ पॉन्ड स्विमिंग वाज देयर. ए ऑप्शन, किंग राज डॉक्टर इज टेलिंग ए ऑप्शन. तो स्विमिंग की हिस्ट्री है तो ऑब्वियसली इट्स गोइंग टुवर्ड्स द पैम, प्राइमरी एमीबिक मेनिंगोएन्सेफलाइटिस, एंड इट इज बीइंग डन बाय नाग्लेरा फॉलोरी, यू नो. Acanthamoeba associated with contact lens keratitis that you already know, and Balamuthia is like clearly not written up, the etiology regarding it, but it also does granulomatous encephalitis. No history of swimming. Picture thi. Picture of what, Chandranshu? What was the picture in this? Water drinking history of the village. Black and white. Black and white picture. Black and white picture. Fine. Okay. Black and white picture थी organism. Fine. It was acanthamoeba image. Oh, acanthamoeba image. Swimming history थी, निखिल. भाई साहब तुम ही कंफ्यूज हो गए इसमें थी या नहीं थी, क्या था? स्विमिंग हिस्ट्री थी तो भैया नेग्लेरा फॉलोरी की तरफ है, और स्विमिंग हिस्ट्री अगर कंटामिनेटेड स्विमिंग पूल में थी तो वहाँ भी acanthamoeba की तरफ है. तो बेसिकली ये जो है मतलब पिक्चर के ऊपर बेस्ड है फिर ये क्वेश्चन, मतलब व्हाट दे हैव गिवन अप. अगर मछली जैसा था ना, अगर मछली जैसा था, इट लुक्स लाइक अ फिश, तो इट्स acanthamoeba. इफ इट वाज लाइक अ फिश इट वाज acanthamoeba. और नाग्लेरिया फॉलोरी मतलब वो तो पिक्चर देखने के बाद पता लगेगा एग्जैक्टली क्या था. चलो, EM इमेज वाज गिवन, नहीं थी सर. Okay. Chalo, fine. Now tell about this question. What was exact question that which of the following is required for HIV entry into the human cell? What was exact question? A option सही है. King Raj ने बोल दिया तो A option सही है भाई. History of swimming was in forensic question. Okay. Mona Singh is telling. मोना जी ने पहली बार कमेंट किया तो माननी पड़ेगी बात उनकी, ऐसे नहीं बोलेंगे वो. नो स्विमिंग हिस्ट्री वॉज देयर. अच्छा, किंग राज तो एकदम कंफर्म है कि सर आंसर यही है. चलो कोई नहीं, बढ़िया, गुड. अब तुम ये बताओ, विच ऑफ द फॉलोइंग इज रिक्वायर्ड फॉर HIV एंट्री इनटू द ह्यूमन सेल. इसमें क्या क्या ऑप्शंस थी और क्या था, और कौन से सेल्स के ऊपर था? मतलब CD4 T सेल्स के अंदर या फिर मैक्रोफाजेस के अंदर क्या था? क्योंकि इससे तो एंकरिंग होती है, GB120 से तो चिपकता है. GP41 ट्रांस मेम्ब्रेन प्रोटीन है. ऑर्गेनिज्म प्रोजेक्शंस गिवन सर, प्रोजेक्शंस थी. एक्यांथमीबा में होते हैं प्रोजेक्शंस बेटा. श्री कृष्णा एक्यांथमीबा की तरफ हो सकता है. तो इसको जब मैं अपना नेक्स्ट सेशन प्रॉपर वाला करूंगा ना, उसमें इमेजेस आई विल शो यू अप. CCR5 ऑप्शन क्या था? CCR5 वाला ऑप्शन जीनोम एंट्री CCR ऑप्शन में था सर. CCR5 भी था. ओके. GP41 था, GP41 था यहाँ पे. कैन यू टेल मी आप? GP41 CCR5 था, CXCR4 नहीं था. ये था CXCR4. बताओ. CCR5 था तो मतलब GP21 नॉट देयर. अच्छा ये नहीं था. ओके. अब ये तो बताओ क्वेश्चन क्या था एग्जैक्ट? GP41 इन द ऑप्शन सर. GP21 नहीं था, CCR5 था. ओके देखो फ्यूजन प्रोटीन तो मतलब GP41 है. क्या आंसर मार्क करके आए उसका? व्हाट यू हैव पुट इन दिस? What answer you marked up? आंसर क्या मार्क किया इसका? What you marked up in this? अच्छा you marked up CCR5, GP41, वंशी GP41. यही आंसर है. फ्यूजन प्रोटीन यही होता है जिसकी हेल्प से वो एंट्री मारता है ह्यूमन सेल में. CCR5 और CXCR4 ये दोनों को रिसेप्टर्स होते हैं, इनकी ज़रूरत पड़ती है. ये भी हैं. ह्यूमन सेल इज गिवन. GB120 से एंकर करता है एम्बुलर प्रोटीन से. GP41 फ्यूजन वाला होता है, ट्रांसमेम्ब्रेन वाला. और CXCR4 और CCR5 दोनों हैं अगर, ऑब्वियसली दे आर को रिसेप्टर्स. ठीक है. और CCR5 स्पेसिफिकली मतलब मैक्रोफाजिस के लिए होता है. चलो एग्जैक्ट चीज़ पता लगे तो पता लगेगा कि भाई CXCR4 भी था क्या? CXCR4 था वहाँ पे, ये बताओ ज़रा. CXCR4 था ऑप्शंस में? CXCR4 था? वाज इट देयर? CXCR4. Yes please. Anybody? Sunil, Dark Knight, Mona. Yes please, yes please. था या चले आगे? अच्छा, और ह्यूमन सेल में कुछ डिस्क्राइब किया था? CD4 T सेल्स हैं या क्या, कौन से सेल्स हैं जिनके अंदर एंट्री की बात हो रही है? नॉट कंफर्म. था सर. यस सर. तो फिर तो आंसर GB41 पे जाएगा बस. GB41 ट्रांसमेम्ब्रेन, वही फ्यूजन प्रोटीन होता है, उसी की हेल्प से फ्यूजन होता है और वही एंट्री में हेल्प कराता है. ठीक है, बिकॉज ये दोनों तो को रिसेप्टर्स हैं, CXCR4 और CCR5. ठीक है, ये तो हो ही गया हमारा. ये आई थिंक तुमने कर लिया होगा डिस्कस सर ने. इसमें क्या था, कुछ बताओगे? पैथोजन नॉट सेंसिटिव टू द गिवन ड्रग. No description of the cell, only human cell was written. Okay. तो co-receptors है बहुत, CCR5 और CXCR4 ना, they are co-receptors. GP41 is a fusion protein जिसकी हेल्प से वो एंट्री मारता है. ठीक है. चिद्रांशु, निखिल, मोना, सुनील, now tell about this question. Pathogen not sensitive to given drug. What were exact options and was these there in the question in the exam? C you have marked up. Candida krusei, amphotericin B. Okay, Mona, you marked up C in this. अच्छा, ओके, फिर तो डन है बॉस. अगर ये फ्लूकोनाजोल दिया था तो ये मैंने पढ़ाया है. कैंडिडा क्रूजी इज इंट्रिंसिकली रेसिस्टेंट टू द एजोल्स. ओके, और उसको याद भी हमने कैसे किया था? क्रूज आर रेसिस्टेंट टू होल्स. ओके, दैट इज एजोल्स. सर ऑप्शन सही नहीं था. हाँ, तो नॉट सेंसिटिव है ना, बिल्कुल सी आंसर है इसका. द आंसर ऑफ दिस पर्टिकुलर वन इज सी. ग्लेबरेटा के लिए एम्फोटेरिसिन बी दिया था. ओके ओके ओके, सी आंसर है ना. फाइन. अब इसके अलावा जो है, लाइक somebody have told up regarding pyogenic meningitis, one question was there, yes or no? And you know already guys कि pyogenic meningitis में प्रोटीन्स बड़े होते हैं, शुगर्स का लेवल कम होता है. ठीक है, और न्यूट्रोफिल्स बड़े होते हैं. क्या था ऐसा? कैंडिडा क्रूजी विथ फ्लूकोनाजोल. हाँ, वही आंसर है. वेरी राइट सुनील. निखिल, मेडिटेशन वंडरफुल. इसमें बताओ, क्या न्यूट्रोफिल्स दिए थे इंक्रीज्ड और प्रोटीन्स बड़े हुए दिए थे और ग्लूकोज कम था इन दिस पर्टिकुलर वन? टिपिकल केस ऑफ पायोजेनिक मेनिंजाइटिस था या नहीं था? कोई क्वेश्चन वाज देयर समथिंग रिगार्डिंग द पायोजेनिक मेनिंजाइटिस इन द एग्जाम? यस प्लीज, कैन यू टेल अप? हाँ जी दोस्तों बताओ, लिम्फोसाइटोसिस था, क्या था? अच्छा शुगर 20 दी थी, ओके। और सुनील और बताओ इस क्वेश्चन के बारे में। लिम्फोसाइट्स वर गिवन, अच्छा लिम्फोसाइट्स दिया था, ओके। और लिम्फोसाइट्स थे। ग्लूकोज 20 था, फाइन। तो टीबीएम दिया था क्या ऑप्शन में? वॉज इट टीबीएम? टीबीएम था ऑप्शन में? टीबी मेनिंजाइटिस आंसर है, तो बात खत्म हो गई भाई। लिम्फोसाइट्स बड़े हुए हैं, ग्लूकोज कम है, प्रोटीन्स बड़े हुए हैं, तो ऑब्वियसली आंसर टीबी है। लाइनस ऑलिड का क्वेश्चन था सर, रॉन्ग स्टेटमेंट पूछा था, लाइक 30 मिनट है। डार्क नाइट भाई तुम कहाँ घूम रहे हो? टीबीएम इसका आंसर है, मतलब अगर ये वाला पूछा है ना तो दिस आंसर फॉर दिस इज टीबीएम। लिम्फोसाइट्स इंक्रीज होते हैं, प्रोटीन्स बड़े होते हैं और शुगर जो है वो कम होती है, लेकिन इतनी कम नहीं होती जितनी पाइजेनिक मेनिंजाइटिस में होती है। ठीक है दोस्तों, एक क्वेश्चन दोस्तों ये आया था कि वायरस कौन सा जो है वो प्रेगनेंसी में टेराटोजेनिक नहीं होता। ओके, विच पर्टिकुलर वायरस इज नॉट टेराटोजेनिक इन द प्रेगनेंसी। और ऑप्शंस में था दोस्तों सीएमवी, ठीक है, रुबेला, फाइन, सिफिलिस और हर्पीज। ये सब थे ना ऑप्शंस में, सीएमवी, रुबेला, सिफिलिस एंड हर्पीज। बताओ इसका आंसर, ये था क्वेश्चन। पहले तो ये बताओ कि वॉज इट देयर दिस क्वेश्चन। गलती होगी सर, मार्क बैक्टीरियल मेनिंजाइटिस। लिम्फोसाइट देखने थे ना दोस्त। तो कॉबवेब कोई कैरेक्टरिस्टिक एकदम वो थोड़ी है। एचपीवी, एचपीवी था या एचएसवी था? व्हाट वाज गिवन अप, एचएसवी और एचपीवी? एचएसवी था ना, मोना इज टेलिंग एचएसवी। इसका आंसर एचएसवी है। सीएमवी में भी टेराटोजेनिक इफेक्ट होता है, रुबेला में भी होता है, सिफिलिस में तो सिफिलिस तो शायद ऑप्शन में नहीं था। कोई बोल रहा है कि कोई कह रहा है कि मतलब इट वाज वेरिसेला विच वाज गिवन अप, तो वेरिसेला का भी टेराटोजेनिक इफेक्ट होता है, सीएमवी का भी होता है, रुबेला का भी होता है, एचएसवी नहीं होता। बिल्कुल सही आंसर है इसका एचएसवी। मोना यू आर राइट इन दिस पर्टिकुलर वन, परफेक्टली राइट। ठीक है, अच्छा समबडी हैव टोल्ड अप कि जो है क्वेश्चन आया था regarding the chick embryo pic, was it given up, chick embryo pic, and some inoculation was shown up. Okay, क्या ऐसा था कुछ कि कुछ चिक एम्ब्रियो के ऊपर? चिकन पॉक्स, अच्छा चिकन पॉक्स ऑप्शन में था उसके। यस प्लीज, कैन यू टेल मी आप गाइज, बोलो। हाँ हाँ, उसका आंसर हर्पीज है, नो डाउट, एचएसवी। अब तुम ये बताओ मुझे कि चिक एम्ब्रियो की कोई पिक आई थी जिसमें इनोकुलेशन वगैरह का कुछ बताया था? कैन यू टेल मी अप? ओके ओके, वेरिसेला हो गया ना, वेरिसेला जोस्टर, वेरिसेला इन्फेक्शन, वेरिसेला जोस्टर का। हाँ जी बोलो। चिक एम्ब्रियो पिक यूज्ड पूछा था, स्टेनिंग का पूछा था सर, आयोडीन एंड नॉर्मल सलाइन माउंट। ओके ओके, हाँ ये क्वेश्चन भी पूछा किसी ने कि मतलब विच वन इज प्रेफर्ड अप, chick embryo anatomy given derivatives asked, anat question. Oh okay 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 okay, sorry. तो tell me up regarding this that ये saline mount के बारे में पूछा था कि saline mount में इतना तो like obviously in the saline mount we go for what, seeing of the trophozoites in the parasitology, मतलब प्रोटोजोलॉजी में ट्रोफोजोइट्स देखते हैं। इसमें ईजी होता है बनाना, मतलब एक ड्रॉप ऑफ सलाइन लेते हैं, उसके अंदर फीकल सैंपल डालते हैं एंड देन इट वाज आस्क्ड। सो मोना एक्चुअली व्हाट दे वांट टू आस्क अप इन दिस, कि मतलब वो पूछना क्या चाह रहे थे, डिफरेंस इन स्टेनिंग विद सलाइन माउंट एंड आयोडीन माउंट। आयोडीन जो होता है वो सिस्ट को करता है, आयोडीन माउंट इज एक्चुअली फॉर द सिस्ट। ठीक है, और क्यों अच्छे से स्टेन करता है? क्योंकि इसमें ग्लाइकोजन होता है। 3 स्टेटमेंट गेम, ओके। पैरासाइट एग के ऊपर भी क्वेश्चन आया था कुछ, पैरासाइट एग के ऊपर, वाज देयर एनी क्वेश्चन फॉर पैरासाइट एग? अच्छा, सेलाइन माउंट एडवांटेजेस वर आस्क्ड ओवर आयोडीन माउंट। तो भाई एक ही एडवांटेज है मोटा मोटा तो, कि ईजिली बन जाता है रादर देन द आयोडीन माउंट जिसमें थोड़ा टाइम लगता है। यस प्लीज। ओके अब वो एकदम ऑप्शंस नहीं पता लगेंगे तो उतना आसान नहीं है इसको बताना कि क्या है क्या नहीं है, ठीक है। अच्छा ये बताओ दोस्तों, वन क्वेश्चन वाज आस्क्ड रिगार्डिंग जोना ऑक्लूडेंस, ये मैं बताता था क्लास में, दिस पर्टिकुलर थिंग वाज डेफिनेटली बी आस्क्ड। किसमें? ट्रोफोजोइड तो बेटर सलाइन माउंट में दिखते हैं ना, सलाइन माउंट होता ही ट्रोफोजोइड के लिए। तो सुनील यस यू आर राइट, तो इसीलिए सलाइन माउंट हम करते भी हैं फॉर ट्रोफोजोइड्स। आयोडीन जो है वो सिस्ट के लिए होता है। मोटिलिटी कैन बी सीन, हाँ मोटिलिटी दिखती है, सलाइन माउंट में मोटिलिटी दिखती है, बिल्कुल दिखती है, ये है सलाइन माउंट में मोटिलिटी दिखती है, राइट। ग्लाइकोजन स्टोर्सिंग, ग्लाइकोजन तो भाई आयोडीन से दिखते हैं, मोटाइल फॉर्म्स दिखती हैं, और समथिंग एल्स जो है पता नहीं वो समथिंग एल्स क्या है, चलो देखते हैं। मतलब ट्रोफोजॉइड्स दिखते हैं और मोटिलिटी दिखती है बाय द सलाइन माउंट, इतना तो है, ठीक है। अच्छा ये बताओ जोना ऑक्लूडेंस वाला क्वेश्चन था, वॉज देयर एनी क्वेश्चन रिगार्डिंग जोना ऑक्लूडेंस? नॉन बाइल स्टेन डिफरेंशिएशन किसके बेसिस पे? मल्टीपल करेक्ट टाइप क्वेश्चन था ये, ओके ओके ओके। अच्छा चलो ये बताओ विब्रियो कॉलरे वाला, क्या इसमें जोना ऑक्लूडेंस का जिक्र था? विब्रियो कॉलरे रिगार्डिंग जोना ऑक्लूडेंस, अच्छा क्वेश्चन है, फिर आ सकता है ये। जोना ऑक्लूडेंस और टाइट जंक्शंस, इन्हीं पे एक्ट करता है विब्रियो कॉलरे, इन्हीं पे एक्ट करता है कौन? विब्रियो कॉलरे। ओके ओके ओके। ऑक्लूडेन वाज गिवन, जोना नहीं दिया था, ऑक्लूडेन टॉक्सिन दिया, क्या दिया था? तो ये तो सही कर दिया होगा आई सपोज, यू मस्ट हैव डन दिस पर्टिकुलर वन राइट, वी ऑलरेडी टॉक्ड अबाउट दिस। And this I have got to know that there was a question regarding BSL-3, biosafety level 3. हाँ मोना यू आर राइट। BSL-3 biosafety level 3 वाले ऑर्गेनिजम्स में क्या क्या ऑप्शन थे? क्लॉडिन कुछ नहीं होता, डार्क नाइट, नथिंग लाइक क्लॉडिन एंड ऑल इज देयर। हाँ ठीक है, ट्रोफोजोइड सही है, मोटिलिटी, ग्लाइकोजन के लिए हम सिस्ट वाले को प्रेफर करते हैं। वेयर विल द टॉक्सिन एक्ट? जोना ऑक्लूडेंस, टाइट जंक्शंस, बिल्कुल सही है आंसर इसका। जोना ऑक्लूडेंस वाला क्वेश्चन भी आया था मतलब, ओके। अब इसका बताओ BSL-3 वाले में क्या क्या आया था? अच्छा ऑक्लूडिन क्लॉडिन भी आया था और नाम में, ओके 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 फाइन 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 फाइन, ऑक्लूडिन है इसका आंसर। ओके बिंदास, वंडरफुल, गुड क्वेश्चन। अच्छा इबोला तो बॉस BSL-4 है, जशन सिंह BSL-4 है इबोला, और ये बताया भी है मैंने। इबोला इज अ वन क्वेश्चन अकाउंट बायोसेफ्टी लेवल 3। अजर वही मैं पूछना चाह रहा हूँ, क्या ऑप्शन में क्या था? व्हाट वाज द ऑप्शन रिगार्डिंग बायोसेफ्टी लेवल 3? ऑप्शंस में क्या क्या था इसके? XDR-TB, यस यही आंसर है इसका, आंसर XDR-TB है दोस्तों। अगर BSL-3 वाले में दिया है XDR-TB 100% यही आंसर है इसका, BSL-3 में यही करते हैं। कैडरिन-4 भी था उसमें, कैडरिन-4 नहीं है वो, उसका तो वही है फिर ऑक्लूडेन। इबोला था, XTB था, इबोला तो बायोसेफ्टी लेवल 4 है, BSL-3 के लिए XDR-TB है, बिल्कुल सही है। बहुत सारे ऑर्गेनिजम्स हैं, बैसिलस एंथ्रेसिस हो गया, ब्रुसेला हो गया, सारे इसी में देखते हैं हम, फ्रांजिला टूलरेंसिस, येलो फीवर, वेस्ट नाइल फीवर, ये सारे के सारे बायोसेफ्टी लेवल 3 वाले हैं। हाँ बिल्कुल सही निखिल। हाँ ये XDR-TB आंसर है इसका दोस्तों, अगर ये आया था तो इसका आंसर XDR-TB है, ठीक है। हाँ हाँ यही आंसर है इसका, XDR। ई कोलाई तो 1 है, बायोसेफ्टी 1 में देखते हैं, ठीक है जी। तो ये हो गया। इसके अलावा लाइक कैन यू टेल मी द एग्जैक्ट क्वेश्चन विच वाज देयर फॉर हेपेटाइटिस बी, कि हेपेटाइटिस बी में क्या anti-HBC के बारे में क्या बोला था? इसकी IgM पॉजिटिव है, IgG पॉजिटिव है, क्या पॉजिटिव है? वर दे आस्किंग रिगार्डिंग विंडो पीरियड, व्हाट दे वांट टू आस्क अप इन दिस? XDR was correct. हाँ Mona, you are right. Mona is answering a lot of questions. Mona, you are getting selected, I suppose. कैप्सुलेट ऑर्गेनिज्म, हाँ ये तो हो गया रिफ्लेक्स, वी हैव ऑलरेडी डिस्कस दैट. क्रिप्टोकोकस न्यूफॉर्मेंस, इंडियन इंक स्टेनिंग, ये तो हो गया रिफ्लेक्स, वी हैव ऑलरेडी डिस्कस्ड दैट. इसमें विंडो पीरियड के बारे में पूछा था क्या? पैप स्मीयर वाज देयर. अच्छा, पैप स्मीयर क्वेश्चन तो वो पैथो वाले बताएंगे भाई. अब तुम ये बताओ इसमें क्या था, क्या IgM था, IgG था, क्या था? IgM एंटी HBC पॉजिटिव था, हैं? और क्या था उसमें? टोटल एंटी HBC. IgM नेगेटिव था. एक ही क्वेश्चन के इतने सारे प्रारूप कैसे बन जाते हैं आफ्टर कमिंग अप आउट फॉर द एग्जाम? एक IgM नेगेटिव बता रहा है, एक पॉजिटिव बता रहा है. विंडो पीरियड वाज इन ऑप्शन. ओके, चलो इसका बेटर क्या निकलेगा वो देखते हैं. IgM नेगेटिव था. ओके, तो पॉजिटिव क्या था फिर? IgG. IgG तो क्रॉनिक बताता है. HBCAG पॉजिटिव, everything else negative. It's a inactive carrier. HBCAG positive. HBCAG positive तो आ ही नहीं सकता, आता ही नहीं कभी कोर एंटीजन तो. रिमोट क्योर्ड समथिंग एल्स. टोटल एंटी HBC पॉजिटिव. अच्छा ओके, टोटल एंटी HBC. तो देखो दोस्तों, अगर IgG लिखा है उसने, IgG एंटी HBC, अगर इसके बारे में बात करना चाह रहा है वो, ठीक है, तो वो तो क्रॉनिसिटी को वो करता है कि हाँ भाई एक मतलब कैरियर है, उसके साथ चल रहा है मामला. अच्छा, फॉर श्योर इट वाज नॉट मेंशन. टोटल एंटी HBC पॉजिटिव बता रहा है. एंड ऑप्शंस है इनएक्टिव कैरियर, विंडो, रिमोट क्योर्ड, समथिंग एल्स. तो प्रोलॉन्ग्स, देखो एक बार जब हमारी बॉडी में ना IgG एंटी HBC आ जाता है देन इट प्रोलॉन्ग्स थ्रू आउट द लाइफ. तो ये भी इसमें है. तो एग्जैक्ट क्वेश्चन पता लगेगा तो ज़्यादा बेटर रहेगा आई सपोज. और कुछ दोस्तों विच यू थिंक हैव कम, कि कोविड और उसके अराउंड कुछ आया हो, और कोविड आया हो, रेबीज़ आया हो, मलेरिया आया हो, समथिंग रिगार्डिंग मलेरिया एंड ऑल, एनीथिंग एल्स रिगार्डिंग एनी बैक्टीरिया? स्टाफ कुछ नहीं दिखा, स्ट्रेप्टो कुछ नहीं दिखा, कुछ समथिंग रिगार्डिंग देम? वैक्सीनेटेड का तो कोई सेंस ही नहीं है, एंटी HBS होना चाहिए वो तो. तो आई सपोज दिस मच हैव कम गाइस, एंड थैंक यू सो मच एंड वेरी बेस्ट ऑफ लक फ्रॉम माय साइड. और डेफिनेटली तुमने बहुत अच्छा किया होगा आज. अब थोड़ी देर बाद रिलैक्स करना आफ्टर नोइंग अप ऑल दीज पर्टिकुलर वंस. और दिस इज जस्ट टेल यू अप दैट these are the correct answers and all. Or I think the paper was very much doable and you must have done it wonderfully well. And if you take up like read up my notes or videos you have seen up, or YouTube lives and all that, so all these things they are being covered off. Even the BSL 3, BSL 4, all these things are also being covered off along with these occludens and all. So right from the start and up till last, everything was being like saline bond and this iodine bond. These are also things they are also being told up. Okay. So dengue test we have already discussed up, that is there. So very best of luck from my side and thank you so much. Collection of RHD sample in a patient, what is this? Rheumatic heart disease patient sample. A super antigen was there. So anyways, you write up this and we will come up with a wonderful recall of all this with the proper options. Thank you so much.
हेलो स्टूडेंट्स, वेलकम। तो आज आप लोगों का एग्ज़ाम आई होप बहुत अच्छा हुआ होगा. So all of you must have done exam wonderfully, and today we'll be discussing dermatology questions. And as I have seen these questions, I am very happy for all of you because we have discussed almost each and every question in our TND as well as in our regular batch classes. So all my students must have answered these questions correctly. तो at least dermatology में तो I can say कि आप लोगों के अच्छे marks आने वाले हैं. बाकी for overall I will wish you all the very best. So let us begin with today's session and let's discuss dermatology questions. I hope I am audible and my slide is visible to all of you. If yes, just type yes in the chat box. Yes, so students, let us discuss the first question. Here this was image based question, and in the image as you can see, yes, dark night, thank you very much. So in the question there was one image and the image was near medial canthus, and I hope all of you must have identified this condition. Very common question which have been asked so many times in various exams. So 60-year-old patient. So obviously old individuals are more prone for malignancies. So this is one of the malignancy, and the site is very characteristic, that is medial canthus, because this is a very common site for basal cell carcinoma. Yes, basal cell carcinoma, and these basal cell carcinomas can present with ulcer, and the margins or the edges are very characteristic, like you can see these rolled edges. So this is a case of basal cell carcinoma. Yes. Moving to the next question. In this question, they said 25-year-old male patient. Okay, and one thing more, that if you find that any of the options were wrong or the question language was different, so you can just type in the chat box. Okay, so here I have the chat box just in front of me. So if you feel that any option was missing or any option was wrong which is written here, or any question language was different, so you can definitely type in the chat box. Okay, so reflex, thank you very much. Yes, it was BCC. Yes, so moving on to the next question. So in this question, again this was image based question, and the image of the trunk was given, and over the trunk there was these pinkish or reddish lesions, and as you can see in the second image, this characteristic lesion was given, and this lesion was again present over trunk, and all of you know trunk is the common site for one of the condition which is mentioned here in the option. And what is the question? Yes, the question states that 25-year-old young male patient, okay, has presented with asymptomatic scaly lesions. So scaly, okay, and scaling is very characteristic. Last time also in INI-CET, one match the following question came, and there again the different types of scaling was mentioned, and different condition have different characteristic scaling. So this becomes a very important topic for INI-CET, that is scaling seen in dermatology. Then lesions on the back, so trunk, the commonly involved area, as shown in the image, also symmetrically distributed. So lesions were symmetrically present, and the provided image showcased the lesion. Can you identify the pattern which is shown and the specific disease? Okay, so Warnoff ring, first option. I hope all of you know Warnoff ring is the hypopigmented ring which is formed around the lesions of psoriasis. It is seen in psoriasis, and why they develop? Because of release of prostaglandins generally after phototherapy. Okay, so obviously this option is wrong. Warnoff ring is not seen in seborrheic dermatitis, it is seen in psoriasis. Very good. So please keep typing in the chat box if you find that any option was missing or any language of the question is changed, because this is a recall session and these are the options of the question which we got and the images which we got. So we are going to discuss them, and then later on we will come up with the accurate question and the accurate options. Okay, so we will be recording this session again, but this is for all of you so that you can know that what option you have marked and which one is the correct option. So moving to the second option, Wickham striae is seen in lichen planus. Yes, this is true, Wickham striae is seen in lichen planus, but is this a patient suffering from lichen planus? No, because lichen planus presents with pink, not pink but purple, so purplish lesions are seen. Okay, and other features are also present which I am not going in detail right now because we are going to keep the session short. Then
Collared scales Christmas tree pattern seen in Pityriasis rosea. Yes, so this is the answer. And why this is the answer? Because the Christmas tree pattern or the fir tree pattern is seen in Pityriasis rosea. And agar aap iska naam dekhenge, if you look at the name of the condition, Pityriasis means scaling, and here scaling is present. Rosea comes from rose, and rose aap sabhi ne Valentine Day mein dekha hi hoga. Rose kaisa? Red rose. So red or pink rose. So lesions are pink or reddish in color. This is a case of Pityriasis rosea, and when these lesions start developing, they develop along the line of ribs. So because they are present along the line of ribs, agar aap iska longitudinal diameter in lesions ka, if you draw a straight line, you will find a pattern which is similar to Christmas tree or fir tree. So that is the specific pattern, and the scaling which is seen is very fine, cigarette paper like or colorate of scales. We have discussed this numerous times in every lecture, in every T&D session, in every live class. I discussed this condition, and so many times this question have been asked. So repeated question again, and I hope all of you have marked correct. So yes, in the chat box, tell me how many of you have marked this question correct. Please type correct in the chat box. Yes. So if your answer was correct, then just type correct in the chat box. Very nice. And Christmas tree pattern in psoriasis. No, Christmas tree pattern is not seen in psoriasis. It is seen in Pityriasis rosea. So again, this answer is Pityriasis rosea. So this is the correct option. Moving to the next question, one image was given, and this is a very important investigation which we do in blistering conditions in immunologically mediated blistering disorders. Yes, and this is what? This is DIF. DIF stands for direct immunofluorescence. So in direct immunofluorescence, what we do? Yes, what we do? In direct immunofluorescence, we see the fluorescent antibodies. So because like let us consider a condition, pemphigus, where desmoglein are involved. So antibodies are formed against desmoglein, and wherever desmoglein is present, there you will find these antibodies. And because we are using fluorescent antibodies, you will find the fluorescent under fluorescence microscopy, and that fluorescence gives a characteristic pattern like the fishnet like pattern which can be seen in pemphigus, like linear pattern which can be seen in bullous pemphigoid. So such patterns are very characteristic, and this is DIF, which is considered as the investigation of choice. Investigation of choice for immunologically mediated blistering disorders. Yes, very nice. Moving to the next question. Yes, Bindas. So if you have any doubt, or if you feel that any option is missing or any option was wrong, please keep typing in the chat box. Yes. So yet another question, again from the blistering disorders, and again we have discussed this so many times. Again a repeat question. A person presented with flaccid blisters. Which type of blisters? Flaccid blisters. Oral mucosal lesions were present, and you can see in the image also oral mucosal lesions are present, and this is what? This is very superficial oral erosions which are present here, and the blisters are also flaccid. They are not tense, they are also superficial blisters shown in the image below, along with the histological finding. And if you see the histological finding, what you can make out? You can see that if this is epidermis and below this is dermis, and this is what? This is the junction. So you can see this is the basal layer, and above the basal layer is the split. So split is above basal layer, that is suprabasal split, and suprabasal split is seen in pemphigus vulgaris. I hope you have marked this correct. Yes, reflex, very good. So you have marked this question correct, very good. Yes, it is pemphigus vulgaris, and pemphigus vulgaris, remember, generally present with oral mucosal erosion. So this is the common presentation initially, and when you see the histology, if you do the biopsy and under microscopy, you will get suprabasal split. So suprabasal split is also shown here. Moving to the next question, here they are saying all are features of non-scarring all are seen in all are the conditions where non-scarring alopecia can be associated except. So this is again a very common question which is asked. Alopecia, all of you know, is hair loss, and it can be of two types. One is known as temporary and one is known as permanent. So permanent is actually scarring. It is also known as cicastaceal alopecia, while the temporary type of hair loss is non-scarring and non-cicastaceal type of alopecia. And you will read these lists in most of the guides and most of the books. We also discussed during our notes and during our classes. So remember that all those alopecias which start with alphabet A and T generally cause non-scarring alopecia, and by chance, by luck, you can see that out of these four options, 3 are starting with A and T. So you see, I give this mnemonic in my classes every time, and see, it is so simple to answer this question because 3 among the 4 options are starting with A and T. So they are going to cause which type of alopecia? Yes, non-scarring type of alopecia. So the answer here obviously becomes what? Answer becomes frontal fibrosing alopecia, which cause scarring, that is, which cause cicastaceal or permanent type of hair loss. Okay, so I hope this answer was also correct for all of you. Yes, very nice, Bindas. Frontal fibrosing, Shri Krishna, very good. The answer is D. And why? Because frontal fibrosis causing scarring, while all these like telogen effluvium, like androgenetic alopecia, alopecia areata, all these are treatable conditions. Here the hair loss come back, so this is temporary type of hair loss, that is non-scarring alopecia. Yes, so most of the students here have marked this answer correct. Very good, Bindas. So if you feel that any question is missed, any image was missing in this discussion which I am taking right now, do type in the chat box and let me know that the language was different or some image was there. Okay, so please, yes. Now, I don't know whether this type of question was there, it was assertion or reasoning type of question, or whether it was something like this that we have got from the students, that there were 2 cases mentioned and they asked that whether one is true and the other one is false, both are true, both are false, or the vice versa. Okay, so whether it was this type of question or whether it was reasoning and assertion type of question where they give a assertion and then they give a reason and then they ask you that whether this assertion is correct or whether this reason is correct or whether this is the correct reason for the assertion. So just type in the chat box. Yes, so reflex, yes, easy, yes, it was easy. And dermatology, as you know, it is high scoring subject and you should never leave dermatology. It is not going to take very long time, hardly in 1 or 2 days you can finish off the revision of dermatology, and you can see that 8 questions were asked and almost 8 of them you could have marked them correctly if you have gone through dermatology. Okay, so that's why I always tell my students that short subjects are very important and high scoring. So coming back, yes, so Sri Krishna is saying that this type of question was not there. So what is the opinion of other students? Yes, please tell me whether this type of question was there or not, or whether the format was different, because I am also a little bit confused because this is not reasoning and assertion and they have directly mentioned 2 cases. Anyways, we are going to read this question. If you have any suggestions or you want to tell me that whether such type of question was there or not, just type in the chat box. So here they have said that case 1. So case 1, a patient having flaccid bulla with painful erosions. Okay, so again flaccid bulla, just now we have discussed flaccid bulla, painful erosions, will show suprabasal split, inflammatory infiltrate in the blister cleft on histopathological examination. Yes, all these are pointing towards the previous condition which we have discussed, that is pemphigus vulgaris, where flaccid blisters are seen, painful erosions are seen which are generally oral, and suprabasal split is present, and there can be inflammatory infiltrate which you can see on histopathological examination. Very good. Yes, so Dark Knight is also saying this question was not there. So probably some students have made a mistake and they have told in this way. Anyways, you can see. Then case 2, row of tombstones appearance is diagnostic of pemphigus vulgaris. Yes, this is one investigation, that is investigation finding. We do histopathological examination and row of tombstones appearance is seen in pemphigus vulgaris. So both are true. So if such question was there, then the answer will be both are true. Moving on to the next question. Yes, so tell me whether this question was there. Again, a very, very, very easy question, and all of you might have seen such patients during your derma OPD visit or your posting, because this is a very common condition. And here patient start developing dark, that is hyperpigmented, velvety skin over folds. Okay, it's like neck fold is being shown here, and this is obese patient. So another clue, because these obese patients have what? They have insulin resistance, they might have metabolic syndrome. So what happens? They start developing this velvety appearance over their neck folds. This is known as acanthosis nigricans. Acanthosis nigricans. And because in acanthosis nigricans, insulin resistance is also the underlying cause which is present. So that was also there in the option, and some students got confused whether to mark insulin resistance or whether to mark acanthosis nigricans. Now read this question again. They are saying obese lady presented with velvety appearance. So cause can be obesity, cause can be diabetes, cause can be insulin resistance, but the velvety appearance is not insulin resistance. Velvety appearance is acanthosis nigricans. Okay, yes, so Sunil is saying that it was 13-year-old girl. So point well taken, Sunil. Thank you very much. So we'll change the age group. So remember that this is acanthosis nigricans, though the underlying cause can be insulin resistance, but the answer you will mark is acanthosis nigricans because okay, so double XT, yes, so nice name, double XT. So he's not double XL, it is double XT. So sir, it was 13 years, acanthosis and insulin resistance both were in the single option. Wow, very good, more easy question. So if both were there in the single option, then obviously that will be the answer. But still, if you have these different options, then you should go for acanthosis nigricans, because they have mentioned velvety appearance. Okay, so insulin resistance might be the cause. And as you can see, 13-year-old, as the Sunil told, that 13-year-old girl is there. Okay, so 13-year-old girl. So 13-year-old girl is there. So remember that there is one condition which is known as herein, that is hyperandrogenism, then insulin resistance and acanthosis nigricans, which are associated and seen together. Okay, so that's why it can present in early age group as well. Okay, so generally what happens that in older age group, due to lot of obesity or underlying condition like diabetes or metabolic syndrome, patients start developing acanthosis nigricans. But if you're getting it in early child, then it could be due to hyperandrogenism, that is excessive hormones. Very good. So moving on to the next question, this was very easy, that is apocrine glands are commonly present in which part of the body? So all of you know that the common sweat glands which are present almost everywhere in a body are eccrine. Eccrine sweat glands are common and they are present everywhere, including palm and sole. So some patients have hyperhidrosis of palm and sole, that is due to eccrine sweat gland. But apocrine are the one which are present over axilla. Again, very easy to remember, A for A. So remember that apocrine sweat glands are the one which are present over axilla. Okay, and face, scalp, palm and sole, these are the sites where these common sweat glands, that is eccrine sweat glands, are present. Okay, so very good, Shri Krishna have answered this question correctly. So tell me, just I am very curious, because these were very obvious questions, repeat questions, and I just want to know that how many of you have got all these questions correct in the examination. So please tell me how many of you have got all the questions correct. Please type awesome in the chat box. Awesome, because all of you are awesome. All of you must have done these questions correctly and I'm very proud of you. So type awesome in the chat box. Let me know how many of you have answered these all questions correct, because I think this was a very high yield and very easy dermatology session in your examination, and I hope all of you will get very good marks in INI-CET and all of you will come out with flying colors. My best wishes are with you. I am waiting. Yes, Shri Krishna said derma was easy. So just tell me, Shri Krishna, whether you answered all of them correct or not. Yes, please. Yes, so Paramoin is the first one who have answered, and very good, you have done awesome, very nice. So all correct, very good. So yes, anyone who have done this session awesome in the examination, all corrects? Very nice. Very nice. So, thank you very much. I hope that all of you will come out with flying colors. My best wishes are with you. Thank you. Thank you. Thank you.
Hello dear students, INI-CET November 2023 exam is over. Be relaxed. Dear doctors, so today I am going to discuss OBG part of INI-CET 2023 November exam, and here is a set of around 8 to 10 questions from obstetric part, and my colleague is going to discuss the gynec part. The first thing I want to tell you is that most of the questions is from my Allen OBG notes. Okay, doctor. And the questions from OBG, most of the questions are clinical vignettes. Now, first we'll discuss the first question in obstetric part. Yes, that is from physiological changes in pregnancy. That is, increased blood volume during pregnancy is due to. What is the cause for increased blood volume during pregnancy? One, the option A is increased aldosterone and estrogen. B is increased aldosterone and ADH. And C is increased retention by kidney. Yes, and D is increased retention by kidney, increased aldosterone and estrogen. What is the correct option? Now, dear doctors, in this exam, for this question, they given a graph, it seems. I am not able to get the graph, but what is the final take-home message? Increased blood volume during pregnancy is due to one, increased aldosterone. Yes, that is the one thing, and increased estrogen, and another one thing, increased retention by kidney. Please make a note of it. The option, suitable option for this question is the D option, that is increased retention by kidney, increased aldosterone and increased estrogen. Now, so I'm not able to get the graph which was given in the exam, but I can tell you what is the graph that is given in the exam. Now, doctor, look into this. This blood volume, please make a note of it. This blood volume starts to increase. Please make a note of it. This blood volume starts to increase around 6 weeks of pregnancy. Please make a note of it. This blood volume starts to increase around 6 weeks of pregnancy. Yes, and peaks around third trimester. So, peaks around third trimester means around 32 to 34 weeks. Yes, the blood volume will peaks. So, this is the graph would have been given in the exam. Understood, no? So, blood volume definitely increases around 40 to 45%. Yes, which is given in the Bible of obstetrics, that is Williams. So, it will start increasing around 6 weeks, peaks around third trimester, that is 32 to 34 weeks. And this increased blood volume may be due to increased aldosterone or increased estrogen or increased retention by kidney. I think this question is clear, doctors. Yes. Yes. Now, doctor, come to the next question. Yes, very nice question. So, 39-year-old, Gravida 6, Para 3, Abortion 3 with previous 3 LSCS with PAS. All of the following are complications due to PAS except. Now, dear doctor, what is this PAS? Doctor, PAS is also called as MAP. What is this PAS or MAP? So, PAS is, that is placenta accreta syndrome or placenta accreta spectrums. You got my point? So, placenta accreta syndrome or morbidly adherent placenta. So, morbidly, dear doctors, morbidly adherent placenta. Yes. PAS or MAP is nothing but placenta accreta syndrome or morbidly adherent placenta. So, we have got 3 morbidly adherent placentas. One is placenta accreta, increta, percreta. Understood, doctor? So, you all know, if you go through my video, most common risk factor, please make a note of it, most common risk factor for this PAS or MAP is what, doctor? Placenta previa in present pregnancy. Please make a note of it. Most common risk factor is placenta previa in present pregnancy. Second most common risk factor for this placenta accreta syndrome or morbidly adherent placenta is previous uterine surgeries. Previous uterine surgeries. Either it can be a cesarean section or either it can be a myomectomy or hysterectomy, whatever it may be. Now, she is a Gravida 6, Para 3, Abortion 3 with previous 3 LSCS with PAS. So, all of the following are complications due to PAS. Definitely, due to this Creta syndrome, there will be increased risk due to increased risk of bladder injury, yes, increased risk of peripartum hysterectomy, increased risk of bleeding leads to increased risk of blood transfusion and increased risk of bowel injury also. But when compared to bladder bladder injury and bowel injury, more chances of what? Bladder injury. Because if you take that placenta percreta, that placenta percreta involves the cirrhosis of uterus, which involves the bladder mucosa also. That's why more chances of bladder injury compared to the bowel injury. Now, yes, if you see these 4 options, even it leads to bowel injury also, bladder injury also, more chance of peripartum hysterectomy. That is the definitive management of this Akrita spectrum diseases, and increased risk of more bleeding leading to increased risk of blood transfusion, and there is a chance of bowel injury. But suitable option for this question, I can go for what? Increased risk of bowel injury. Yes, increased risk of bowel injury is less compared to the increased risk of what? Bladder injury. I think this question is clear, doctor. So in NEET PG also they can ask you the question. You should very familiar with this. So placenta accreta syndrome or morbidly adherent placenta is what, doctor? It is due to what? Placental implantation pathology. Placental implantation pathology. Here means in this condition the placenta is not only attached to endometrium, it is infiltrated through the layers of the myometrium up to serosa. That's why the definitive management of this condition is what, doctor? Peripartum hysterectomy. The most common risk factor is placenta previa in present pregnancy. Second most common risk factor is previous uterine surgery like cesarean section, myomectomy, hysterotomy. Understood, doctor? Yes, this placenta accreta spectrum can lead to bowel injury, bladder injury, peripartum hysterectomy, increased risk of bleeding, that is PPH. Is it clear, this question? The answer for this question is increased risk of bowel injury. Now come to this question, that is infection in pregnancy. All of the following are teratogenic infection in pregnancy except, it's a repeat question. You all know this HSP, herpes simplex virus, it has got the intrapartum transmission is very high with HSV. But what about this chickenpox or CMV or rubella? They are all congenital infections. They cause more of congenital syndromes. That's why this HSV has got intrapartum transmission is highest with HSV. Intrapartum transmission is highest with HSV compared to this chickenpox, CMV or rubella, because this chickenpox, CMV or rubella have got congenital infections. Understood, doctor? I think this question is clear. Now come to this wonderful question. 35-year-old multigravida visits to labor ward casualty at 30 weeks. Please remember this period of gestation, that is at 30 weeks with history of painful vaginal bleeding. She is 30 weeks POG. Yes. So she comes with history of painful bleeding, that is antepartum hemorrhage. Then and also gives history not able to perceive fetal movements. Fetal movements are absent, and her BP is 164/90 with proteinuria 2+. Obstetric grip examination shows fundal height corresponds to 34 weeks. Here the fundal height is more than POG. So clinically look into this, her LMP as per clinical estimation she is telling 30 weeks, but as per her fundal height it is 34 weeks, means fundal height more than POG, and uterus is tensed, ridged and not able to auscultate fetal heart sounds. Pelvic examination, os is 6 cm dilated with 60% effacement. Next step in the management. Now dear doctor, what are the catchy points here is, one is the fundal height more than POG, that is an important point, please make a note of it. The fundal height more than POG, that is a one thing, and absent fetal heart sounds, yes, and hypertension, and she is in active phase of the labor. Please make a note of it. So as per ACOG, dear doctor, active phase of the labor is nothing but more than or equal to 6 cm dilator. Please make a note of it. So fundal height more than POG, absent fetal heart sound, hypertension, yes, BP is 164/90 with proteinuria 2+, maybe preeclampsia. So and she is in active phase of the labor. Now what is the diagnosis of this question, doctor? Definitely it is concealed variety of abruption. Please make a note of it. What is the diagnosis of this question, doctor? It is a concealed variety of what? Abruption. Now dear doctor, in concealed variety there is RP clots. You all know, doctors. So if you see my videos, I nicely explained with the diagram. There will be what, doctor? RP clots. What is this RP clots? It is nothing but retroplacental clots. Now this retroplacental clots produces two things. One is thromboplastin, yes. Another one is thrombin. thrombin. Now doctor, this thromboplastin and thrombin, they all serves as a uterotonics. They all serves as a uterotonics, that is increases the tone of uterus, increases the tone of uterus. That's why uterus is tense, tender and rigid. Tense, tender and rigid. So due to RP clots, definitely this RP clots, it will infiltrate through the layers of the uterus. That's why the fundal height will be more than POG. Now doctor, if you see, one of the indication for doing ARM is in abruption. Definitely we will try to do what ARM. What is ARM? That is artificial rupture of membranes. Means if you do ARM, definitely the process of abruption gets stopped. And you all know most of the women in abruption, they are all in active phase of the labor. Why they are in active phase of the labor? I told you, due to RP clots, there will be release of thromboplastin and thrombin. They are all uterotonics. Means they will make the woman to progress the labor. Understood? That's why they are most of the women with abruption presents in active labor, and if you do ARM in abruption, definitely this ARM will stop the process of abruption in most of the women, as the Bible says. You got my point? If you do artificial rupture of membranes in abruption, definitely the process of abruption gets stopped or the process of abruption get altered. That's why one, we will control BP with antihypertensives and do artificial rupture of membrane. The answer for this question is do artificial rupture of membranes. So most of the students will try to answer, sir, control BP with antihypertensives and do immediate cesarean section. Yeah, you will think immediate cesarean section. See, in placenta previa, we will prefer to go for immediate cesarean section. But in abruption, we will try to do vaginal delivery because most of the women with abruption will be in active labor. Please make a note of it. Once, doctor, look into this. If you do artificial rupture of membranes, yes, the abruption process will be stopped. That is the release of thromboplastin, thrombin. Because more thromboplastin, more thrombin leads to what, doctor? So disseminated intravascular coagulation. That is consumptive coagulopathy. So that's why we will rupture membranes. Understood? So definitely we will rupture membranes in abruption, but we won't rupture membranes in placenta previa. Understood? Never ARM in placenta previa, must ARM in abruption. Understood? This is a take-home message from this question. Is it clear? So if such questions comes in your NEET PG, please be careful. So once again, take-home message. Dear doctor, abruption women will present with painful vaginal bleeding. And one of the risk factors for abruption is hypertensive disorder. That is the one thing. And most women with abruption definitely presents in active labor. Why? Due to release of thromboplastin or thrombin. And definitely we will do what ARM to alter the process of abruption. Is it clear? Yes. So next, very good question. An intern was conducting vaginal delivery, inadvertently leads to uterine inversion. The next best step would be, doctor, if you see my video, that is the third stage labor complication, in that uterine inversion, the first line I told you in the management of uterine inversion is never attempt to remove the placenta. Please make a note of it. I used to tell many times to my NEET PG aspirants under the topic of uterine inversion, never attempt to remove the placenta. Understand? First, you replace the uterus inside, then you try to remove the placenta. Please make a note of it. Never attempt to remove the placenta. Never attempt to remove the placenta. That is a first important take-home message in the management of uterine inversion. Understand? That is repositioning the uterus without removing the placenta. You got my point? That is, so first never attempt to remove the placenta, then manual replacement of uterus under general anesthesia. Please make a note of it. Manual replacement of uterus. Manual replacement of uterus under general anesthesia. And another important point, what is the technique we will follow? The part which is delivered first is what, doctor? Replaced last. Please make a note of it. Please make a note of it. The part which is delivered first, which is coming out first. The part which is delivered first. So which is that part which is delivered out first, doctor? It is a fundus. The part which is delivered first, that is the fundus, is replaced last. Is replaced last. So these are all the catchy points you should know under uterine inversion. And most common cause of death in uterine inversion is hemorrhagic shock. It is not the neurogenic shock. Please make a note of it. It is a hemorrhagic shock. So first the answer for this question is yes, we will manually replace the uterus without removing the placenta. Means never attempt to remove the placenta. That is a one important point. Is it clear? Yes. Now come to this. I think this is a forensic medicine question, but anyway I will discuss the two important golden points on this question. 13-year-old female was brought to OPD by her mother. Yes, upon examination she was found to be 8 weeks pregnant. Yes, so it is 8 weeks pregnant and not willing for genital examination. What is the most appropriate next step? So preserve the clothing. Yes, register a MLC and inform the police. Take consent from the mother for examining genital organs. Plan MTP immediately. You all know, doctor, as per POCSO Act, less than 18 years pregnant definitely will intimate the police and make it as MLC. Yes. Is it clear, doctor? As per POCSO Act, less than 18 years pregnant definitely will intimate police and register for what, doctor? MLC case. You got my point? Is it clear? It's a direct question. So you should remember the POCSO Act. And less than 18 years, definitely make a MLC and inform the police. These are the two catchy points from this question. Yes? Yes. Now look into this question. A 36-year-old pregnant mother with known psychiatric bipolar disorder on lithium therapy, that is 750 milligrams per day, presents to labor casualty at third trimester. Yes, that is the one thing. No issues or attacks since 1 year. What is the next best step? Doctor, if you look into my OBG videos, 2 drugs in obstetrics is very important. Please make a note. Very, very important. 2 drugs. One is lithium in pregnancy. Definitely you should know. What is the dose? What is the toxicity? Yes, everything is important. Lithium in pregnancy. That is very important. And another one important, indomethacin. On and off, dear doctor, indomethacin in pregnancy. On and off, the questions on these 2 drugs will be coming. Please remember. In NEET PG also, either they can ask you question on indomethacin, either they can ask you question on lithium. Understood? So now this time they are asked the question on lithium. Now the pregnant mother who is a known case of bipolar disorder on lithium presents to labor ward casualty at third trimester. What is the next step? Dear doctor, any pregnant mother on some drugs which will be somewhat teratogenic during near term, definitely we will reduce the dose. Why? To decrease the neonatal toxicity of the stroke. Please make a note of it. So you got the point, doctor. Now she presenting at third trimester. Understood? Most of the drugs in pregnancy near term will reduce the dose because due to the effect of that drug on a neonate. Understood, doctor? So we will decrease the dose of lithium to prevent neonatal transmission or to prevent neonatal lithium toxicity. You got the point, doctor? The answer for this question is decrease the dose of lithium. Understood, doctor? Please make a note of it. For NEET PG, try to read golden points on lithium in pregnancy. Yes. And what? Indomethacin in pregnancy. Is it clear, doctor? Yes. Is this question is clear? Yes. Now come to this another important clinical vignette. 29-year-old primary gravida visits to labor ward casualty with history of pain abdomen at 39 weeks of POG. Pelvic examination reveals 3 cm dilated, 70% effacement at -3 station with bag of worms felt. Doctor, if you see whenever in your final years or in your internship, the consultant would have told you bag of worms is always characteristic of umbilical cord feeling. You got the point, doctor? So it is bag of worms is nothing but umbilical cord. Here it is 3 cm, 70% effaced. Yes, -3 station with bag of worms felt. Doctor, bag of worms felt means definitely it is umbilical cord, and the diagnosis of this question is it is umbilical cord presentation. It is not umbilical cord prolapse. It is umbilical cord presentation. So what is this umbilical cord presentation? Means in this the membranes are intact. Please make a note of it. Membranes are intact. But in umbilical cord prolapse, the membranes are not intact. That is, the membranes are ruptured. But then this question, 3 cm dilated with 70% effaced with -3 station with bag of worms felt, definitely it is umbilical cord presentation. Doctor, if you look into the topic in the OBG, that is in the induction of labor I clearly mentioned the contraindications of labor. I clearly mentioned the umbilical cord presentation is one of the contraindication for induction of labor. You got my point? Miss, definitely in umbilical cord presentation, we won't go for induction of labor or we won't go for artificial rupture of membranes. Only thing is what, doctor? We will do immediate cesarean section. She is already 39 weeks, yes, with 3 centimeter dilated, with 70% effacement, with -3 station, with bag of worms, definitely umbilical cord presentation. So, umbilical cord presentation is an absolute indication for what? Immediate cesarean section. Is it clear? The question is clear? Yes. So, I think, so these are all the 8 questions which I collected under obstetric part. So, dear doctors, my humble request, so most of the questions in obstetrics and gynecology will be clinical vignettes. Understood? So, easily solved. Understood, doctor? So, anyway, the gynec part will be discussed by my colleague. So, I tried to cover the maximum authenticated questions of INI November obstetric part. Understood? So, dear doctors, thank you and revise for my NEET PG exam. Thank you, doctors.
ओके बच्चों, वेलकम टू द पीडियाट्रिक्स रिकॉल INI-CET November 2023 and congratulations to all of us. India has finally won the game. So I come with very good news and of course the later good news will follow कि आपके पीडियाट्रिक्स के क्वेश्चन आई होप सो सारे अच्छे हुए होंगे, ठीक है, सारे करेक्ट हुए होंगे. तो चलो शुरू करते हैं हम लोग. द फर्स्ट मोस्ट ऑफ द क्वेश्चंस यूजुअली स्ट्रेट फॉरवर्ड थे, एक दो थोड़े टेढ़े क्वेश्चंस आए थे, बट आई एम श्योर आप लोग आंसर करने में सक्षम हो गए होंगे, राइट. चलो अब शुरू करते हैं. पहला, अ बेबी वैक्सीनेटेड एट 14 वीक्स. द यूजुअल क्वेश्चन वैक्सीनेशन पे आना ही आना था. विच वैक्सीन टू बी गिवन नेक्स्ट, रूट एंड साइट पूछा गया था आपसे. सो 14 वीक्स के बाद अगर हम नेशनल इम्यूनाइजेशन स्केड्यूल देखें बच्चों, तो उसमें 14 वीक्स के बाद व्हाट कम्स इज द 9 मंथ्स वैक्सीनेशन विद MR. MR स्टैंड्स फॉर मीजल्स एंड रुबेला एंड 9 मंथ्स पे देनी होती है हमें. एंड कहाँ देनी होती है, रूट क्या होता है, रूट सबक्यूटेनियस होता है MR वैक्सीन का. एंड कहाँ देनी होती है, तो कैसे आपने याद रखना है. देखो BCG का ट्रेडिशनल साइट होता है लेफ्ट आर्म. MR वैक्सीन हम देते हैं राइट आर्म पे, ठीक है. सो इसका करेक्ट आंसर क्या होगा, MR वैक्सीन एट 9 मंथ्स सबक्यूटेनियसली राइट आर्म. सो दिस इज व्हाट यू नो, हमको इसमें सही ऑप्शन लगेगा एंड ये आपका करेक्ट आंसर होगा, राइट. चलो इसके बारे में थोड़ा और पढ़ लेते हैं. दैट ऑल इंजेक्टेबल वैक्सीन्स यूजुअली हम कहाँ देते हैं, एंट्रोमीडियल पार्ट ऑफ थाई में देते हैं, एक्सेप्ट फॉर फ्यू वैक्सीन जिसके लिए कुछ स्टैंडर्ड साइट्स डिजाइंड है. BCG के लिए तो इसलिए स्पेसिफिकली डिजाइंड है बिकॉज वी नो दैट वी हैव टू लुक फॉर द स्कार एंड इट इज ऑलवेज इफ यू नो सेट द कन्वेंशन की वी हैव टू गिव ऑन लेफ्ट अपर आर्म. सो द मोमेंट यू हैव टू लुक फॉर द BCG स्कार यू विल ऑलवेज लुक फॉर द स्कार एट द लेफ्ट अपर आर्म. तो लेफ्ट शोल्डर होता है BCG के लिए, राइट. देन उसके बाद MMR और FIPV के लिए सेम होता है. FIPV इज फ्रैक्शनेटेड IPV जो अगेन आपके नेशनल इम्यूनाइजेशन स्केड्यूल में इंक्लूडेड है, ठीक है. उसके लिए राइट अपर आर्म है जो कि अब आपका क्वेश्चन आया था. जैपनीज एनकेफ्लाइटिस के लिए लेफ्ट अपर आर्म अगेन मेंशन्ड है. एंड PCV न्यूमोकोकल कॉन्जुगेटेड वैक्सीन जो निमोनिया की वैक्सीन होती है उसके लिए डेजिग्नेटेड साइट है राइट एंट्रोलेटरल थाई. कोई स्पेसिफिक रीजन बाकी सबके साथ नहीं है, बट डेफिनेटली BCG के साथ है दैट इट इज़ द लेफ्ट शोल्डर फॉर श्योर टू लुक फॉर द स्कार, राइट. चलो ओके, सो लेट अस सी आप लोगों ने कैसे किया. सो आई एम वेटिंग फॉर द चैट टू कम. ओके, नेक्स्ट इज so this is a national immunization schedule I have already included in this, and you can see that 6, 10, 14 पे आपकी यूजुअल वैक्सीनेशन पेंटावेलेंट वैक्सीनेशन होती है अलॉन्ग विद फ्रैक्शनेटेड IPV एंड ऑफ कोर्स मीजल्स रुबेला फर्स्ट डोज अलॉन्ग विद विटामिन A द फर्स्ट डोज 9 कंप्लीटेड मंथ्स पे आती है. तो ये आपका आंसर हो गया, ठीक है. चलते हैं अब नेक्स्ट क्वेश्चन पे. हाउ डू यू असेस पेरीनेटल एस्फिक्सिया. सो अगेन आई एम टेलिंग यू दैट वॉट एवर ऑप्शंस दैट आई गॉट उसमें से मैंने बेस्ट आपसे निकालने की कोशिश करी है. सो लेट अस सी इसमें क्या ऑप्शंस मिले हमें. एपगार्ड स्कोर ऑफ 4 to 7 आफ्टर 5 मिनट्स, इज दिस द आंसर. और कॉड pH ऑफ लेस देन 7.2 और हाइपोटोनिया और द प्रेजेंस ऑफ हाइपोकैल्सीमिया. सी आई एम नॉट वेरी श्योर वेदर द फोर्थ ऑप्शन वॉज प्रेजेंट और नॉट एज पर द source of the recall, but then this is what we could muster. So देखते हैं first what are the definitions, how is perinatal asphyxia defined, पहले वो देख लेते हैं. So we have 2-3 definitions which we usually follow. So first definition is the presence of either of the following is suggestive of birth asphyxia. सबसे पहले persistence of Apgar score of 0 to 3 for more than 5 minutes. अगर आप recall करो आपके question में 4 to 7 दे रखा था. So that is definitely not the case. Scalp और cord blood pH less than 7.0 आपके question में 7.2 आया हुआ था, ठीक है. Then evidence of multi-organ system dysfunction in immediate neonatal period, ठीक है. This is one of the criteria. And fourth and very important criteria with respect to your question is neurological manifestations. और कुछ definitions देख लेते हैं. According to National Neonatology Foundation जो हमारा NNF है इंडिया का and WHO, हमने कैसे categorize किया है birth asphyxia को severe and moderate में. तो severe वो तब बोलते हैं जब 0 to 3 at 1 minute हो and moderate जब 4 to 7 at 1 minute हो. आपके क्वेश्चन में 4 to 7 एट मोर देन 5 मिनट्स था, तो डेफिनेटली वो तो ऑप्शन आउट है. और क्या क्राइटेरिया है, एक और क्राइटेरिया है बर्थ एस्फिक्सिया की फॉर द कम्युनिटी सेटिंग. ये भी NNF ने दी है So this is for those semi trained staff जो कि डॉक्टर नहीं है at the grassroots level, how they can detect asphyxia. So absence of cry at 1 minute is asphyxia for them, absent or inadequate breathing, and अगर at 5 minutes भी same चीज़ हो, that means no cry and no breathing, then we call it severe asphyxia. So this is for the community setting. So once we have gone through all these ऑप्शंस, तो आप नोटिस करोगे कि अब आपका आंसर बहुत ही सिंपल हो जाएगा. सो वी अगेन रीविजिट द क्वेश्चन, और इसमें आप क्या देखते हो कि आपका स्कोर ऑफ 4 to 7 एट 5 मिनट्स तो किसी हालत में नहीं है. कॉड पीएच 7.0 से कम होता तो हम सोचते. हाइपोकैल्सीमिया तो कहीं फिगर आउट नहीं करता, ऑल्दो हाइपोकैल्सीमिया इज अ कॉम्प्लिकेशन ऑफ सिवियर बर्थ एस्फिक्सिया, बट देन इट इज़ नॉट अ क्राइटेरिया टू असेस बर्थ एस्फिक्सिया. सो व्हाट वी आर लेफ्ट विद इज हाइपोटोनिया. अब आप बोलोगे मैम इसमें तो हाइपोटोनिया कहीं क्लियरली मेंशन नहीं था. See, of all the options which I have got, तो उसमें तो सबसे पहले हाइपोटोनिया इसलिए फिगर आउट करता है क्योंकि आप नोटिस करो इधर हमने देखा था द प्रेजेंस ऑफ न्यूरोलॉजिकल मैनिफेस्टेशंस. सो न्यूरोलॉजिकल मैनिफेस्टेशंस में आपका हाइपोटोनिया होता है. हाइपोटोनिया इज बोथ सेंट्रल एज वेल एज पेरिफेरल. क्यों होता है हाइपोटोनिया? बिकॉज ऑफ डिक्रीज ब्लड सप्लाई टू द डिक्रीज ऑक्सीजनेटेड ब्लड सप्लाई टू द मसल्स, एज वेल एज बिकॉज ऑफ द सिवियर CNS डिसफंक्शन विच अकम्पनीज पेरीनेटल एस्फिक्सिया. सो ये दो रीजंस होते हैं, एंड दैट इज वाई हाइपोटोनिया इज वन ऑफ द मार्कर ऑफ ऑल द थिंग्स जो कि हमें रिकॉल में मिला है. इसमें बेस्ट ऑप्शन तो हाइपोटोनिया ही रहेगा. ठीक है, तो चलते हैं अब आगे. ओके, देन लेट अस सी व्हाट एल्स. So now let us move forward with the next question. Next question क्या होगा देखें ज़रा. नेफ्रोटिक सिंड्रोम, which of the following marker is increased in serum electrophoresis. So आपको पता होना चाहिए कि नेफ्रोटिक सिंड्रोम में there is loss of low molecular weight proteins, and इसलिए high molecular weight proteins हमको देखने को मिलेंगे, and इसमें हमारा alpha-2 globulin आंसर होगा. अगर आप इसका इलेक्ट्रोफोरेसिस का पिक देखो, दिस इज नॉर्मल इलेक्ट्रोफोरेसिस. अगर आप देखो ये जो पीक है ये एल्ब्यूमिन की है, और अल्फा-2 ग्लोबुलिन की हार्डली एनी पीक है, थोड़ा गामा ग्लोबुलिन की पीक रहती है. ठीक है, यहाँ पे अगर आप देखो तो एल्ब्यूमिन की पीक है, ठीक है, बट डेफिनेटली इससे कम है. इससे मतलब आपके नेफ्रोटिक, दिस इज नेफ्रोटिक सिंड्रोम का इलेक्ट्रोफोरेसिस, एंड हियर यू कैन सी द अल्फा-2 ग्लोबुलिन इज मार्केटली पीक्ड एज कंपेयर टू द नॉर्मल वाला इलेक्ट्रोफोरेसिस. सो यहाँ पे आंसर आएगा आपका अल्फा-2 ग्लोबुलिन, दैट इज इंक्रीज्ड ऑन सीरम इलेक्ट्रोफोरेसिस, राइट. सो द करेक्ट आंसर इज गोइंग टू बी द डी ऑप्शन. ओके, नेक्स्ट क्वेश्चन देखते हैं. चाइल्ड विद अक्यूट रेस्पिरेटरी डिस्ट्रेस, व्हाट वी शुड नॉट डू. अगेन देखो बच्चों, इसमें what I can see is, just a minute, am I seeing any chat? I am not seeing. Okay, so what I am seeing over here is the child with acute respiratory distress, what we should not do. See, given the options, मुझे फोर्थ ऑप्शन नहीं मिला. अगर आपके पास फोर्थ ऑप्शन है तो प्लीज़ मुझे बताओ कि क्या और ऑप्शंस इसमें आए थे. ऑफ ऑल द ऑप्शंस व्हाट वी कैन गैदर, इसमें से अगर बेस्ट ऑप्शन आपने नहीं करना है इन अ चाइल्ड विद रेस्पिरेटरी डिस्ट्रेस होगा बैग एंड मास्क वेंटिलेशन. देखो, बैग एंड मास्क वेंटिलेशन विल बी इंडिकेटेड व्हेन द चाइल्ड इज गोइंग इनटू रेस्पिरेटरी फेलियर. अक्यूट रेस्पिरेटरी डिस्ट्रेस में यूजुअली जो रेस्पिरेटरी रेट होगा वो इंक्रीज रेस्पिरेटरी रेट होगा, और उस टाइम बैग एंड मास्क वेंटिलेशन इन तीनों में से तो बहुत ज़्यादा अच्छा ऑप्शन नहीं रहेगा. लेट अस लुक एट द अदर ऑप्शंस, क्यों वो ज़्यादा बेटर रहेंगे. सी, इंक्रीज इन पीप प्रेशर विल डेफिनेटली बी हेल्पफुल. व्हाट इज पीप? इफ आई हैव टू राइट, पीप इज पीक एंड expiratory pressure. So this pressure, when we deliver, it helps us in recruiting the collapsed alveoli, and plus it also helps in preventing the collapse of the alveoli at the end of the expiration. So that means अगर बच्चे को respiratory distress है जिस भी कारणवश, ठीक है, वो अपने accessory muscles यूज़ कर रहा है, तो पीप देने से क्या होगा, थोड़ा बहुत alveolar ventilation बढ़ जाएगा, बिकॉज हम नए नए alveoli रिक्रूट करना चाहेंगे, और जो ऑलरेडी रिक्रूटेड है उनको collapse नहीं हो, इसलिए पीप काम में आता है. सो दिस इज़ अ वेरी गुड ऑप्शन कि ठीक है हम ये हम ये ए ऑप्शन तो करेंगे. What about the third option? Of course, you would like to increase the oxygen delivery across the alveoli. जो भी alveoli बचे हुए काम कर रहे हैं, बाकी diseased alveoli है, respiratory distress शायद इसी वजह से है, ठीक है. तो इस वजह से आप चाहोगे कि जो भी alveoli काम करें उसके थ्रू हमारा ऑक्सीजन अच्छे से अच्छा क्वांटिटी ऑफ ऑक्सीजन जाए इनसाइड द alveolar air, ताकि वो हमारे गैस एक्सचेंज में ब्लड में पहुंच जाए गैस एक्सचेंज के द्वारा. तो इस वजह से हम बोलेंगे कि ऑक्सीजन थ्रू नेजल ट्यूब भी हम देना चाहेंगे. So what we would not like to give at here is bag and mask ventilation. At least इन तीनों में से तो यही चीज़ निकल के आ रही है. But of course अगर कोई फोर्थ ऑप्शन है तो आप मुझे you can provide me with, and then we can see कि better option क्या होगा. Out of these three तो bag and mask ventilation would be more indicated in acute respiratory failure or in later part of respiratory distress, जब बच्चा थकने लग जाता है और वो respiratory failure में जाने लग जाता है. ठीक है. Okay, now let us come to the next question. Mother brings 9-month-old child. Respiratory rate is 48 per minute, and the child has fever but no chest retractions, and the child is diagnosed to have pneumonia. What is the next step in management? ठीक है. So next step in management अगर हम देखें इसमें, so बच्चों अगर ये प्रैक्टिकली हम देखें कि डे इन डे आउट वी सी सच सिनेरियो एज पीडियाट्रिशियंस. सो इम्पॉर्टेंट थिंग ओवर हियर इज, क्या 9 मंथ्स पे रेस्पिरेटरी रेट 48 पर मिनट अगर दी हुई थी, क्या वो सिग्निफिकेंट है? तो वो सिग्निफिकेंट नहीं है, बिकॉज यू शुड नो द कट ऑफ क्या हम कहते हैं. ट्रेडिशनली द कट ऑफ फॉर टैकेप्निया इज इक्वल टू और मोर देन 50 पर मिनट. कौन सी एज ग्रुप में? 2 to 12 मंथ्स में, और ये बच्चा हमारा 9 मंथ्स में. लेस देन 2 मंथ्स के लिए कट ऑफ 60 होती है, ठीक है. एंड 12 मंथ्स टू 5 ईयर्स तक कट ऑफ रहती है 40 पर मिनट. अगर 40 पर मिनट से ज़्यादा रेस्पिरेटरी रेट है तो टैकेप्निया कहेंगे, पर उसमें बच्चे की उम्र होनी चाहिए बिटवीन 1 ईयर टू 5 ईयर्स ऑफ एज, राइट. तो ये तो बच्चा हमारा 9 मंथ्स का है. एंड द कट ऑफ ओवर हियर टू क्लासीफाई द थिंग एज the respiratory rate as tachypnea is 50 per minute, more than equal to or more than 50 per minute. If the child, the respiratory rate given is 48 per minute, right, and with fever but no chest retraction, and इसमें बोला हुआ है child is diagnosed to have pneumonia. So what will now the question arises, pneumonia फिर कैसे हुआ? तो pneumonia is not always about respiratory distress. You can have chest findings in form of crepitations or rhonchi without the presence of increased respiratory rate, right? तो ऐसे में आप क्या करोगे? You can see that there are no danger signs. कोई tachypnea नहीं है, कोई retractions नहीं है, कोई refusal to feed नहीं है, कोई altered sensorium नहीं है, कोई stridor in a calm patient मेंशन नहीं है. तो अगर हमारे जनरल डेंजर साइंस नहीं हैं तो हॉस्पिटलाइजेशन की तो बात ही नहीं है. सो व्हाट वी वुड लाइक टू डू इज डेफिनेटली सेंड दिस चाइल्ड बैक होम विद ओरल मेडिकेशन, एंड प्रेफरेबली यहाँ ओरल मेडिकेशन में अगर एंटीबायोटिक्स लिखे होते तो बेटर ऑप्शन होगा ये. तो ओरल एंटीबायोटिक्स पे आप इस बच्चे को घर भेज दोगे, ठीक है. नो ट्रीटमेंट नीडेड. सी सिंस इट इज मेंशन दैट द चाइल्ड इज डायग्नोज्ड टू हैव निमोनिया, सो आई विल नॉट से नो ट्रीटमेंट नीडेड, राइट. तो एक तो ये चीज़ आपको पता होनी चाहिए, राइट. अच्छा, उसके अलावा व्हाट एल्स इज देयर इज कि What about the first two options? तो हॉस्पिटलाइजेशन जैसे मैंने बताया आपको आउट ऑफ क्वेश्चन है. स्पेशली द सेकेंड ऑप्शन, हॉस्पिटलाइज द चाइल्ड एंड गिव ओरल एंटीबायोटिक्स. इफ यू हैव टू गिव ओरल एंटीबायोटिक्स दैट मीन्स द चाइल्ड इज एबल टू टेक ओरली, सेंसोरियम इज इंटैक्ट, तो आप हॉस्पिटलाइज ही क्यों करोगे? तो सेकेंड ऑप्शन का तो कोई सेंस ही नहीं बनता, राइट. अब ये तो हुई जनरल बात. अगर हम IMNCI के हिसाब से देखें, बिकॉज आई डोंट नो वेदर दिस क्वेश्चन केम अकॉर्डिंग टू IMNCI और नॉट. तो अगर हम IMNCI जो इंटीग्रेटेड मैनेजमेंट ऑफ न्यूनेटल एंड चाइल्डहुड इलनेसेस के जो प्रोटोकॉल्स हैं, हाउ टू मैनेज चिल्ड्रन विद निमोनिया, नाउ दीज प्रोटोकॉल्स आर फॉर द ग्रास रूट लेवल वर्कर्स हु आर नॉट क्वालिफाइड एज डॉक्टर्स, राइट. उनके लिए कुछ बहुत ज़्यादा सिंप्लीफाइड वर्जन दे रखा है. तो अगर हम वो देखें, सो सिंस द चाइल्ड इज़ 9 मंथ्स ऑफ एज, ठीक है, हमारे बच्चे का एज है 9 मंथ्स. सो चाइल्ड एज 2 मंथ्स टू 5 ईयर्स में अगर हम देखें, हमारे 3 ऑप्शंस आते हैं. नो निमोनिया होता है, निमोनिया या सिवियर निमोनिया या वेरी सिवियर डिजीज. यहाँ पे ध्यान ये रखना है, देयर इज नो टर्म एज वेरी सिवियर निमोनिया. ईदर इट इज वेरी सिवियर डिजीज और देयर इज सिवियर निमोनिया. ना हाउ डू यू क्लासीफाई? तो अगर हम इससे देखें तो नो साइंस ऑफ फास्ट ब्रीदिंग और चेस्ट इन ड्रॉइंग, तो ये कफ और कोल्ड है और इसमें आप कुछ नहीं करोगे, बच्चे को घर भेज दोगे, विद एडवाइज द मदर टू टेक होम केयर एंड कम बैक आफ्टर 5 days. अब सेकेंड ऑप्शन अगर आप देखो, इसमें अगर बच्चे को फास्ट ब्रीदिंग और चेस्ट इंड्रॉइंग है तो ही निमोनिया क्लासिफाई होता है। तो जैसे मैंने बताया, ये जो गाइडलाइंस हैं ये ग्रास रूट लेवल वर्कर्स के लिए बच्चों, ये हम MBBS डॉक्टर्स के लिए नहीं है, हमारे ग्रास रूट लेवल वर्कर्स के लिए। तो इस वजह से इसमें बहुत ही क्लियर कट बोला हुआ है कि अगर फास्ट ब्रीदिंग या चेस्ट इंड्रॉइंग है तो हम तभी निमोनिया बोलेंगे, नहीं तो नहीं बोलेंगे, क्योंकि ये तो विजुअल इंस्पेक्शन से किसी भी लेवल वर्कर को, ग्रास रूट लेवल वर्कर को पता चल जाएगा। तो इसमें है गिव ओरल amoxicillin for 5 days and relieve the cough by some the home treatment and advise mother to return within the 3 days. And of course the severe pneumonia will be when the child is having these danger signs, right? तो इसमें तो you have to give the first dose of IV antibiotic then and there and refer urgently to the hospital because this child requires hospitalized care, right? So I hope this is very clear कि क्योंकि इसमें एक तो निमोनिया लिखा हुआ है एंड रिट्रैक्शंस या चेस्ट इंड्रॉइंग नहीं है, तो हमने क्या किया है, इसको ओरल एंटीबायोटिक पे घर भेज दिया है। ठीक है, चलो तो ये हमारा करेक्ट आंसर हो जाएगा। चलो नेक्स्ट देखें हम ज़रा। So Sub-Zero is telling me question was every parameter like eating etc of child was normal, diagnosis and management पूछा था। ठीक है, so diagnosis and management पूछा था। So अगर okay, if you are saying this with reference to pneumonia, I know there is lag। तो देखो अगर डायग्नोसिस नहीं दिया है निमोनिया का, सो आई कैन चेंज दिस क्वेश्चन राइट नाउ। सो अगर डायग्नोसिस नहीं दिया है निमोनिया का और बच्चे का रेस्पिरेटरी रेट 48 पर मिनट दिया है, फीवर दिया है, पर कोई चेस्ट रिट्रैक्शंस नहीं है, मतलब दिस चाइल्ड इज नॉट हैविंग नो टेकिपनिया। ठीक है, इफ आई हैव टू राइट इट डाउन, इज नॉट हैविंग एनी चेस्ट रिट्रैक्शंस। ठीक है, राइट, ये दोनों चीज़ें हैं, और 9 मंथ ओल्ड का चाइल्ड है जिसको कि फीवर करके बच्चा आया है। तो अगर इसमें डायग्नोसिस और मैनेजमेंट पूछा है बच्चा, तो फिर इसमें नो निमोनिया ही बोलेंगे। IMNCI के हिसाब से आप देखो तो इस बच्चे में आता है नो निमोनिया, नो साइंस ऑफ फास्ट ब्रीदिंग और चेस्ट रिट्रैक्शन, तो इसमें नो निमोनिया ही बोलेंगे। एंड इसमें फिर आपका आंसर आ जाएगा नथिंग टू बी डन। ठीक है, सेंड द चाइल्ड बैक, नो ट्रीटमेंट टू बी नीडेड। ठीक है, फिर इसका आंसर डी हो जाएगा। बट देन यू हैव टू टेल मी, अगर ये वाला सिनेरियो था जिसमें आपसे पूछा गया था कि डायग्नोसिस क्या है एंड मैनेजमेंट क्या है, तो डायग्नोसिस इस बच्चे का नो निमोनिया हो जाएगा, क्योंकि अगर आप देखो कि इसमें न चेस्ट रिट्रैक्शंस हैं और न ही सिर्फ फीवर है, फीवर इज पॉजिटिव एंड नो चेस्ट रिट्रैक्शंस और नो टैकेपनिया, तो फिर ये बच्चा नथिंग कफ कोल्ड वाली कैटेगरी में आता है। एंड यू विल नॉट डू एनीथिंग, जस्ट कॉल द चाइल्ड बैक आफ्टर 5 days। ठीक है, सो आई कैन आई हैव जस्ट मॉडिफाइड द क्वेश्चन अकॉर्डिंग टू जो भी ऑप्शंस थे, तो आपको अब करेक्ट आंसर पता लग गया होगा। ठीक है, चलो आगे चलते हैं। Child with 3 days of watery diarrhea, vomiting and altered sensorium presented to OPD. All of the following can be included in differential diagnosis except. So this is a classic PYQ। अभी आपकी जो लास्ट INI-CET एग्जामिनेशन हुआ था उसमें सेम क्वेश्चन आया था, सेम ऑप्शंस थे। ठीक है, सो दिस इज अ PYQ क्वेश्चन दैट हैज़ बीन रिपीटेड within 6 months। तो इसमें हम क्या सोचेंगे, तो देखो डायरिया, वाटरी डायरिया, वॉमिटिंग एंड ऑल्टर्ड सेंसोरियम अगर है तो हाइपोनेट्रीमिया, ठीक है, दिस इज वन ऑफ द कॉम्प्लिकेशंस ऑफ वाटरी डायरिया। सिवियर डिहाइड्रेशन, यस हो सकता है, आपको पता है बच्चा लूज कर रहा है, अपर पार्ट से वॉमिटिंग से भी लूज कर रहा है, अपर GIT से और लोअर GIT से इन फॉर्म ऑफ वाटरी डायरिया भी लूज कर रहा है, तो सीवियर डिहाइड्रेशन हो सकता है। सेरेब्रल वेन ऑक्लूजन या सेरेब्रल वेन थ्रोम्बोसिस जिसे हम कहते हैं, तो उसकी परफेक्ट सेटिंग है जब बच्चा सीवियर डिहाइड्रेशन में होता है, तो सेरेब्रल वेन थ्रोम्बोसिस इज और सेरेब्रल वेन ऑक्लूजन इज अ नोन कॉम्प्लिकेशन। एंड वी नो दैट ऑल दीज 3 जो कंडीशंस हैं दे लीड टू व्हाट्स ऑल्टर्ड सेंसोरियम, राइट। तो ये सारे अगर कोई बच्चा मेरा वाटरी डायरिया, वॉमिटिंग एंड ऑल्टर्ड सेंसोरियम में आता है, तो वी हैव टू think these 3 differential diagnosis for sure। Now the big question arises, मैम HUS का क्या करें। तो HUS का बच्चों आपको पता होना चाहिए कि HUS 3 days की हिस्ट्री में नहीं होता, दिस इज़ वेरी क्लियर। अराउंड 7 days to 10 days की हिस्ट्री होती है, एंड वो भी वेरी स्पेसिफिकली HUS में आपको मिलेगी ब्लडी डायरिया की हिस्ट्री और डिसेंट्री जिसे हम कहते हैं, तो ब्लडी डायरिया की हिस्ट्री मिलेगी। अगर आपसे वो HUS का डायग्नोसिस चाहता है, तो वो आपको कुछ अनीमिया भी बोलेगा, बिकॉज इसमें क्लासिकली माइक्रो एंजियोपैथिक हेमोलिटिक अनीमिया होता है और इसमें क्लासिकली लो प्लेटलेट्स होते हैं। और इसमें एक और चीज़ होती है, दैट इज रीनल फेलियर, डिक्रीज यूरिन आउटपुट या अनूरिया या ओलिग्यूरिया, एनीथिंग कैन बी HUS कैन प्रेजेंट विद. व्हाट अबाउट ऑल्टर्ड सेंसोरियम? क्या ऑल्टर्ड सेंसोरियम HUS में होता है? बिल्कुल जी होता है. आपको पता होना चाहिए HUS में 2 ऑर्गन्स मेजर अटैक पे होते हैं. कौन से 2 ऑर्गन्स? एक होता है किडनी, ठीक है, और दूसरा होता है ब्रेन. दोनों ऑर्गन्स के जो माइक्रोवैस्कुलेचर होते हैं वो अंडर अटैक होते हैं. इट इज़ अ काइंड ऑफ ऑटोइम्यून डिसऑर्डर टाइप्स उस टाइम डेवलप हो जाता है, ठीक है. एंड इसकी वजह से जो माइक्रो कैपिलरीज होती हैं उसमें थोड़े थोड़े थ्रोम्बोसिस बनने लग जाते हैं, एंड दैट इज़ वाई दीज 2 ऑर्गन्स आर अंडर. ऑटोइम्यून तो नहीं बोलो, ठीक है, आई टेक माई वर्ड्स बैक, डोंट कंसिडर इट एज ऑटोइम्यून, बट yes, microangiopathic hemolytic anemia इसलिए होता है because RBCs when they traverse through these capillaries which are under attack, तो they get deformed and they get hemolyzed, right? तो किडनी और ब्रेन ये 2 होते हैं, इसकी वजह से ऑल्टर्ड सेंसोरियम तो देखा जाता है. बट यहाँ पे हम HUS को सिंगल आउट कर देंगे. आपका आंसर यहाँ पे HUS ही होना चाहिए because of the reason that the history given is too short and we are not having any history of bloody diarrhea or low platelets or something suggestive of low platelets or renal failure. तो इसकी वजह से यहाँ पे odd man out HUS हो जाता है. बट remember altered sensorium तो HUS में भी पाया जाता है, ठीक है. So this is your classical this thing, ठीक है. Okay, so Dr. Suhotra Chatterjee is telling me, ma'am, scenario was same, but in option A and C में pneumonia था. देखो बच्चों, अगर मैं अगेन आई एम कमिंग टू दैट क्वेश्चन, आई न्यू कि इसमें ना, क्योंकि बिकॉज इवन आई वॉज नॉट वेरी हैप्पी गेटिंग द रिकॉल इन दिस केस बिकॉज थिंग्स वर वेरी कॉन्ट्रोवर्शियल ओवर हियर, ठीक है. बट एनीवेज इसमें बेटा अगर आपको डायग्नोसिस निमोनिया का नहीं दिया गया है और यही सिनेरियो है जिसमें कि बच्चे को सिर्फ फीवर है एंड आपको ऑप्शन को एंड आपको क्वेश्चन को एनालाइज करना है कि 48 पर मिनट वाली रेस्पिरेटरी रेट को हम एट 9 मंथ्स क्या जज करें, तो आप नो टैकिपनिया जज करोगे. तो उसको टैकिपनिया नहीं है और इन्होंने बोला है नो चेस्ट रिट्रैक्शंस, ठीक है. एंड इस बच्चे को क्या है, सिर्फ और सिर्फ फीवर है. तो मैं इसको फिर कफ और कोल्ड बना करके उसको कुछ नहीं देंगे, नो एंटीबायोटिक्स एंड टू बी सेंट होम, ठीक है. दिस इज योर क्लासिकल. फिर उन्होंने IMNCI ही प्रोटोकॉल पे शायद पूछा है. अगर उन्होंने कुछ लिखा है कि नहीं वॉज डायग्नोज्ड एज निमोनिया, देन मैंने आपको उसके बारे में एक्सप्लेनेशन समझा दी है, ठीक है. आई होप दिस इज वेरी क्लियर, डोंट गेट कंफ्यूज. दिस इज स्ट्रेट अवे IMNCI प्रोटोकॉल पे हर साल क्वेश्चन ज़रूर आता है. सो आई वाज एक्सपेक्टिंग द सेम ओवर हियर एंड वही चीज़ आई है जैसे कि आप लोग मुझे इनपुट्स दे रहे हो. सो लेट अस मूव फॉरवर्ड टू द नेक्स्ट क्वेश्चन. ओके, सो एक क्वेश्चन आया था, हेड SS असेसमेंट इज डन फॉर, ये क्या चीज़ है. सो येस, दिस इज डन फॉर अडोलेसेंट्स. अब ये किस चिड़िया का नाम है देख लेते हैं ज़रा. सो दिस इज एन इंटरव्यू इंस्ट्रूमेंट फॉर फाइंडिंग आउट अबाउट इशूज़ इन द लाइव्स ऑफ अडोलेसेंट्स, ठीक है. तो अडोलेसेंट एज ग्रुप में हम ये असेसमेंट करते हैं, क्वेश्चनेयर के रूप में होता है ये, एंड वाज डेवलप्ड बाय सम मिस्टर कोहेन एंड हिज कलीग्स. एंड हेड SS का एक प्रॉपर निमोनिक बना हुआ है. व्हाट डज इट स्टैंड फॉर? सो H स्टैंड्स फॉर इंक्वायरिंग द अडोलेसेंट अबाउट हिज होम एनवायरनमेंट, भाई कितने लोग हैं, क्या करते हैं, ठीक है, ऑल दैट स्टफ. देन E इज़ फॉर एजुकेशन एंड एम्प्लॉयमेंट. A इज़ फॉर व्हाट एक्टिविटीज़ डज ही इंडल्ज इन, क्या हॉबीज़ हैं, क्या करता है अपने फ्री टाइम में, स्पोर्ट्स खेलता है कि नहीं, कौन से स्पोर्ट्स खेलते हैं, ऑल दैट क्वेश्चंस, सेट ऑफ क्वेश्चंस विल कम अंडर एक्टिविटीज़. D से आता है ड्रग्स. ड्रग्स में हम हिस्ट्री लेंगे कि भाई उसका पीयर एज ग्रुप में वो खुद क्या ड्रग्स लेता है या उसके पीयर एज ग्रुप में कोई ड्रग्स लेता है या उसकी फैमिली में कोई ड्रग्स लेता है. एंड ड्रग्स में इसमें अल्कोहल इंटेक भी इंक्लूडेड होती है, ठीक है. सो ड्रग्स इसमें आ जाएगा. देन S स्टैंड्स फॉर सेक्सुअलिटी, ठीक है. ऑफकोर्स इफ ही इज सेक्सुअली एक्टिव और नॉट, मल्टीपल पार्टनर्स हैं, सिंगल पार्टनर है, डज ही यूज प्रोटेक्शन और नॉट, ऑल दैट हिस्ट्री वुड कम अंडर सेक्सुअलिटी. एंड ऑफकोर्स व्हाट आर हिज प्रेफरेंसेस, राइट, सेम सेक्स और द ऑपोजिट सेक्स. एंड S कम्स फॉर सुसाइड और डिप्रेशन. सो suicidal tendencies है कि नहीं, have you ever thought of such thing, what gets you, what makes you very sad, this ये सारी questionnaire इसमें आती है. So this head SS, this is done for adolescent. इसका correct answer adolescent आएगा. समझ में आ गया, ठीक है. चलें आगे. ओके, देन नेक्स्ट इज मैनेजमेंट ऑफ डीके. व्हाट इज फॉलोड? सो दिस इज अगेन योर टिपिकली रिपीटेड PYQ। आपके लास्ट INI-CET में भी उन्होंने प्रॉपर इस्पात प्रोटोकॉल लिख करके पूछा था कि हमने कैसे डीके मैनेज करना है। तो अगर आपने वीडियोस देखे हैं हमारे, तो हमने अच्छे से अपने NExT के वीडियो में डिस्क्राइब कर रखा है पीडियाट्रिक एंडो वाले चैप्टर में हाउ टू मैनेज डीके। तो चलो ये देख लेते हैं ज़रा। सो इसमें एक ऑप्शन था स्टैट डोज ऑफ इंसुलिन, आई होप दे आर टॉकिंग अबाउट इंसुलिन, गिवन फॉलोड बाय रेगुलर इन्फ्यूजन ऑफ इंसुलिन 0.1 यूनिट पर केजी पर आवर होता है ये विद IV फ्लूइड्स। ठीक है, और बेटर देख लेते हैं इन्फ्यूजन ऑफ रेगुलर इंसुलिन 0.05 यूनिट्स पर केजी 2.1 यूनिट पर केजी पर आवर आफ्टर 1 hour of IV fluids, and third is bolus subcutaneous insulin given, और D कोई और ऑप्शन होगा जो कि हमको नहीं मिला। सो अगर इसमें देखें बच्चों, आपको सीधा सीधा इस्पात प्रोटोकॉल पूछा गया है, और इस्पात प्रोटोकॉल से पहले हम फॉलो करते थे समथिंग नोन एज मिल्वाउकी प्रोटोकॉल। दोनों ही प्रोटोकॉल्स में एक कॉमन चीज़ होती है जो आपको समझना है, एंड दैट कॉमन चीज़ इज़ कि दोनों ही में सबसे पहले जब डीके में बच्चा आता है, अगर शॉक में आया है, तो आपको ABC तो मैनेज करना है सबसे पहले। सो फर्स्ट आवर ऑफ थेरेपी इज़ फॉर ABC रिससिटेशन। ठीक है, सो एयरवे, ब्रीदिंग, सर्कुलेशन। यूजली ये बच्चे शॉक में आते हैं, तो आपने उनको बोलस देना होता है, नॉर्मल सलाइन का बोलस देना होता है। कितना बोलस? 10 to 20 ml पर केजी। अगर सीवियर डिहाइड्रेशन में तो 20 ml पर केजी का बोलस देंगे, अगर मॉडरेट डिहाइड्रेशन में तो 10 ml पर केजी का बोलस देंगे। एक बोलस दे करके फिर आपको रीअसेस करना होता है, हो सकता है आपको दूसरा बोलस भी देना पड़े। ठीक है, डिपेंडिंग ऑन कि पल्सेस आ गई, कि पल्स पैल्पेबल है कि नहीं है। तो फर्स्ट आवर इज डेडिकेटेड टू ओनली एंड ओनली रिससिटेशन। ये हमने लास्ट INI-CET रिकॉल में भी डिस्कस किया था। ठीक है, सेकेंड आवर ऑनवर्ड्स ही इंसुलिन की कहानी शुरू होती है। ठीक है, अब आप बोलोगे कि मैम आते ही आपको पता है डीके है, उसका ब्लड शुगर वुड बी हिटिंग द स्काई, कुछ 550-600 मिलीग्राम पर डेसीलीटर उसका ब्लड शुगर होगा, तो आप इंसुलिन के लिए देर क्यों कर रहे हो, 1 घंटे की भी देर क्यों कर रहे हो? तो बच्चों पहले आप ये समझो, आप इंसुलिन दे भी दोगे तो कौन सा टारगेट ऑर्गन्स पे पहुंच जाएगी, बिकॉज उसका बच्चे का सर्कुलेशन ही इस्टेब्लिश नहीं है। तो इसीलिए हम कहते हैं कि इंसुलिन कभी भी फर्स्ट आवर में नहीं देना होता है। और भी कई सारी चीज़ें होती हैं कि इंसुलिन क्यों नहीं देना होता है, एंड वेरी इंपॉर्टेंटली सबक्यूटेनियस इंसुलिन तो बिल्कुल ही नहीं देना होता है। ठीक है, जैसे कहते हैं एक तो बोलस नहीं देना और सबक्यूटेनियस, दोनों ही चीज़ें नहीं देनी होती। क्यों नहीं देनी होती अभी आपको बताते हैं। तो ये आपका इस्पात प्रोटोकॉल है। सो इस्पात प्रोटोकॉल में अगर आप देखो कि मॉडरेट और ग्रेटर डिहाइड्रेशन में जब बच्चा आया है, तो आप सबसे पहले IV थेरेपी अगर इसमें देखें, हम देखो सलाइन दे रहे हो आप 10 to 20 ml पर केजी में, रिपीट, कैलकुलेट फ्लूइड रिक्वायरमेंट, एंड देन यू नेक्स्ट आवर, सेकेंड आवर ऑनवर्ड्स, ये सेकेंड आवर ऑनवर्ड्स है, यू कंटिन्यूस IV इंसुलिन इन्फ्यूजन शुरू करते हो 0.05 to 0.1 यूनिट पर केजी पर आवर के हिसाब से। ठीक है, स्टार्टिंग इसमें बहुत क्लियरली लिखा है, स्टार्टिंग 1 hour आफ्टर IV फ्लूइड्स इज इनिशिएटेड। ठीक है, तो ये बहुत क्लियर होना चाहिए। सेम चीज़ हम लोग सीवियर में भी करते हैं, जिसमें भी आपको ऑब्वियसली यू हैव टू लुक फॉर, अगर सीवियर डिहाइड्रेशन में आया हुआ है तो आपको ज़्यादा अच्छे से रिससिटेशन करने की ज़रूरत पड़ेगी। ठीक है, अब क्वेश्चन जो था कि मैम क्यों नहीं देते हैं, तो कि हमको याद रहे, तो कुछ मैनेजमेंट प्रोटोकॉल, मैनेजमेंट पर्ल्स हैं हमारे डीके के जो आपको याद रखना है। सबसे पहले कंटिन्यूड IV इन्फ्यूजन ऑफ इंसुलिन इज प्रेफर्ड। अभी हमने ये नहीं बोला कब, पर आपको अब पता पड़ गया, आफ्टर फर्स्ट आवर ऑफ रिससिटेशन। ठीक है, बाद में भी आएगा ये। नो रोल ऑफ इनिशियल इंसुलिन बोलस, नो रोल ऑफ सबक्यूटेनियस इंसुलिन। वाई? बिकॉज आपको पता होना चाहिए कि सबक्यूटेनियस इंसुलिन का भी एब्जॉर्प्शन काफ़ी पुअर रहेगा इन द सेटिंग ऑफ पुअर परफ्यूजन। जब बच्चे की पल्सेज ही नहीं है, तो चाहे आप IV इंसुलिन दो, जब चाहे सबक्यूटेनियस इंसुलिन दो, ठीक है, आपके इंसुलिन का एब्जॉर्प्शन ही नहीं रहेगा। तो इसीलिए आपने सबक्यूटेनियस इंसुलिन भी नहीं देनी है। नाउ इंसुलिन शुड बी एडेड ओनली आफ्टर इनिशियल हाइड्रेशन। वाई? तो 3 रीजंस होते हैं इसके। बिकॉज अगर आपने इनिशियली दे दी इन द फर्स्ट आवर इटसेल्फ, देयर विल बी ड्रास्टिक फॉल इन प्लाज्मा ऑस्मोलैलिटी। अब आप बोलोगे मैम इससे क्या होगा, हो जाए प्लाज्मा ऑस्मोलैलिटी में फॉल, हम तो चाहते हैं कि शुगर फॉल हो जाए। नहीं बच्चों, डीके का मैनेजमेंट का एक सबसे इम्पॉर्टेंट आस्पेक्ट ये है कि जो मैनेजमेंट होता है, जो इंसुलिन इन्फ्यूजन होता है, जो फॉल ऑफ हम शुगर करवाते हैं, वो बहुत ही ग्रेजुअल ओवर 24 to 36 आवर्स में करवाते हैं। अगर आपने रैपिडली फॉल करवा दिया, जैसे कि यहाँ करवाया, बच्चे को हो जाएगा सेरेब्रल एडिमा, एंड दिस इज वन ड्रेडेड कॉम्प्लिकेशन ऑफ डीके. डीके से शायद बच्चा नहीं मरे, बट सेरेब्रल एडिमा से ज़रूर ही विल बी इन अ फेटल पोजिशन. सो दैट इज़ वाई वी हैव टू गिव इंसुलिन वेरी वेरी स्लोली, एंड वी हैव टू इंश्योर दैट देर इज़ नो रैपिड फॉल ऑफ ब्लड शुगर. दिस. सेकेंडली, अगर आपने इंसुलिन फर्स्ट आवर इटसेल्फ में दे दिया तो अगेन हाइपोकैलिमिया का रिस्क रह जाता है, बिकॉज इंसुलिन विल कॉज शिफ्ट ऑफ पोटेशियम इंट्रासेलुलरली. तो आपने नोटिस किया होगा जब आपने इस्पात प्रोटोकॉल देखा था तो उसमें आपको बताया गया था कि आपको जब सेकेंड आवर ऑनवर्ड जब आप फ्लूइड शुरू करते हो तो एक ड्रिप पे आप इंसुलिन शुरू करोगे, रेगुलर इंसुलिन, डोज बता दी गई थी आईवी, एंड सेकेंड ड्रिप में जो आप फ्लूइड देते हो, मेंटेनेंस आईवी फ्लूइड, उसमें पोटेशियम भी ऐड करते हैं, बिकॉज वी नो दैट इंसुलिन शुरू करने से हाइपोकैलिमिया होने के चांसेस हैं. ऑफ कोर्स दिस चांसेस वुड इंक्रीज मोर इफ यू गिव इंसुलिन इन द फर्स्ट आवर ऑफ रिससिटेशन इटसेल्फ, राइट. तो इसलिए ये नहीं देते. देन और क्या हमारे इंपॉर्टेंट मैनेजमेंट प्रोटोकॉल्स हैं, दैट इन्फ्यूजन रेट जो इंसुलिन का है, दिस हैज़ टू बी रिड्यूस्ड ओनली आफ्टर रेजोल्यूशन ऑफ एसिडोसिस. आई नो सबके दिमाग में चलेगा, नहीं जी हम तो आईवी इंसुलिन बंद कर देंगे जैसे ही हाइपोग्लाइसीमिया की तरफ बच्चा अप्रोच करने लगेगा. नो, प्लीज रिमेंबर, एंड पॉइंट ऑफ insulin infusion is not resolution of hyperglycemia but resolution of acidosis. अब क्या करेंगे, अगर बच्चा हाइपोग्लाइसीमिया की तरफ जा रहा है और बच्चे का एसिडोसिस तो सही नहीं हुआ, तो आप उस जो मेंटेनेंस आईवी फ्लूइड आपने अलग से चालू किया है उसमें हम शुगर ऐड करने लग जाते हैं. तो यूजली व्हेन द ब्लड शुगर अप्रोचेस समथिंग लाइक 270 और 250 मिलीग्राम पर डेसीलीटर, देन वी स्टार्ट एडिंग शुगर टू द आईवी फ्लूइड्स सो दैट बिकॉज वी कैन नॉट स्टॉप इंसुलिन, क्योंकि हो सकता है बच्चे का पीएच अभी भी 7.1 पे हो और हमें पता है कि ये तो नॉर्मल पीएच नहीं है, तो ये तो अभी नॉर्मल होने में टाइम लगेगा. तो आप बच्चे को हाइपोग्लाइसीमिक नहीं होने दो, आप उसके मेंटेनेंस आईवी फ्लूइड्स में वी ऐड शुगर. ठीक है, सो वी हैड ग्लूकोज एंड दिस इज हाउ वी मैनेज, राइट. ओके, एंड डोज वी आई हैव ऑलरेडी टोल्ड यू 0.1 यूनिट पर केजी से शुरू करते हैं, 0.1 यूनिट पर केजी पर आवर. एंड अगर इन्फेंट्स और माइल्ड डीके है तो उसमें थोड़ा डोज हम कम कर सकते हैं, 0.05 यूनिट्स पर केजी पर आवर. सो आई होप दिस इज़ वेरी क्लियर कि हो सकता है जो यहाँ पे क्वेश्चन आपको दिखाया गया एग्जैक्टली वो वर्डिंग्स ना हो, बट देन यू नो अबाउट डीके एंड यू मस्ट बी नोइंग कि करेक्ट ऑप्शन क्या होगा. ठीक है, ओके. नेक्स्ट चलते हैं, विच ऑफ द फॉलोइंग इज नॉट सीन इन डाउन सिंड्रोम. क्या हाइपोथायराइडिज्म दिखता है? बिल्कुल जी दिखता है. हियरिंग लॉस, यू शुड नो दैट डाउन सिंड्रोम चिल्ड्रन दे आर एट रिस्क फॉर बोथ कंजेनाइटल और अक्वायर्ड हियरिंग लॉस. ठीक है, तो ये भी दिखता है. शॉर्ट स्टेचर में तो हम सबसे पहले सिंड्रोम में डाउन सिंड्रोम ही कंसिडर करते हैं. ठीक है, आपको अगर याद है, आपने अगर लेक्चर्स देखे हैं, हमने निमोनिक बनाया था TDS, द सिंड्रोमिक कॉजेज ऑफ शॉर्ट स्टेचर, जो 3 सिंड्रोमिक कॉजेज जो आपको बिल्कुल फॉरगेट नहीं करने हैं. एक है आपका टर्नर सिंड्रोम, D से है डाउन सिंड्रोम, और S से है सेकल सिंड्रोम. इफ आई हैव टू राइट SECKEL, सेकल सिंड्रोम. तो शॉर्ट स्टेचर भी होता है. तो क्या चीज़ नहीं होती? ऑफ कोर्स द ऑड मैन आउट इज द फोर्थ ऑप्शन. कॉर्डल रिग्रेशन सिंड्रोम इज द आंसर ओवर हियर. रिमेंबर, कॉर्डल रिग्रेशन सिंड्रोम is a complication or is a finding which you see typically in children who are infant of diabetic mothers. ठीक है, तो ये न्यूनेट में आपको पता नहीं चाहिए. इन्फेंट ऑफ डायबिटिक मदर में द मोस्ट कहते हैं स्पेसिफिक malformation indicative of infant of diabetic mother is caudal regression syndrome. ठीक है, तो इसमें ये caudal regression syndrome वहाँ देखने को मिलती है, डाउन सिंड्रोम में देखने को नहीं मिलती. ठीक है, तो ये आंसर होगा आपका. ओके, सो ये आपकी पूरी लिस्ट है फ्रॉम आवर बुक ऑफ नेल्सन की क्या क्या चीज़ें देखने को मिलती है. तो इसमें आप देख सकते हो कंजेनाइटल और अक्वायर्ड हियरिंग लॉस दिया हुआ है. इन बच्चों में सीरस ओटाइटिस मीडिया काफ़ी कॉमन होता है. ठीक है, इसको थोड़ा सा ठीक कर लेते हैं, जस्ट अ मिनट. ठीक है, तो दोनों चीज़ें इंक्लूड कर लेते हैं. तो सीरस ओटाइटिस मीडिया डेवलप होने के काफ़ी चांसेस होते हैं इन बच्चों में. ठीक है, सो एंड ऑफ कोर्स दीज चिल्ड्रन आर एट रिस्क फॉर डेवलपिंग congenital or acquired hearing loss. Of course, congenital or acquired hypothyroidism, these children have high incidence of thyroid dysgenesis. आपको ये भी पता होना चाहिए dysgenesis का क्या मतलब है. या तो थायराइड ग्लैंड एप्लास्टिक है, या हाइपोप्लास्टिक है, या एक्टोपिक है. तीनों में से कुछ भी हो सकता है डाउन सिंड्रोम में. ठीक है, एंड दूसरा शॉर्ट स्टेचर तो आपको बताया गया. एंड ऑफ कोर्स जैसे बताया गया, कॉर्डल रिग्रेशन सिंड्रोम इज अ फीचर ऑफ इन्फेंट ऑफ डायबिटिक मदर एंड नॉट डाउन सिंड्रोम. ठीक है, चलो नेक्स्ट करते हैं, फिर देखते हैं स्वेट क्लोराइड एंड पेनक्रियाटिक लेवल्स ऑफ क्लोराइड इन सिस्टिक फाइब्रोसिस आर। सो सिस्टिक फाइब्रोसिस तो बच्चों INI-CET का सबसे फेवरेट टॉपिक है, दिस यू शुड नो। ठीक है, ये तो हर जगह आपको देखने को मिलेगा। स्वेट क्लोराइड मतलब सिस्टिक फाइब्रोसिस हर INI-CET के एग्जाम में एक क्वेश्चन तो ज़रूर आता है। तो क्या होता है इसमें, तो ये देखने से पहले ऐसा करते हैं, जस्ट अ मिनट, सो लेट अस लुक एट दी, just a minute, let us look at some genetics and microbiology of ठीक है of cystic fibrosis. So mutation in the gene, you know CFTR gene होता है जो कि culprit gene होता है। CFTR का full form होता है, आपको पता है, cystic fibrosis transmembranous conductance regulator. So इसमें mutation होती है, मतलब ऐसा कोई जीन, ऐसा कोई ट्रांसपोर्टर जो कि क्लोराइड ट्रांसपोर्ट में इन्वॉल्व होता है, वो कल्प्रिट जीन होता है, और उसकी वजह से सिस्टिक फाइब्रोसिस के सारे लीजन्स या सारे के सारे मैनिफेस्टेशंस आते हैं। एक क्वेश्चन लास्ट INI-CET में सिंपल सा क्वेश्चन आता है कि कौन सा आयन का ट्रांसपोर्ट इसमें मैल फंक्शन करता है, तो उसमें आंसर वॉज क्लोराइड आयन। इस बार उन्होंने थोड़ा रिलेटेड क्वेश्चन दे दिया। नाउ द फेलियर ऑफ chloride conductance by the epithelial cells leads to the dehydration of secretions that are too viscid, viscid मतलब viscosity increase हो जाती है and difficult to clear, and we know that this defective gene encoding for CFTR, this CFTR membrane this thing transporter is located on chromosome 7। ठीक है, the most common mutation हमको पता है इस डेल्टा F508 कहते हैं हम, तो 508 पे पोजीशन पे फिनाइल एलानिन का डिलीशन होता है। ठीक है, ये हमारा, ये भी सारे ये आपके प्रीवियस ईयर क्वेश्चंस आए हुए हैं। अब इसमें देखें तो प्रॉब्लम क्या होती है, तो प्रॉब्लम अगर आप देखो, ये एयरवे ल्यूमन है, ठीक है, और ये आपका जो ये ट्रांसपोर्टर है, ठीक है, और इसमें क्या होता है कि क्लोराइड ऐसे जा रहा है और क्लोराइड के साथ साथ सोडियम भी आ रहा है। ठीक है, अब यहाँ पे क्या होता है, यहाँ पे क्या होगा देखें ज़रा, तो यहाँ पे सिस्टिक फाइब्रोसिस में व्हाट हैपन्स इज दैट देयर इज सम प्रॉब्लम अक्रॉस दी एपिथेलियल सेल्स, और उसकी वजह से क्या होता है कि क्लोराइड ट्रांसपोर्ट ठीक से नहीं हो पाता, और क्लोराइड ट्रांसपोर्ट ठीक से नहीं हो पाता मतलब क्लोराइड बहुत ज़्यादा जाता है और अपने साथ साथ सोडियम को भी वो ले जाता है, और सोडियम जब जाएगा तो आपको पता है वाटर भी साथ साथ जाएगा बिकॉज ऑफ ऑस्मोटिक इफेक्ट। तो आपके जो सिक्रीशंस, जो एयरवे ल्यूमन है, ये एयरवे ल्यूमन है, ठीक है, ये सब म्यूकोजल साइड है, तो इधर आ गया, अगर हमारे सोडियम क्लोराइड ज़्यादा अंदर की इंट्रासेलुलरली आ गया, सब म्यूकोजा की तरफ आ गया, तो आपके जो सिक्रीशंस होंगे ल्यूमन में वो डिहाइड्रेटेड हो जाते हैं, वो विदाउट वाटर हो जाते हैं, वो काफ़ी थिक हो जाते हैं, एंड वो वहाँ पे पड़े रह जाते हैं। उनको निकालना फ्रॉम द एयरवेज बड़ा मुश्किल हो जाता है, एंड वंस दे आर स्टक अप ओवर देयर, दे हार्बर, दे फॉस्टर द ग्रोथ ऑफ माइक्रो ऑर्गेनिजम्स, एंड इसी वजह से इन बच्चों को, स्पेशली ये कहाँ होता है, ये हम लंग्स की बात कर रहे हैं, पैनक्रियास की बात कर रहे हैं, हर जगह ये चीज़ होती है। ठीक है, बट यहाँ पे एक कहानी में ट्विस्ट आता है। कहानी में क्या ट्विस्ट है कि जो हमारा ये है, क्या कहते हैं, स्वेट ग्लैंड्स हैं, स्वेट ग्लैंड्स में क्या होता है कि एयरवे एपिथेलियम, यहाँ पे उल्टी चीज़ होती है, यहाँ पे जो एयरवे सेल्स में तो एक्सक्रीट नहीं होता क्लोराइड फ्रॉम सेल्स इनटू द ल्यूमन, ठीक है, और इसकी वजह से क्लोराइड हमारा ट्रैप हो गया, सोडियम फॉलो हो गया इसको, एंड सिक्रीशंस हमारे विस्केट हो गए। अब स्वेट ग्लैंड्स में क्या होता है, सेम CFTR है, और यहाँ पे क्या होता है, क्लोराइड कांट बी एब्जॉर्ब्ड, तो दैट मीन्स क्लोराइड कहाँ ज़्यादा रह जाता है, इनटू दी ल्यूमन ऑफ दी स्वेट ग्लैंड्स, और अगर क्लोराइड वहाँ पे रह रहा है तो सोडियम भी वहीं पे रहता है, और इस वजह से इन बच्चों का जब स्वेट, अगर आप जब इन बच्चों को किस करते हो तो इनको आपको सॉल्टी फीलिंग आएगी बिकॉज ऑफ द इंक्रीज सॉल्ट कंसंट्रेशन इन द स्वेट। तो आप क्या देख रहे हो, एक जगह जहाँ पे क्लोराइड को नॉर्मली सिक्रीट आउट होना चाहिए था, वहाँ सिक्रीट आउट नहीं हो रहा, वहाँ पे बिकॉज हमारा CFTR जीन जिसको सिक्रीट आउट करना था इनटू द एयरवे ल्यूमन, वो ठीक से नहीं कर रहा, उल्टा ही काम हो रहा है कि सोडियम क्लोराइड इंट्रासेलुलरली रिटेन हो रहा है। जो स्वेट ग्लैंड्स होते हैं उसमें क्या होता है कि आपका जो क्लोराइड और सोडियम होता है वो एब्जॉर्ब होना होता है, और वो एब्जॉर्ब नहीं होता, और वो ल्यूमन में पड़ा रह जाता है, इसलिए स्वेट की कॉन्सेंट्रेशन, स्वेट में सोडियम और क्लोराइड की कॉन्सेंट्रेशन इंक्रीज हो जाती है। तो जब ऐसे बच्चे को, जब आप किस करोगे सिस्टिक फाइब्रोसिस वाले बच्चे को, जिसमें जो कि स्वेटी हो रहा है, तो आपको सॉल्ट का टेस्ट आएगा, और ये ही डायग्नोस्टिक क्राइटेरिया होता है दैट इंक्रीज कंसंट्रेशन ऑफ सोडियम क्लोराइड इन दी स्वेट, दैट इज वन ऑफ द डायग्नोस्टिक क्राइटेरिया फॉर सिस्टिक फाइब्रोसिस, राइट। तो ये चीज़ होती है, और ये सिर्फ स्वेट ग्लैंड्स में होता है जहाँ पे इंक्रीज कंसंट्रेशन होती है, बाकी जगह डिक्रीज कंसंट्रेशन होगी, ये ध्यान रखना, ठीक है। तो पैनक्रियाज हो गया, लंग्स हो गया, या आपके रिप्रोडक्टिव ऑर्गन्स के ल्यूमन हो गए, सब में यही चीज़ होता है कि जो जो हमारे सिक्रीशंस होते हैं वो विस्किड और थिक हो जाते हैं, क्योंकि वहाँ पे सोडियम क्लोराइड एंड वाटर एज अ रिजल्ट का ठीक से सिक्रीशन इनटू द ल्यूमन नहीं हो पा रहा। आई होप दिस इज वेरी क्लियर। तो अब देखते हैं इसमें क्या प्रॉब्लम होगी। तो क्लोराइड कंसंट्रेशन इंक्रीज इन स्वेट, ये तो सही है, बट इंक्रीज इन पैंक्रियाटिक सिक्रीशन तो ये गलत हो गया, तो इसलिए हमारा ये वाला ऑप्शन नहीं है। क्लोराइड कंसंट्रेशन डिक्रीज इन स्वेट, ठीक है, एंड ये तो गलती है, तो आगे हम पढ़ेंगे ही नहीं। क्लोराइड कंसंट्रेशन इंक्रीज इन स्वेट, ये तो सही है, एंड डिक्रीज इन पैंक्रियाटिक सिक्रीशन, तो ये बिल्कुल आपका सही ऑप्शन है इफ दिस वाज द क्वेश्चन विच वाज गिवन। एंड क्लोराइड कंसंट्रेशन डिक्रीज इन स्वेट एंड इंक्रीज इन पैंक्रियाटिक सिक्रीशन, ये गलत है, तो हमारा करेक्ट ऑप्शन इसमें क्या होगा, सी ऑप्शन रहेगा, ठीक है। सो दिस इज इट। अब देखते हैं नेक्स्ट क्या है। अ चाइल्ड हैज फीचर्स ऑफ मेनिंजाइटिस विद फॉलोइंग CSF एग्जामिनेशन, बताओ जी डायग्नोसिस क्या है। आई होप दिस वाज द क्वेश्चन विच हैड कम इन योर एग्जाम, मुझे तो रिकॉल में ये मिला। तो अगर आप देखो, अगर हम इसके यूनिट्स डाल देते हैं, 63 मिलीग्राम पर डेसीलीटर होगा, 20 मिलीग्राम पर डेसीलीटर होगा, एंड लिम्फोसाइट्स प्रेजेंट है। तो क्या ये बैक्टीरियल मेनिंजाइटिस है? बच्चों, बैक्टीरियल मेनिंजाइटिस में यूजुअली आपके न्यूट्रोफिल्स देखने को मिलते हैं। हाँ, अगर आपको वो बहुत खींचना चाहे तो आपको पता होना चाहिए इनिशियल स्टेजेस में, या फिर इन पार्शली ट्रीटेड बैक्टीरियल मेनिंजाइटिस, जिसे हम PTPM कहते हैं, पार्शली ट्रीटेड पाइथोजेनिक मेनिंजाइटिस, उसमें हो सकता है लेटर ऑन स्टेजेस में आपको लिम्फोसाइट्स देखने को मिलते हैं। बट यहाँ पे हम क्यों बैक्टीरियल इसको नहीं कहेंगे, बिकॉज इसमें प्रोटीन्स तो इतने ज़्यादा एलिवेटेड नहीं है, ठीक है। नॉर्मल प्रोटीन लेवल 20 to 40 मिलीग्राम पर डेसीलीटर होता है हमारा CSF का, 40 से तो ज़्यादा है, पर इतना नहीं है जितना कि बैक्टीरियल मेनिंजाइटिस में होता है। तो बैक्टीरियल मेनिंजाइटिस हमारा आउट हो गया। ऑल्दो ग्लूकोज इसका काफ़ी कम है, पर आपको पता होना चाहिए ग्लूकोज का लेवल यूजुअली हम ब्लड शुगर के मुकाबले देखते हैं, तो हम कहते हैं जब CSF ग्लूकोज का लेवल लेस देन 2/3 ऑफ द ब्लड शुगर हो, तब हम सिग्निफिकेंट मानते हैं इस चीज़ को, ठीक है। तो वैसे यहाँ पे नहीं दिया हुआ है, बट एनीवेज लेट मी टेल यू, एनीथिंग लेस देन 40 मिलीग्राम पर डेसीलीटर ऑफ शुगर इज़ डेफिनेटली, मतलब ठीक है, ये हम सिग्निफिकेंट मानेंगे। बट ये फिर भी हमारा बैक्टीरियल मेनिंजाइटिस इसलिए नहीं क्लासीफाई करता, क्योंकि एक तो लिम्फोसाइट्स हैं, एंड सेकेंडली प्रोटीन्स उतने एलिवेटेड नहीं है। अब आप बोलोगे मैम पार्शली ट्रीटेड पाइथोजेनिक मेनिंजाइटिस में तो आप कह रहे हो लिम्फोसाइट्स हैं, और हो सकता है प्रोटीन भी नॉर्मलाइज होने लग जाए, बट प्लीज़ रिमेंबर प्रोटीन्स आर द लास्ट पैरामीटर टू बिकम नॉर्मल इन अ केस ऑफ मेनिंजाइटिस। तो प्रोटीन्स तो एलिवेटेड रहेंगे पार्शली ट्रीटेड में भी, ठीक है, तो इतने एलिवेटेड नहीं, तो इसलिए हमारा बैक्टीरियल आउट हो गया। क्या ये ट्यूबरकुलर है? तो ट्यूबरकुलर हमारा मन तो कर रहा है ये ट्यूबरकुलर है, क्यों? क्योंकि लिम्फोसाइट्स हैं, ट्यूबरकुलर में होते हैं, और ग्लूकोज भी लो है, ठीक है जी, थोड़ी बहुत होती है। बट प्लीज़ रिमेंबर, ट्यूबरकुलर मेनिंजाइटिस में जो प्रोटीन्स होते हैं वो बहुत ज़्यादा इंक्रीज होते हैं, 500 to 1000 मिलीग्राम पर डेसीलीटर। अगर आपको याद है, इसमें हम बोलते हैं कि इफ़ वी कीप द CSF in a test tube untouched in a vertical position, what do we see is कि हम देखेंगे कि उसमें फिब्रिन स्ट्रैंड्स देखने को मिल जाते हैं, ठीक है, और जिसे हम कहते हैं कॉबवेब कोएगुलम। तो प्रोटीन्स बहुत ज़्यादा इंक्रीज होते हैं, तो इस वजह से 63 का प्रोटीन डज नॉट क्वालिफाई फॉर ट्यूबरकुलर मेनिंजाइटिस, ठीक है। मुझे इसकी क्लिनिकल हिस्ट्री नहीं पता है, अगर क्लिनिकल हिस्ट्री पता होती तो शायद मैं और अच्छे से आपको ये समझा पाती, बट एटलीस्ट जजिंग बाय दी, गोइंग बाय दी व्हाट इज गिवन, द सिनेरियो गिवन ऑन द CSF, अनलाइकली कि ये ट्यूबरकुलर मेनिंजाइटिस है। सो दिस यूजुअली क्लासिफाइज एज वायरल मेनिंजाइटिस, क्योंकि वायरल मेनिंजाइटिस में लिम्फोसाइट्स भी होते हैं, नंबर 1, प्रोटीन भी हो सकता है लो। स्पेसिफिकली जो मम्स मेनिंगो इनकेफ्लाइटिस होता है ना, मम्स में हमको लो शुगर देखने को मिलता है, बाकी आपको किसी वायरल मेनिंजाइटिस में इतना ज़्यादा लो शुगर देखने को नहीं मिलेगा। बट हाँ, मम्स में हम डिस्क्राइब करते हैं कि हाइपोग्लाइकोरेकिया होता है। व्हाट इज हाइपोग्लाइकोरेकिया? लो CSF शुगर का दूसरा टेक्निकल नाम है हाइपोग्लाइकोरेकिया। तो हाइपोग्लाइकोरेकिया स्पेसिफिकली वायरल मेनिंजाइटिस में देखने को मिलता है, ठीक है, एंड प्रोटीन्स थोड़े बहुत एलिवेटेड होते हैं, ज़्यादा नहीं होते हैं। तो मोस्ट लाइकली आपका डायग्नोसिस क्या बन गया? तो करेक्ट आंसर इज वायरल मेनिंजाइटिस, ठीक है, ठीक है, ओके, चलो और कुछ बोलना है? सो लिटलेस लेंसेज सेइंग भूपेंद्र जोगी, अच्छा आई डोंट नो व्हाट डॉक्टर लिटिल सेंस इज ट्राइंग टू मेक सेंस ऑफ, ठीक है। चलो आगे चलते हैं। मैच द फॉलोइंग आया था, ठीक है, कि आपके इनहेरिटेंस पैटर्न दे रखे थे और ये हमारी बिल्कुल क्लासिकल बीमारियां दे रखी है, इफ़ द रिकॉल इज करेक्ट, एंड आई एम श्योर ये सबका करेक्ट हुआ होगा। सो व्हाट डू वी सी ओवर हियर इज कि जो ऑटोसोमल डोमिनेंट होता है वो तो होता है मायोटोनिक डिस्ट्रोफी, ठीक है। जो ऑटोसोमल रिसेसिव होता है वो होता है क्लासिकली आपका सिस्टिक फाइब्रोसिस। माइटोकॉन्ड्रियल तो LHON होती है, लेबर हेरिडिटरी ऑप्टिक न्यूरोपैथी, एंड एक्स लिंक रिसेसिव होता है डुशेन मस्कुलर डिस्ट्रोफी, ठीक है। तो ये आपका दिस वाज द करेक्ट यहाँ पे मैंने करेक्ट कर रखा है, तो दिस वाज द करेक्ट मैचिंग। आई होप आप सब लोगों ने ये कर लिया होगा, ठीक है। Okay, so I think that brings us to the end of this pediatrics recall session of the questions of pediatrics. I'm sure आप सब लोगों ने अच्छा किया होगा. All the best for your results. I'm sure you are going to ace it. And congratulations once again to all of us for winning this South Africa versus India wala match. Chalo, good. Thank you.
All right, good evening, my dear students. How was the exam today? I know there must be mixed feelings always after an exam, and specifically, I wanted to know how was the physiology part. It was definitely doable, good questions, most of which are covered in your classes, but we can go over these questions once again. So let's see this. Let's see the first question which has been asked, and that is the insulin independent absorption occurs in all of the following except. Now herein lies the importance of reading the question carefully. So this is saying insulin independent. So insulin independent absorption occurs in the RBCs, in the pancreas, in the brain. Insulin dependent absorption is in the adipocytes as well as the muscle cells. Insulin will increase the number of GLUT4, which are insulin-dependent GLUT, in the adipocytes and in the muscle cells. So this should have been a very simple question, right? So yes, I'm sure most of you must have got it right. All right, let's look at the second question. It says that the adjoining graph shows the effect of parathormone on the blood calcium and phosphate in an experimental animal. So here you have parathyroid hormone, which was administered to an experimental animal, and what do we see? What happens to the plasma calcium levels? The plasma calcium levels will increase and the phosphate levels decrease. And this is because what is the effect of parathormone? Parathormone has an effect on the bone and on the kidney. On the bone, even though the receptors for parathormone are on osteoblasts, but it causes a secondary increase in osteoclastic activity. So it does increase the osteoclastic activity. Number two, what is the role of parathormone on the kidney? On the kidney, it causes a decrease in the phosphate reabsorption in the PCT. So it causes increased loss of phosphate in the urine, which is known as a phosphaturic action. So that is how the plasma phosphate level will show you a decrease. And how does it increase the calcium level? It causes increased calcium reabsorption in the DCT, right? So it increases the calcium reabsorption or reduces the renal excretion of calcium. So there was one option where both, by increasing the osteoclastic activity and decreasing the renal excretion of calcium, both were given. So that is the answer to this question. Right, so I'm sure this also should have been, most of you should have got it right. Right? So it increases calcium reabsorption. Parathormone has a dual action on the nephron. In the PCT, it reduces phosphate reabsorption, which is called the phosphaturic action, and in the DCT, it increases the calcium reabsorption. Right. Then the next question is the motor supply of the muscle spindle is which of the following? Now, in my class, I make you repeat this particular point again and again. What is the motor supply to the extrafusal muscle fibers and what is the motor supply to the intrafusal muscle fibers? Intrafusal muscle fibers are the muscle fibers inside the muscle spindle. And this is one question which I'm very fond of, and I keep repeating this in my class. And that is motor supply to the extrafusal muscle fibers, which are responsible for a muscle contraction. That is A alpha. The motor supply to the intrafusal muscle fibers, which are inside the muscle spindle, is A gamma. There are two motor neurons. The larger one is A alpha and the smaller one is A gamma. A alpha supplies the extrafusal muscle fiber and is responsible for muscle contraction. A gamma supplies the ends of the intrafusal muscle fibers. So the motor supply to the muscle spindle is A gamma. And I keep telling you this as well, that muscle spindle is a very unique receptor, that it has sensory fibers and it has motor fibers. The sensory fibers from the muscle spindle are 1A and 2, and the motor supply to the muscle spindle is A gamma. Right, so again, All right. So this is A gamma. Okay, so let's go on to the next question. In the adjoining image of the muscle fiber action potential, the phase marked B is due to which of the following? So A is the depolarization phase, and this is because of opening of voltage-gated sodium channels, which results in a sodium influx. What is the repolarization phase? B is the repolarization phase, and this repolarization phase is due to closure of the fast voltage-gated sodium channel, so a decrease in the sodium influx, plus opening of the slow voltage-gated potassium channels, so increase in the potassium efflux. Right? So let's look at the options. It says, is it because of efflux of potassium? Definitely. Is it because of influx of potassium? Now please understand, whenever a channel is open, channels are ion specific, right? And whenever a channel is open, that particular ion will always move from its higher to lower concentration. So if a potassium channel is open, whether it's like in this case, a voltage-gated potassium channel, potassium will move from inside to out, from higher to lower concentration. You have a higher concentration of potassium inside the cell, lower concentration of potassium outside the cell. So it's always an efflux of potassium through voltage-gated potassium channels. Of course, movement of potassium from inside to out, that means against a concentration gradient, will involve a pump, the sodium-potassium pump, right? But through a channel, influx of potassium is not a possibility. And similarly, sodium efflux. If a sodium channel is open, sodium will come from outside to inside. There is an influx of sodium. For efflux of sodium, that means to move the sodium out of the cell, you need a pump. So sodium efflux is not the answer, calcium is not the answer. The answer here is repolarization is because of efflux of potassium from inside to out, causing loss of positive charge and the repolarization phase. Repolarization phase, like I said, is due to a decrease, closure of sodium channels and opening of the slow voltage-gated potassium channels. Answer to this, efflux of potassium. Right, so again, I think most of you have got it right. Yes? Okay. All right. Let's look at, of course, this is from one of the classes, the depolarization and the repolarization of the action potential. Okay. Then you also had a question on pacemaker potential. Now these are extremely important topics. These are PYTs and also PYQs, the action potential in a nerve, in a muscle, in the skeletal muscle, in the cardiac muscle, and also the pacemaker potential in the heart. Now, pacemaker potential, phase 0. The pacemaker potential, phase 0 is, which is the depolarization phase. This is not due to sodium, but in fact due to calcium. There are two tissues where the depolarization is due to calcium, and that is the pacemaker cells and the smooth muscle cells. Neuron, skeletal muscle, cardiac muscle, the depolarization is because of sodium influx. But the pacemaker cells of the heart and the smooth muscle cells, depolarization is because of calcium influx. So the answer to this question becomes calcium influx. Right. Let's look at the next question. The graph given below shows the normal FEV1. So you've got force expiratory volume of air at the end of 1 second. This is the normal graph here. And you've got the forced vital capacity. So FEV1 and the FVC curves for a normal lung and a diseased lung. How much is normal FEV1 by FEVC ratio? This is 0.7 to 0.8 or 70 to 80%. This is a normal FEV1 by FEVC ratio. Now what you see in this graph, which is given in red, what has happened to the FEV1 has reduced. The FEC is normal. So that means what has happened to the FEV1 by FEC ratio, the numerator has decreased, the denominator hasn't. So what has happened to the ratio? Reduced. And FEV1 by FEVC ratio will be reduced in an obstructive lung disease. And the obstructive lung disease here would be COPD. What happens in a restrictive lung disease? FEV1 by FEVC ratio is normal to increased. This is obstructive lung disease. FEV1 by FVC ratio is reduced. Why is it reduced? Because the numerator decreases more than the denominator. In obstructive lung diseases, rates are affected more than volumes. FEV1 is a rate, FVC is a volume. FEV1, why do we call it a rate? Because it involves time. It is a forcefully expired volume of air at the end of 1 second, so it involves time. So it is a rate. FVC is a volume. So in obstructive lung diseases, rates are affected more than volumes. Numerator decreases more than the denominator. Therefore, the ratio reduces. What happens in restrictive lung diseases? Restrictive lung diseases, the decrease, both the FEV1 and FVC will reduce, but the reduction in FVC is more than the reduction in FEV1. Here the denominator reduces more than the numerator. So either the ratio will be normal. If both have reduced to the same extent, ratio remains normal, or the ratio will increase if the decrease in denominator is more than the decrease in the numerator. So what happens in restrictive lung diseases? Restriction and expansion, so volumes are affected more than the rates. Again, FVC, which is a volume, will be affected more than FEV1, which is a rate. Right. So next, which of the following is incorrect about baroreceptors? So I'm not very sure about the recall, about the options. Now these are the options which have been given to me, and so this is, I'm not 100% sure of the options, because there is sort of a there are different options which have been given, but I think now which of the following is incorrect about baroreceptors? Is it located in the thick muscle layer? You have the tunica interna, tunica media, which has the muscle, and the tunica adventitia. And baroreceptors are in the tunica adventitia, not in the muscle layer. Are they stretch receptors, which is true? The afferent fibers from the carotid sinus. Where is the carotid sinus? Carotid sinus is in the internal carotid artery, just above the bifurcation, in the adventitia of the internal carotid, just above the bifurcation. So the fibers, the sensory fibers from the carotid sinus will pass via the glossopharyngeal, which is true. From the aortic arch baroreceptors, the sensory fibers or the afferent fibers will join the 10th nerve. Are they sensitive to changes in arterial pressure? Which is true. These are mechanoreceptors. These are sensitive to stretch. These are stretch receptors. They are mechanoreceptors, stretch receptors. So yes, they are sensitive to changes in arterial pressure. So the best answer here appears to be A. AC appears to be incorrect, not in the muscle layer, but in the tunica adventitia. Now remember, whenever there is an increase in the mean arterial pressure, there is an increase in the stretch of the vessel wall, which increases the firing rate of the baroreceptors. And what is the reflex response? Reflex response will be, it reduces the sympathetic discharge to the cardiovascular system, increases the parasympathetic discharge, both of which result in a decrease in heart rate and a decrease in blood pressure. So this is a negative feedback mechanism which helps to maintain the blood pressure. On the contrary, what will happen if there is a fall in the mean arterial pressure, reduced stretch of the vessel wall, decreased firing rate of the baroreceptors, which increases the sympathetic discharge, reduces the parasympathetic, causes an increase in heart rate and an increase in the blood pressure. So this is a negative feedback mechanism for regulation of blood pressure. Right. Now, which of the following occur during a cough reflex? Now, as far as the cough reflex is concerned, I'm not sure about what are the other options, but this is definitely, which was told to me, forced expiration against a closed glottis, or was it forced expiration against an open glottis? Now, which of the following occur during a cough reflex? Now, what happens in a cough reflex is, initially, there is a forced expiration against a closed glottis, and that increases the intrapleural pressure. Now, if you remember from your theory class, the intrapleural pressure is always negative. It's only when I do a forced expiration against a closed glottis that the intrapleural pressure becomes positive. So, initially, during a cough reflex, there is a forced expiration against a closed glottis, but then suddenly the glottis opens, and because of which air is pushed out of the lungs at a very fast rate, and which helps to clear the airways. So this is what happens in a cough reflex. Whereas what happens during sneezing? During sneezing, the forced expiration is against a continuously open glottis. So here my best answer, because the question has said what occurs during a cough reflex, my best answer here would be forced expiration against a closed glottis, because like I told you, what happens here? There is a deep inspiration followed by forced expiration against a closed glottis, and this is then the next event to occur is a sudden opening of the glottis, producing an explosive outflow of air with velocities up to 600 miles or 965 kilometers per hour. And what happens in sneezing? This is a similar expiratory effort with a continuously open glottis. So the best answer here would be forced expiration against a closed glottis. Let's have a look at the next question. Now this says, first part of the PCT has which of the following transport proteins? I got 3 options and they appear to be correct, and that is sodium potassium pump, which is true. The basal side of the PCT cell has the sodium potassium pump, which pumps out 3 sodium, brings in 2 potassium. So sodium potassium pump is definitely present on the basolateral membrane. Is there a sodium glucose co-transporter? Which is true. Sodium and glucose move into the cell by a secondary active transport, which is also known as co-transport or symport. Is there a sodium hydrogen antiport? Which is also true. Sodium will move into the cell and H+ ions move out of the cell. So that is a antiport. Sodium, hydrogen. So all 3 are present. Unfortunately, I do not know what are the other options, and since this was multiple correct, all 3 options are correct. If somebody has anything to add as far as ये नहीं आ रहा, chat box नहीं आ रहा है? अच्छा ठीक है. So this is your, these 3 proteins are definitely present in the PCT. Let's have a look at the next question. Now this says 2,3-BPG. 2,3-BPG is a byproduct of the glycolytic pathway. This binds with which of the following? Now 2,3-BPG and oxygen bind at the same place on the beta chain of hemoglobin. So it binds with the globin part of the hemoglobin. Beta chain is the globin part. So it binds with the beta chain of hemoglobin. And what are the conditions which cause increase in 2,3-BPG? If there is an increase in 2,3-BPG, this causes a shift of the oxygen hemoglobin dissociation curve to the right. And rightward shift means FDR, favors delivery or dissociation, a shift to right. So by increasing 2,3-DPG, there is a shift of the oxygen hemoglobin dissociation curve to the right. And what are the conditions which can cause increase in 2,3-BPG? And Gita, whenever there is excess of growth hormone, exercise, excess of thyroid hormone, anemia, high altitude, and whenever there is excess of androgens. So these conditions will increase the 2,3-BPG. They increase glycolysis and therefore there is increase in 2,3-BPG. More 2,3-BPG, that means less binding with oxygen or more delivery of oxygen. So remember, increase in 2,3-BPG will cause a shift of the curve to the right, which favors delivery or dissociation. So these were your physiology questions in today's INI-CET. I hope that you got these correct. My best wishes to each one of you, and hopefully we will see excellent results from you all, and thank you very much for being a part of today's session. Thank you and God bless.
So hi dear students, I hope you have just enjoyed this session of the INI-CET. So this time we had a new pattern of INI-CET, and most of the students were anxious before going for exam, but this time the paper was moderate, doable, and if you talk about surgery was really very easy. All the questions which were asked, there was nothing like a very weird type of question. So all the questions were easy, and let us have a quick recall. Let me tell you before I start this discussion that all these questions are based on what you people have suggested to us. They are not the original questions because I have not given the paper. So don't just get, you can say, surprised if you think that this was not written in the question that was there. And do comment in the comment section below what was the exact question if you think the question was a bit different from what you anticipated. So we had a question on the incisions, and let me tell you about the incision that was actually along the groin, a curved incision towards the groin. People were telling something like this. So if you talk about the options given amongst them, so this is Cocker's, the right subcostal incision that we go for the gallbladder surgery. So this is Cocker's. When we talk about the other incisions, this is Maillard incision. When we talk about Maillard incision, it's a transverse incision. So in low transverse incision is Maillard. We also have one of incision as Robson's incision. So a paramedian incision towards the Ziffy. This is what is a Robson's incision. This is Maillard incision. Then we have an incision which is known as Gibson's incision, curved incision going 1 centimeter above the, you can say, inguinal ligament. And this is a Gibson's incision which we use for actually ureters. So ureteric surgeries, we use this Gibson's incision, and this is what is the, you can say, the answer. Next is, let us talk about, there was a question, which of the following is a contraindication for liver transplant in case of secondaries to the liver? So breast cancer, melanoma, RCC and rectal cancer. Remember, colorectal cancers. So colorectal cancers with liver mets. With liver mets is a known entity. And remember, here the transplant can be done easily. So remember, it is the rectal cancers or colorectal cancers which is the answer amongst the options provided. So C is the most probable answer here. Next is bile duct injury. So we must have heard of, and I have actually in the rapid revision also, I have already discussed about this. So there's a classification which is known as Bismuth-Strasberg classification. So now if you see, Bismuth is also there, Strasberg is also there, but Bismuth is for the strictures and the Strasberg's classification is for the injury. So if you talk about this Bismuth-Strasberg, A, B, C, D, they are for the what? Injury, and E is for the stricture. So this is the answer for this is Strasberg is for bile duct injury and the Bismuth part is for the strictures. Now then again in this exam, it was very surprising that we had lot of questions from the, you can say, the liver part, the gallbladder part. We had lot of questions from the GIT this time. The patient with cholecystectomy on histopath, the specimen was found to be a CAGB with invasion into the muscularis. So remember, T1A is into the mucosa, T1B is into the submucosa. Remember, submucosa is not there. That is what is known as muscularis mucosae. Muscularis mucosae. It is T2B, which is actually perimuscular. T3 is into the liver. So remember, this is what is very, very, very important. If this is a T1B and above tumor, if it is a T1B and above tumor, the only management is radical cholecystectomy. Radical cholecystectomy. So when we talk about radical cholecystectomy, what do you mean by this radical cholecystectomy? Removal of the gallbladder and along with that 2 centimeter wide local excision of the what? Gallbladder fossa. This is important. Remember, if this is not there, then you will actually go for extended cholecystectomy. What is extended cholecystectomy? It is nothing but cholecystectomy with resection of 4B and segment 5. This is extended. So this patient has to undergo a repeat surgery, and here you will go for a wide excision. Next is, which of the following are used to manage hyperthyroidic crisis except? So these drugs, you know, thyroid storm. We have propranolol to control the rate and the rhythm, lugol-iodine to induce a negative reinforcement, acetaminophen to reduce the temperature, and aspirin is contraindicated. Why? Because it will increase the free iodine, you can say free T4 and free T3. Why? Because it decreases the binding of the thyroid hormone with the protein. So it will increase the free, you can say, thyroid levels, and therefore it will worsen the scenario. So aspirin is actually contraindicated here. Now again a question on burn. I don't know whether it is an exact recall. Burn involving the chest and the abdomen. So anterior part of the chest and the abdomen, this is going to contribute to what? 18%. Then the right leg, someone was saying a well circumscribed burn over the thigh. I don't know whether what is right. Right leg, both front and back, it hardly matters. So it is 6. And also the right arm. This is what is again very, very, very important. So right arm. So when we talk about this, let us take it to be 9, 18 plus 9, 27, and 27 plus 6. At least it should be somewhere around 33%. So the best probable answer I would have marked as D, that is 36%. Now, which is the most important prognostic factor in case of the, you can say, breast cancer? So remember, it is the lymphovascular invasion, and therefore lymph node status is more important than the tumor size. This is what is very important. So nodal status is very, 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 very important. When we talk about the ER/PR status, this is the most important prognostic factor in case of metastatic cancer. So this is what is the classical difference that we have. Now there was one question on adrenal gland. So this is a one-liner question. What is the color? Yes, it is yellow in color. Remember, left adrenal is near to the pancreas. As you know that this is the concentric shape adrenals, and here you have the spleen. So this is how the adrenals are arranged. So yes, it is close to the tail of the pancreas. The right adrenal is actually pyramidal in shape. It is not a semilunar organ. So remember, this is wrong, and of course they are retroperitoneal. So this is what is very, very, very simple question that we have. So the option C is incorrect here. Gallbladder cancer, all are except the high risk factor. Remember, Salmonella typhi carriers, it is the porcelain gallbladder, it is the stones. So gallstone, giant stones more than 3 centimeter, polyp less than 1 centimeter? No. Polyp more than what? 1 centimeter. Porcelain gallbladder and primary sclerosing cholangitis is also what is not. So polyp less than 1 centimeter are not increasing the risk of malignancy. Remember, this is now a bit controversial when you talk about a higher level. Even the polyps more than 7 centimeter in the Asian race or specifically in the Indians, they are a high risk factor. Anyways, I would have marked B as the answer here. Now, the best diagnostic method for parathyroid adenoma, you know, cysta-MeB dual isotope scan. Dual isotope scan. And what is the dual isotope? It is technetium-99. cysta-MeB is far better than the cysta-MeB alone. Remember, here I would have given more priority to the SPECT also, but the SPECT alone is not useful. It should have been cysta-MeB SPECT. So remember, technetium-99 cysta-MeB scan is the most you can say sensitive test amongst the option given below. A non-reducible swelling with pain lateral and below the pubic tubercle. So remember, pain is there below and lateral to the pubic tubercle. So this is a potential site for what hernia? Femoral hernia. What is the diagnosis? The X-ray also shows obstruction. What is the diagnosis? Strangulated inguinal hernia? No, it is strangulated femoral hernia. Very easy question. Very easy question. Most of the questions are straightforward from the notes. If you see, I always give an algorithm, and this is a very common thing that it is below and lateral or it is medial and above. Let us move forward. A patient, and we have already discussed this question. Female with CA breast with fixed nodule, immunohistochemistry done, HER2 positive, which stain gives brownish appearance on IHC. This question is again, you can say incomplete, so I cannot comment on this. But remember, on the stains, we check the amount or degree of the stain. If it is positive, it is taken as 1 positive. It is moderately increased stain, that is taken as 2 positive, or you can say weak. And if it is densely stained, that is taken as a strong, or you can say 3 positive. So this is how we see 2 positive, 3 positive. I don't know about the exact question. If you have, you can always comment. So bilateral adrenalectomy is done for which adenomas? Remember, bilateral adrenalectomy is done for bilateral adrenal hyperplasia associated with cons. So remember, amongst the option provided here, it is the cons, that is aldosteronoma. Aldosteronoma which might require. Do you know what is aldosteronoma and when will you suspect this? A patient with poorly controlled hypertension on multiple antihypertensive drugs. So they are always suspicious of aldosteronoma, and in case of bilateral adrenal hyperplasia, we check, and if we find bilateral adenomas, we may go for bilateral adrenalectomy in this case. Now, open cardiac massage, you are doing open cardiac massage, and open cardiac massage is done in the ER room. So remember, whenever you do ER room open cardiac massage, this is considered to be what? A clean contaminated. So we have class 1 as clean, then we have class 2 as clean contaminated, and the third category is contaminated wounds. So this is option D here, that is class 3 wound or contaminated wounds. The risk of SSI is 3 to 13% in these patients. There was again one question on luminal ACA breast. I am not able to recall. I have shared this question also, the luminal A1 along the various platforms. But yes, if I get a question, I will definitely share with you. And if you think you know the question, you can recall the question, do comment in the comment section. So that was the surgery part of discussion. I hope you enjoyed it.
Hello students, very good evening. This is your very own ENT faculty, Dr. Sarabjit Singh, and I'm going to discuss the INI-CET recall questions which were asked today, that is on November 2023. Now, many a times we think that the ENT paper is, ENT questions, there are going to be only 2 or 3 questions. That was the first response that was given to me by the students who came out of the INI-CET exam, and I was standing outside the hall. But we always tend to remember the difficult, the tough questions which are asked, and many times we forget the easy questions. And today INI-CET, the questions which were given in the paper from ENT, I'm surprised, this I think is the maximum. I got around 11 questions till now, which I have got of ENT. Of course, 2 or 3 are overlapping questions, but the remaining questions are pure ENT questions. So generally, we get 5, 6, 7 questions of ENT, even if they are overlapping or integrated questions. But today I got around 11 questions of ENT that came in the exam today, right? So, so many questions came, and the best thing was that all the questions were direct questions, even though some were clinical, some had histopathology images. They were all direct questions. There was nothing that was hidden. There was no hidden surprises. There was nothing which was new. Right? So many questions came. Let's discuss the question and we'll discuss each of these questions in detail. Let's go ahead, shall we? Yes, so this is the first question which came, straightforward question. Hindi mein what do you say that? Ki, for ENT, if you have seen my videos, if you read the notes, तो आप लोगों ने आकर के जरूर बोला होगा कि लप्पू सा पेपर आया था और झिंगूर से क्वेश्चन थे. Similar, straightforward question, one-liner questions, direct images, nothing, just pick it, mark it, go ahead. Okay, so the first question, identify the type of joint marked in the given image. So ossicles दी हुई हैं friends, we have the ossicles, the ear ossicles, and I've taught you that the joint between the ossicles is the synovial joint, and the arrow was marked over here at the incromalleal joint. Okay, so you can see over here, and we know that this is saddle variety of synovial joint, and incrostapedial joint, this is ball and socket variety of synovial joint. Okay, both of these are saddle varieties. So answer to this question is saddle joint. Straightforward question, very easy question. Okay, second question was asked, a 33-year-old, and I'm looking at the chat. So friends, if you are there, you're watching me, just give me a thumbs up if you're able to get the questions, and write if you think that some choice is little wrong. Okay, although I've tried to get almost all questions with the right language, because even a single language alphabet can change the answer, and such as in this question that I am going to discuss. So if you find that some language was different in the question, or you see that some choice was different, please feel free to just write it. Okay. Now second question, and this question I have a doubt as well, because I'll tell you the image, if there's a little difference in the image, that can change the answer. A 33-year-old male presented with URTI, upper respiratory tract infection, with pus in the left nasal cavity and orbital pain along with blurring of vision. Okay, so that means there is a, there is a URTI, there is pus. So patient is having sinusitis, and now there is blurring of vision, there is orbital pain, there is blurring of vision. So what is this? This is a question of complication of sinusitis, right? CT scan was done and following findings were seen. Now over here, whether CT was given or maybe the MRI was given, I am not sure, what is the most likely diagnosis? So it is not just sinusitis, it is complication of sinusitis. So first option is definitely out. Now it can be, different types. We have, periosteal abscess, subperiosteal abscess. We have orbital cellulitis. We can even have orbital abscess. Now you see, subperiosteal abscess, cellulitis or abscess would have been over here. Okay. Now this you can see that there is a definite proptosis. There is bulging of the orbit, plus there is blurring of vision. So that is seen if there is, orbital cellulitis or orbital abscess. Now orbital abscess was not there in the options given to me. Plus over here, I cannot see any frank abscess in the cavity. I am not able to see any frank abscess in the orbital cavity. So if there is no frank abscess, there is proptosis. So only answer that is left to me is orbital cellulitis. However, depending upon the image, this answer can change because blurring of vision can be seen both in orbital cellulitis as well as orbital abscess. Okay, you see this is a patient of subperiosteal abscess that you can see over here. So I have just kept these images that you can guys just write to me in the comment section and tell me, sir, this image was there. It was looking like subperiosteal abscess? No. That what students have told me. Or was it looking like orbital cellulitis? So this is an MRI as well as a CT scan you can see over here. So in this you can see the eyeball is protruding out. So something similar to this image I found that the students sent me, right? Okay. So this kind of image I am seeing in the question. So I have labeled it as orbital cellulitis. Okay. However, if it was an orbital abscess, then you can see over here there is a frank abscess. Okay, you can see subperiosteal abscess as well as there is a orbital abscess also. So sometimes in the orbital abscess, this is an orbital abscess. This again is a frank abscess. So frank abscess was not seen, right? Okay. So frank abscess was not seen. So that means it is a case of orbital cellulitis, right? Okay, next question. Now I am sure this question even the dermatology faculty must have discussed with you, right? Because this question it came in the dermatology, it's an overlapping question. So whenever we have these kind of overlapping questions, I teach dermatology, sir, Dr. Manish also teaches it. Apocrine glands are seen in straightforward one-liner question, face, scalp, palm and sole or axilla. So I to tell you apocrine AAA, the mnemonic is AAA. Okay, atypical apocrine adrenergic fibers, and they are found in AAA. What? Axilla, areola, anal, perianal, circumanal or perianal, right? Remember, so answer is axilla and pubic areas. Remember 4 places I tell you, axilla, areola, nipple areola, anal, so circumanal, okay, and pubic area. So AAA, remember the AAA mnemonic, apocrine atypical sweat glands and adrenergic nerve fibers, right? Okay, next. Question number 4, again a straightforward, and this was a repeat question that came in the exam. The image was new, I agree, but you don't get the same images like that. A 60-year-old patient presented with following lesion which is slowly progressively increasing in size. So you see 60-year-old man, elderly patient, and you have a lesion on the face. This looks like say ulcer, and this ulcer you can see that there are rolled out margins. So this is again an overlapping question with dermatology once again. Okay, so answer was BCC. We have studied this BCC, most common malignancy of the skin, right? Very common on face and hands, on the dorsal side of the hands, right? Exposed to ultraviolet B rays. All right. Next question, question number 5. Now this question, I think it's an overlapping question between radiology because the X-ray was given to you. But yes, it's a pure ENT question. A child was playing alone and is found to be drooling and choking. X-ray is done and is shown below. So what is the likely? So you see that the question generally asks is that where is the foreign body? Now you see over here, instead they ask what is the likely foreign body ingested. And I have taught you in my lectures, I have taught you multiple times that whenever you see a coin or a ring like foreign body, circular foreign body, what you have to see, you have to very carefully, and this is one thing that we have to, as a clinicians, we have to see over here, there is a ring in ring appearance. Okay, there is a double ring or a ring in ring appearance. And whenever I see this X-ray, it's an alarm in my mind because this is an emergency. Coin you can wait for 2 hours, 3 hours, but this is an emergency because this is a button battery. Okay, this is a button battery. How can you determine, how can you confirm? You can confirm by looking at the lateral view. What do you see in the lateral view? It gives you a stacked appearance, as if there are 2 coins. Okay, so as if there are 2 coins, there is a stacked appearance over in the lateral view. And this is very important. Why? Because this is a time bomb. I always say this is a time bomb. Why? In 2 hours it starts leaking. And in next 2 hours it causes perforation. And in next 2 hours it causes mediastinitis. which is a life-threatening complication, life-threatening infection. So friend, this is an emergency. You can't wait even for the child to become 6 hours nil per orally as per anesthesia, general anesthesia requirement. You have to immediately take, and you cannot wait for 6 hours. In a coin, the anesthetist will ask, okay, let the child become NPO for 6 hours, then we'll give the GA, and then we'll take the patient to the OT, give GA, and then you can take out the foreign body. And we are happy to wait for 6 hours. But in case of foreign body, which is a button battery, we say no. 6 hours, a lot of things will happen and things will go out of control. So we have to take it out immediately. Right, friends? Okay, next question. You know, INI-CET paper is incomplete without autosclerosis. They have to give a question of autosclerosis, and it generally comes as a clinical question. How? You see, a lady presented with bilateral hearing loss. You see, bilateral hearing loss, more on right side. It was decided to do stapedectomy after examination. So stapedectomy is the treatment plan. That means you know it is a case of autosclerosis. Straightforward question. You cannot get a simpler question than this. What is the likely Reni's and Weber? So we know autosclerosis is a disease where we have conductive hearing loss, and it is a bilateral disease. So patient will have bilateral conductive hearing loss. That means Reni's in conductive hearing loss is negative. What about Weber's? So you see, Weber's, hearing loss is more on right side. Which kind of hearing loss? Conductive hearing loss. So we know Weber's goes towards conductive hearing loss. And out of right and left, right is having more conductive hearing loss. So Weber's will go towards the right side. Yes, so answer is bilateral Reni's negative and Weber's going to the right side. Okay, 7th question. I'm not able to get all the 4 choices in this. So I would like you to, give me the choices, right? So all of the following statements are true except 1 layer cells in inner hair cells and 3 layers in outer hair cells. That's true. We have discussed the differences between inner hair cells and outer hair cells in my lecture. And we know that the inner hair cells and outer hair cells, the difference, I have told you, outer hair cells, the mnemonic is more. Okay, outer more. O, I have told you, O more. What is more? More in number. 13 to 14,000 in number. Okay, inner hair cells are less in number, 3,500 number. Okay, now outer hair cells more in rows, 3 to 5 rows. Inner hair cells 1 single row. So this statement is correct. Okay, now we have also seen the diagram in the physiology. We know that the outer hair cells, they lead to electrosomatic motility. Okay, so we have discussed that there is a special protein inside the wall of the outer hair cells, and that leads to electrosomatic motility. Whereas the inner hair cells, inner hair cells, 95% fibers. This also I have told you, 95% fibers, they supply the inner hair cells, and they are responsible for afferent nerve fibers. Whereas outer hair cells, they are efferent nerve fibers. Okay, and they receive only 5% of supply. So this statement is also correct. Now the third statement, I didn't get a complete statement. It was about the outer hair cells, sense movement, or whether it was because of the efferent fibers. So based upon that, this statement may be true or false, and I am still waiting for the 4th option. So friends, do write to me if you know the 4th option. Please do that. Okay, right? All right. Let's go ahead. So students who are watching this video, Dr. Abdul, Dr. Nikhil, Dr. Juhi, Dr. Suhotra, can you just fill up the last choice? Is this question rings any bell to you? Does this question rings any bell to you? Dr. Para, Dr. Sri Krishna, Dr. Sunil, whosoever is there, please, I'm waiting for you. Okay, can you just write me the options? If you remember this, I'll be happy. Please do write to me the options that are there. Okay. All right, no worries. If you don't remember it right now, no worries. We'll have it later on. I can come back to this question. Let's discuss the other questions. Question number 8. Now this again, so I think 2 or 3 questions were overlapping between ENT and dermatology. A HIV positive patient presented with white non-scrapable lesion on the lateral border of tongue as shown below. So you can see which of the following is most likely. So what is this diagnosis? It is non-scrapable. Answer to this is oral hairy leukoplakia. Okay, oral hairy leukoplakia, and this is caused by Epstein-Barr virus. All right, I think Dr. Manish has already discussed this question with you, so I will not go into much detail into this thing. Right, let's go ahead to the next question. Now question number 9, and this is a pathology overlapping question. Okay, although I'll say it's a pure ENT question because we have discussed this in detail in our lectures. A patient presented to ENT OPD with unilateral nasal mass causing obstruction and occasional bleeding. The mass was removed and histopathology shows the following finding. What is the most likely diagnosis? So what do you see over here? You see that there are a lot of sporangia, right? Okay, so unilateral mass, occasional bleeding. Now, the confusion is generally between 2 things, rhinoscleroma or rhinosporidiosis. So that is why students had put these 2 options to me. I don't remember the remaining 2 options. I don't know them because students didn't remember them. They were confused between 2 of these things, rhinoscleroma or rhinosporidiosis. So rhinoscleroma generally tends to be bilateral, number 1. Number 2, it will always have atrophic rhinosinusitis like findings. Like there will be atrophy, there will be crusting, okay, there will be foul smell. So all that will be mentioned in the history. Okay, whereas rhinosporidiosis, the nasal mass is there. And I think one of the students told me that this nasal mass, they had mentioned strawberry-like mass. So if it's a strawberry granuloma, that clearly points towards rhinosporidiosis. So I am not sure whether strawberry was there or not. So that is why I have not mentioned this strawberry-like mass. If it was there, then the question was pretty straightforward. Just on the basis of history only you could have solved. Okay. If this was not there, then you look at this histopathology finding, and that is clearly in favor of rhinosporidiosis. Okay. Sometimes they give you a history of rhinosporidiosis that the patient belongs to the, it is found in southern coastal India. So southern coastal Indian states like, West Bengal, Odisha, then we have Andhra, we have Tamil Nadu, okay, or you can even have Pondicherry, or it belongs to Bangladesh or Sri Lanka. So that's the only place where we have this disease. The disease is found in rural population or people who take bath in the pond. So if any of that was mentioned in the question, please let me know, okay, because then that makes the history, even more pointing and definitive towards our diagnosis. All right, let's go to the next question. Okay, so I think I have marked question number 10 over here. Upsloping audiometry is seen in. So we know that the upsloping audiometry is seen in endolymphatic hydrops. So that was the option, students remember. It's a pretty straightforward question, right? Whether it was an image-based question or a straightforward one-liner, I am not sure. Okay, so just let me know, because students, they just told me, sir, that this question came in the exam. So do let me know if this was a, IBQ image-based question. That will make it a little more interesting, because generally INI-CET people are not, fond of giving 2 or 3 words question, one-liner question like that. We know that upsloping audiometry is seen in Meniere's disease, also known as endolymphatic hydrops. Okay, we can also have a downsloping audiometry, that is, so upsloping is also known as rising curve. Downsloping, that is seen in presbyacusis. Okay, it is also seen in ototoxicity. In both of them, they are bilateral, downsloping. Of course, in Meniere's disease also, in later stages, it becomes downsloping, but there it is unilateral. So late Meniere's disease has downsloping, but early Meniere's disease is upsloping. So answer is endolymphatic hydrops. right? Okay, question number 11 that we have, a patient recently recovered from COVID-19. Now, this question is a 2-year-old question. It's a repeat question. Okay, now why? Because this question came, in 2021 when we had the Delta wave, the second wave of COVID. A lot of patients had mucormycosis, and this question was there in almost all the papers. At least 2 or 3 questions came in one paper. So it has come from there. I was surprised to see such a question, a repeat PYQ. At this time when we don't have, any more COVID-19, we have COVID-19, but we don't have these cases now. So a patient recently recovered from COVID-19 who was treated with steroids. After 3 weeks, he complains of nasal discharge. Swab collected and following image is seen. So what you can see over here aseptate fungi. Okay, you can see over here aseptate fungi. So one of these images, I think this image was given. I have kept all the 4 images, but this image was shown over here, I guess, or maybe this image was given. I am not pretty sure which image was given. So I have kept both the images over here, and I'll still wait for your response to tell me which image was there, right? So aseptate fungi was there, okay, obtuse and at right angles. So that is the answer, the answer was pretty clear. It is mucormycosis, COVID-19, post-steroids, and we have something growing in the nose. The answer was mucor. Okay, that's a straightforward question, no brains applied for that, right? So these were the questions that were from ENT. I've tried to complete the questions, as much language as was possible, try to give the right images, try to give the right options, but still I know it's a very short time that I got in between, and there are some things which are missing over here, some components. Maybe I have missed some other question also. I understand it's already late and you are tired, but I'll wait for you. Give me the answers, right? Give me the right options. You can reach to me at sarvjit@gmail.com. That's my email ID, or you can reach to me at my WhatsApp number 962542816. Okay, and I'll be happy to reply to you, right? Thank you very much and best of luck. Don't worry, this paper, INI-CET paper, sets the tone for the NEET PG paper. I always say that, because even if you are not aiming for INI-CET, it tells you where your preparation is right now. And you still have 4 months, November, December, January and February. The exam, as announced, is slated to be in March. So you have 4 good months. Out of these 4 months, at least 2 months you can utilize to complete the course if you are left with any course, and 2 months you can give for revision. And if you have completed your revision, your course till now, you are at a very good stage. The remaining 4 months you can just put for revision, and if you put 4 months for revision, you are definitely going to crack the NEET PG. All right, so it's a win-win situation for everyone, people who have not finished the course as well as people who have finished the course. You can still make a lot of difference in your NEET PG. Don't worry about the INI-CET score, because there's a lot of difference over there. And there are people who are very happy, who have given the question paper very nicely. I wish you best of the luck. As I said, for ENT, this was a Lappusa paper and Jingur se questions. Okay, so best of luck, guys. See you next time. Thank you.
So hello all and welcome students for this anatomy recall of INI-CET November 2023. I'm Dr. Ankit, your anatomy faculty at our NExT platform. So I hope the paper went fine. Paper अच्छा गया होगा, and especially those जिनको थोड़ी सी anatomy की basics में थोड़ा hold command अच्छा है, because we have heard anatomy questions in the first part, particularly जो first 45 minutes में 50 questions थे, many of them were anatomy questions from that. So let's start the recall, and I hope it goes well for all of you. Let's start it. So first question which we got the recall from the students was this. The question was, nuclei of thalamus is located dash to the marked area. So I guess there was an image shown, and this image is very famous in our INI-CET, and this topic also, the topic that is the fornix. This fornix also is frequently asked. So the fornix was asked, and then they asked not about the fornix, they asked that this fornix is related to which nuclei of the thalamus. So if you have gone with the lectures, if you have a basic idea, because thalamus is a big topic, there are so many nucleus, but we always in our classes also say कि there are 7-8 nucleus in thalamus, बस उसके afferent efferent समझ लीजिए, what is the input to it and what is the output to it, that is sufficient. and also you must be knowing the Pepys circuit. So this question was indirectly from thalamus, as also indirectly from the Pepys circuit. And we all know that this is a mammillothalamic tract. So this phonics comes from the mammillary body and goes to thalamus, and goes to which nucleus of thalamus? That was actually asked in the question, and it goes to the anterior nucleus of the thalamus. So the answer for this question should be the anterior nucleus of thalamus. एक दो images देख लेते हैं. Let's see a couple of images. This is a cadaveric image, and here you can very well see this area. This is basically what is the phonix over here, and above it you can see there's a whole corpus callosum, the commissural fibers. You can see a lot of the diencephalon over here. Particularly the thalamus area is this, and this is the hypothalamus area, which we have done in detail in our classes. But yes, this phonix is related to the anterior nucleus of thalamus. And let me show you one more image which we have discussed in our classes. This actually is a whole thalamus being shown, and the nuclei, the name of the nucleus are shown, and what is the input and output. So in this particular time for the INI-CET, they asked about this phonix part, and you can see it's going to the A, that is the anterior nucleus of thalamus. And the efferent from it will go to the cingulate gyrus, and then you know the whole Pepys circuit, right? So anatomically, the 2-3 things is what? The take-home message is we should know the cadaveric images, particularly from the brain, and we should know what structures they are asking, and then some knowledge, some basic knowledge around it. That is okay. So this was the first question. Let us see one more. A question was again an image-based question was given, and a cadaveric image as per the students was shown over here, and then some arrow was marked out to a specific point, and the information which we got, which we received, was that the arrow was pointed out to this particular area, and then they asked that what is this particular area? So if you look at this image, you can see both the lungs are on the sides, and you can have a good hold of it about the structures which are between the lungs, that is the mediastinal structures basically. So what are the inferences that we can take up from this image? So अगर आप एग्जाम हॉल में बैठे हैं और इमेज आपके सामने आई तो क्या क्या चीजें दिमाग में घूमेंगी सबसे पहले? Listen, understand over here that this structure is the beginning of the aorta. So that is the ascending aorta. This is the ascending aorta, right? And then there is an arch of aorta in the superior mediastinum. Then it continues down as the descending aorta. This becomes the descending aorta, descending thoracic aorta to be more precise. अब aorta के पीछे क्या होता है? What is behind the aorta? See, these images you can understand if you have a core basic important concepts of anatomy अगर clear है, then the question solve हो जाएगा. Now, if you look at the heart, let me just take a few seconds over here. If you look at the heart over here, आप क्या देखते हैं heart में? सामने you see this rising aorta, right? This is ascending aorta, then it forms an arch and it goes behind and to the left side. But अगर आप ध्यान दीजिए तो यहाँ से from the right ventricle there is emergence of pulmonary trunk, and then there's a bifurcation of the pulmonary trunk. But the pulmonary trunk bifurcation जो होता है, the pulmonary arteries, they are basically in front of the ascending aorta or behind? They are just behind, right? So this structure which they have actually asked in the exam is actually a structure which is just behind the ascending aorta, and that would probably be the pulmonary trunk or its bifurcation. So therefore, if you go with the options, option number A is the closest option over here. If the arrow was over here, let us see the other options as well. Now, option number B, if esophagus, think about esophagus. Where would be the esophagus? Esophagus is actually more behind. It is more behind. It's behind the heart, right? So esophagus is actually located, and understand in esophagus you won't get a complete lumen because it is a collapsed structure. So esophagus ki location will be somehow around over here. This will be the location of esophagus, right? Arch of aorta obviously is not seen over here because you are seeing the ascending descending aorta. SVC. Now SVC is to the right side. It's to the right side and empties into the right atrium, right? And it is to the right of what? It is right and anterior to the ascending aorta, right? If you look at this image, तो यहाँ पर कहीं आपका SVC ऊपर से आ रहा होगा. That again is a venous structure, again a collapsed structure. उसकी location, तो SVC की location would be somewhat around over here, है ना? So the answer for this particular question, if the arrow is right at this position, will be the pulmonary trunk. और अगर option में आपके bifurcation था, then it is fine. Actually, you can see the bifurcation over here. This area, if you look at it carefully, if I just delete this whole stuff, and if I show you this area, you can see the bifurcation. You can see the bifurcation of pulmonary trunk. Okay, so going with this, we think it should be the pulmonary trunk or its bifurcation. चलिए अब देखते हैं अगला question. Pterion on the later side of the skull, one of the most commonly asked question in INI-CET. एक दो साल से नहीं, पिछले 5-6 सालों से. Pterion is frequently asked. तो एक तो ये हो गया, it is a must know topic for if you are going to appear for INI या फिर NEET PG. Pterion पता होना चाहिए. Nowadays, till now, questions have come कि टीरियन में विच आर द 4 बोन्स, वी नो द 4 बोन्स ओवर हेयर आर विच वंस, आगे आपकी फ्रंटल है, पैराइटल है, इधर टेम्पोरल है, यहाँ ग्रेटर मेंगोस्फेनॉइड है, दे फॉर्म एन H-shaped suture. Then the questions have also come कि कौन सा हेमरेज होता है, we all know epidural hemorrhage. Now this time they asked that which sulcus is present over here at this point about the terion. So first of all we should know that they have asked about the terion and they are asking which sulcus. Now terion में normally we confine ourselves to the knowledge कि हाँ यहाँ पर there is an anterior division या anterior trunk of the middle meningeal artery जो कि EDH कराएगी. So there is middle meningeal artery, we all know. But there is a sulcus over here. So deep to the terion, okay, you have all the meninges. Meninges के अंदर you have the brain. Deep to the terion you have one more vessel. वो कौन सी है? That is your middle cerebral artery. That is the middle cerebral vessels. Middle cerebral vessels होती हैं just deep to the terion related to the brain. अब middle cerebral vessels कहाँ से निकलेंगी? They come out from the lateral sulcus. जो आपको lateral sulcus होता है यहाँ पर, which is between the frontal lobe above and the temporal lobe below. ऊपर नीचे, ऊपर frontal, नीचे temporal, बीच में lateral sulcus. वहां से निकलती है middle cerebral vessels, right? So they are asking basically कि यहाँ पर कौन सा sulcus मिलेगा? The answer for that will be the stem of lateral sulcus. ठीक है, stem of lateral sulcus. Let me show you an image of the brain over here. और यहाँ से आप कुछ idea लीजिए. Right, this is the left hemisphere which you are seeing. This is over here the anterior aspect. ये हो गया posterior aspect. This over here, this is the lateral sulcus. That is the stem of lateral sulcus. अगर आप कभी वो देखें उसकी इमेज, द vascular image, vascular supply of the brain, you will see vessels coming out of it. All these are actually branches of what? Middle cerebral artery, right? MCA you have 3-4 parts, and MCA comes out from the stem of lateral sulcus. उस तरह से it will then supply it is a major supply of the superolateral part or superolateral surface of the brain hemisphere. Right? So therefore answer for this question will be the stem of lateral sulcus. Now other options are not very far off. Inferior frontal sulcus हो गया, that will be this one over here. यहाँ पर कहीं position आएगी inferior frontal sulcus की, parietal sulcus और superior temporal sulcus. They're also nearby. But yes, आपको याद करनी कुछ vessels. The vessel over the terion, right? The vessel over the terion. अगर terion superficial पूछेंगे आपसे, then there's a superficial temporal vessels. उसके आप डीप में जा रहे हो, then just deep to the terion you have the anterior division of middle meningeal vessels, EDH, epidural hemorrhage. But if you talk of the brain, वहाँ पर lateral sulcus and there you have the middle cerebral vessels. तो याद कीजिए, याद रखिए, ये terion बड़ा important है, clinical important. So this we should know, and this time they ask us this question. चलिए अगला question देखते हैं. Okay, another favorite topic and the very important topic I would say. Internal oblique and transverse abdominis muscles both make which boundaries of the inguinal canal? Now, inguinal canal, inguinal hernia, every time we say कि भाई hernia में से या hernia के related topics में से question आना ही आना है. Why? Because it is so common. You go to the surgery OPD, you go to the surgery wards, you go to the OT of surgery. आप डेली जाएंगे किसी अच्छे चलते फिरते अस्पताल में, you will see a cases of hernia on a daily basis, day to day basis, मिलेगा. Therefore, the question came from anatomy this time about the anatomy of the inguinal canal. क्या पूछा उन्होंने? Internal oblique or transabdominis. Now, this is a question from the anterior abdominal wall anatomy, right? And from it is from इससे क्या बन रहा है? Inguinal canal की anatomy. Okay. Now, internal oblique and transverse abdominis, we have done this multiple number of times. दोनों मिलकर क्या बनाते हैं? They both form the conjoint tendon. ये बनाते हैं conjoint tendon, which is also known as क्या बोलते हैं उसका नाम? इसका fox inguinalis, right? And very importantly, जब आप पढ़ते हैं कि what are the ways in which the natural ways by which the hernia is prevented, the functional, physiological ways, तो आपसे पढ़ते हैं when we contract the abdominal wall, these muscles contract and they close the inguinal canal. Why? Because they are basically forming the roof. ये छत बना रहे हैं. जो inguinal canal है, मान लीजिए पूरा inguinal canal है, right? इसकी जो छत बनेगी, इसके जो ऊपर जो छत बनेगी, that is basically formed by these two muscles, internal oblique and transabdominis. But यहाँ पे कैच है, क्या कैच है? देखिए क्वेश्चन बहुत अच्छा है, very good question. INI-CET, let me tell you, which I have questions I have seen from many years. क्वेश्चन लगता सिंपल है पर हल्का सा कहीं हल्का सा ट्विस्ट होता है. We have to catch it. अगर हम कंसेप्ट क्लियर है बहुत आराम से पकड़ा जाएगा. कंसेप्ट क्लियर नहीं तो बहुत आराम से गलत भी होता है. जितना आराम सही होगा उतना आराम से गलत होता है. अब देखिए, internal oblique and transabdominis, right? They start from anteriorly. तो ये आगे भी हैं, ये रूफ में भी हैं, and then they go posteriorly. Remember I taught in classes that this is the inguinal canal, right? तो internal oblique transabdominis आगे से आता है, they form the roof and then they go behind, they form the conjoint tendon. तो ये आगे भी हैं, anterior wall on the lateral side, they are forming the posterior wall on the medial side, और roof में तो ही है.
बट याद की रखिए कि एंटीरियर वॉल में बेसिक कंट्रीब्यूशन कम्स नॉट फ्रॉम द ट्रांस एब्डोमिनस बट बेसिक कंट्रीब्यूशन इज कमिंग फ्रॉम द इंटरनल ऑब्लिक मसल, ना कि ट्रांस एब्डोमिनस। वो थोड़ा लेटरल और पड़ जाती है, अभी दिखाएंगे इमेज में। एंड पोस्टीरियर वॉल बेसिकली यहाँ कंजॉइंट टेंडन बन जाता है, दैट इज मोर मीडियली, ज्यादा मीडियली आ जाएगी। क्यों? बिकॉज इट हैज टू कवर विच रिंग, इट हैज टू कवर द सुपरफिशियल इंग्वाइनल रिंग। ये मैं ब्रैकेट में लिख देता हूँ। और देखिए नीचे तो हमारा इंग्वाइनल लिगामेंट, दैट इज एक्सटर्नल ऑब्लिक। तो रूफ विल बी द बेस्ट पॉसिबल आंसर ओवर हियर। अगर सिंगल ऑप्शन चॉइस पूछी गई है, रूफ याद रखिए विल बी द बेस्ट आंसर। लेट अस सी हियर इमेज ओवर हियर। दिस इज इंग्वाइनल कैनाल व्हिच यू आर सीइंग ऑन द राइट साइड। ठीक है, यहाँ पर पूरा पूरा आपको इंग्वाइनल कैनाल दिख रहा है निकलता हुआ। दो तीन चीजें यहाँ समझ लीजिए, बेसिक लैंडमार्क्स। वन इज अ सुपरफिशियल रिंग, ध्यान दीजिए कहां पर है, एंड वन इज अ डीप रिंग, ध्यान दीजिए कहां पर है। एंड देन योर टू मसल्स व्हिच वर आज इंटरनल ऑब्लिक यहाँ पर, ट्रांस एब्डोमिनस यहाँ पर। सो इंटरनल ऑब्लिक लाइज इन फ्रंट, ये हो गई हमारी इंटरनल ऑब्लिक, पीछे आ गई ट्रांस एब्डोमिनस, राइट। सो यू कैन सी कि इंटरनल ऑब्लिक ट्रांस एब्डोमिनस धीरे धीरे से दे आर फॉर्मिंग द रूफ, ये ऊपर चली जाती हैं। एंड देन दे फॉर्म बोथ जॉइन एंड दे फॉर्म व्हाट, दे फॉर्म दिस कंजॉइंट टेंडन posteriorly but posterior medially, because it has to cover which, it has to cover the superficial ring। जो superficial ring है यहाँ पर, इसको कवर करता है conjoint tendon। let me highlight in this way, ये आ गया हमारा conjoint tendon, ओके। और आगे internal oblique mainly है in front of deep inguinal ring। trans abdominis ऊपर से जाती है। आपको अगर सर trans abdominis लग तो रही जा रही है, the thing is over here is, अगर trans abdominis, if the trans abdominis was just going in front of it, या फिर आप कह दीजिए कि इंग्वाइनल कैनाल वाज पियर्सिंग थ्रू इट, देन ये जो स्पर्मेटिक फेशिया हैं, वन ऑफ देम शुड हैव बीन अ डेरिवेटिव ऑफ द ट्रांस एब्डोमिनस, एंड इट इज नॉट इन दिस केस। तो ट्रांस एब्डोमिनस थोड़ी लेटरल रह जाती है एनाटॉमिकली, याद रखिए। तो बेस्ट आंसर ओवर हियर वुड बी द रूफ। सो रिमेंबर द टॉपिक इन इंग्वाइनल कैनाल, वेरी इंपॉर्टेंट टॉपिक। चलिए अगेन आई गेस नॉट वेरी डिफिकल्ट क्वेश्चन, बट बेसिक्स, अगेन बेसिक्स को टच करना नहीं छोड़ना है। इट इज अ लेसन टू ऑल ऑफ अस कि हमें बेसिक्स को टच करना नहीं छोड़ना है। We can't leave them alone, क्योंकि वो backfire करेगा, it will backfire। Apocrine glands, we all know in our first year, भूल जाते हैं बाद में। But apocrine glands, we all know, are specialized sweat glands, present where? Present in the axilla, in the genital region, around the areola, around the umbilical region। वहाँ पर सारे apocrine sweat glands हैं। More functional or more secretory in the pubertal age में। Over here, answer was simply axilla over here। बाकी जगह पर तो मेजॉरिटी स्वेट ग्लैंड्स आर इक्राइन स्वेट ग्लैंड्स, जो पाम में, सोल में, फीट में, वहां पर काफी होता है थ्रू आउट द बॉडी। बट एपोक्राइन आर स्पेशलाइज्ड स्वेट ग्लैंड्स। याद रखना द बेसिक्स, एक्सिला, जेनाइटल रीजन, एरियोला रीजन, पेरिअम्बिलिकल रीजन, ऑल दीज रीजंस, राइट। तो अगेन टचिंग द बेसिक्स, डोंट फॉरगेट द बेसिक्स। देखिए बेसिक्स में से आ गया क्वेश्चन। चलिए अगला देखते हैं। अगेन मेलियस इनकस जॉइंटस, आपको याद होगा 1-2 साल पहले, आई रिमेंबर लास्ट ईयर ओनली, द क्वेश्चन केम, दे शोड एन इमेज of a bone, incus I suppose was the bone over there, and then they asked ये कौन सी bone है ना, and this time they asked you which type of joint। so देखिए क्वेश्चन रिपीट नहीं हो रहा है, टॉपिक्स रिपीट हो रहे हैं। ये हमें सब लोग आपको बताते हैं, हम सुनते भी रोज 10 बार हैं, पर जिसने इस बात को अमल किया है, whoever followed this is on a happy mood। तो हमें टॉपिक पकड़ना है। अब देखिए उन्होंने इनकस लास्ट टाइम पूछा था, अब क्या पूछ रहे हैं, जॉइंट। so this is the malleus over here, ये हमारी इनकस है, ये स्टेपीज है, और ऑब्वियसली दे ऑल वाइब्रेट। हमें पता सबको पता है कि ऑडिटरी साउंड्स हाउ द बोनी कंडक्शन इज हैपनिंग। सो मेलियस इनकस जॉइंट है, दिस इज बेसिकली अ सैडल वैरायटी ऑफ साइनोवियल जॉइंट। एंड इनकस स्टेपीज, क्योंकि यहाँ पर स्टेपीज का बॉल जैसी बन जाती है, दीज आर ऑल मिनिएचर। ये बॉल एंड सॉकेट की तरह इट अपीयर्स लाइक, ऐसा नहीं है कि इस मूवमेंट इसका पूरा 360 डिग्री हो जाएगा, मल्टी एक्सिट हो जाएगा, बट यस दे हैव वेरिड मूवमेंट्स। सो मेलियस इनकस प्रोबब्ली वी शुड बी नोइंग, इट इज अ सैडल वैरायटी में आता है, राइट। अगेन टॉपिक क्या है, टॉपिक हमारा जॉइंट्स है, टॉपिक हमारा मिडिल ईयर की बोन्स है, जिनके जॉइंट्स का नाम पता होने चाहिए था, राइट। सो आंसर ओवर हियर विल बी द सैडल वैरायटी ऑफ साइनोवियल। चलिए आगे बढ़ते हैं। इनकरेक्ट अबाउट एड्रीनल, अगेन दिस टाइम एब्डोमेन वाज आस्क्ड। सो देखिए अच्छा क्वेश्चन आ गया, किडनी नहीं पूछी, एड्रीनल ग्लैंड। नाउ दिस आर ऑल रिकॉल, सो यू कैन अंडरस्टैंड कि लैंग्वेज थोड़ी इधर उधर होगी क्वेश्चन की, बट बेसिक फीचर ही है। अब देखिए एड्रीनल ग्लैंड इनकरेक्ट पूछा है, ऑप्शंस पढ़ते हैं। एड्रिनल ग्लैंड वी ऑल नो, दे आर आल्सो नोन एज सुप्रारीनल, ये किडनी के ऊपर रखे हुए हैं। फाइन वी ऑल नो इनके काम क्या क्या हैं। एम्ब्रियोलॉजी वी शुड बी नोइंग, एड्रिनल मेडुला की डिफरेंट एम्ब्रियोलॉजी, कॉर्टेक्स की डिफरेंट एम्ब्रियोलॉजी, फाइन। इन्होंने क्या पूछा, इनकरेक्ट। देखते हैं, वो 3 सही स्टेटमेंट होंगी, एक गलत होगी। येलो कलर्ड स्ट्रक्चर्स, यस वी ऑल नो कि हाँ येलो कलर्ड स्ट्रक्चर्स होते हैं, किडनी के ऊपर रखे हैं, तो ये तो सही लग रहा है। लेफ्ट एड्रिनल इज नियर टू द टेल ऑफ पैनक्रियास एंड स्प्लीन। अब ये आ गया, ये स्टेटमेंट इज कमिंग फ्रॉम द रिलेशंस ऑफ द एब्डोमिनल ऑर्गन्स, इट इज कमिंग फ्रॉम द रिलेशंस। अब देखो यहाँ पर आप कॉमन सेंस लगाइए, स्प्लीन कहाँ पर है? स्प्लीन हमारा लेफ्ट साइड में बिहाइंड द स्टमक, तो वहीं पर कहीं रिलेशन है होना चाहिए किडनी का भी, बिल्कुल। स्प्लीन, इफ यू रिमेंबर रिलेशन ऑफ स्प्लीन, वी हैव द लेफ्ट किडनी, और वहीं पर किडनी के ऊपर रखा लेफ्ट एड्रीनल, तो ये तो बिल्कुल सही है। एंड टेल ऑफ पैनक्रियास, अब टेल ऑफ पैनक्रियास देखिए स्प्लीन में एंटर कर रही है। टेल ऑफ पैनक्रियास इज एक्चुअली गोइंग इनटू द हाइलम ऑफ द स्प्लीन। इफ यू रिमेंबर द टेल ऑफ पैनक्रियास गोइंग इनसाइड, तो हमें जब स्प्लीनेक्टोमी करते हैं, वी लाइगेट द स्प्लीनिक वेसल्स, वी हैव टू टेक केयर नॉट टू डैमेज द टेल ऑफ पैनक्रियास, है ना। और वहीं पर सो दिस एड्रीनल इज रिलेटेड पोस्टीरियर टू द पैनक्रियास एंड स्प्लीन, हमें समझना है। व्हाई? बिकॉज एड्रीनल एंड किडनी आर प्राइमरी रेट्रोपाइटोमियल, पीछे है, राइट, एंड टेल ऑफ पैनक्रियास एंड स्प्लीन इज इन फ्रंट ऑफ इट, तो दिस स्टेटमेंट इज अगेन करेक्ट। राइट एड्रीनल इज सेमिल्यूनर, ये हमें बेसिक एनाटॉमी यहाँ समझनी थी, तभी कहते हैं इमेजेस देखते रहो, इमेजेस देखते रहो। कभी कभी इमेजेस देखी आपने, अचानक से एग्जाम में यू गेट टू नो नहीं यार वो लेफ्ट वाला कुछ सेमिल्यूनर बिकॉज इट इज हाफ मून शेप, लेफ्ट वाला लग रहा है, राइट वाला तो पिरामिडल शेप। जी हाँ, तो आंसर ओवर हियर इज ऑब्वियसली दिस इज द इनकरेक्ट स्टेटमेंट। व्हाई? बिकॉज राइट एड्रीनल जो है ये आपका पिरामिडल शेप होता है, इज पिरामिडल इन शेप। जो ये सेमिल्यूनर शेप है दैट इज अबाउट द लेफ्ट एड्रीनल, एंड ऑब्वियसली दे आर प्राइमरी रेट्रोपाइटोनियल, अगेन करेक्ट स्टेटमेंट। प्राइमरी रेट्रोपाइटोनियल मतलब कि सबसे पीछे होते हैं ये, along with the kidney and the post abdominal wall. Beautiful question, simple question है, but एक एक ऑप्शन समझना है, बिकॉज जो क्वेश्चन सिंपल दिखता है उसमें एज आई टोल्ड यू INI में एक छोटा सा ट्विस्ट होता है, पकड़ना होता है उसको, राइट। एक दो इमेजेस देखते हैं इसमें। सो हियर यू कैन सी, यहाँ आप देख सकते हो, दिस इज द लेफ्ट किडनी ओवर हियर एंड ओवर इट इज सिटिंग द लेफ्ट एड्रीनल, यहाँ रखा हुआ है, राइट। यू कैन सी द राइट एड्रीनल क्लोज टू द IVC, ये भी एक इंपॉर्टेंट सवाल आ सकता है। अब टॉपिक आप पकड़ के रखिए, नीट पीजी में दे विल रिपीट दिस, नॉट द क्वेश्चन पर से, बट टॉपिक तो पक्का रिपीट होना है। राइट एड्रीनल क्लोज टू IVC, एड्रीनल वेन, राइट एड्रीनल वेन गोइंग टू IVC, रिलेशन समझिए। एंड हियर यू कैन ऑल्सो अंडरस्टैंड कि यहाँ पर आगे स्प्लीन, पहले टेल ऑफ पैनक्रियास है, उसके बाद स्टमक है, स्टमक और एड्रीनल के बीच में स्प्लीन भी आएगी। ओके, लेट मी शो यू दिस इमेज। ये क्या इमेज है? जस्ट फॉर योर अंडरस्टैंडिंग, दीज आर द रिलेशंस ऑफ द किडनी। का कोई लेना देना नहीं क्वेश्चन से डायरेक्टली, बट इनडायरेक्टली बहुत बड़ा लेना देना है। लेट अस अंडरस्टैंड। अब देखिए यहाँ पर क्या क्या चीजें हैं। दिस इज द सुप्रारीनल एरिया, यहाँ पर आपका एड्रीनल आ रहा है, और यहीं पर आपका स्प्लीन है, और यहीं पे आपका पैनक्रियास है। विच पार्ट ऑफ पैनक्रियास विल बी देयर? हियर यू विल हैव द टेल ऑफ पैनक्रियास गोइंग टू द स्प्लीन, और यहीं पे यू हैव द लेफ्ट एड्रीनल, वेरी क्लोज रिलेशंस, राइट। चलिए, लेट्स सी द नेक्स्ट वन। ओके, one more question came. Section through the ascending aorta of the heart, name the mark. The marked structure which we got from the recall was somewhere over here. यहाँ पे कहीं structure marked था, and this area is basically, अब समझना है ये section क्या है. The image might not be this, somehow related to this, which I'm not very sure because you guys must be given the exam. But चीजों को समझो, ये structure क्या है. This we are looking at a superior view of the heart. तो ये जो vessel आपको दिख रही है, this is basically the aorta, right? This is the right side, that is the left side. यहाँ पर आपका आगे एंटीरियर है, पीछे पोस्टीरियर है। ओके, सो यू आर प्रॉब्ली सीइंग द एओर्टा ओवर हियर, ठीक है, and this is probably the left atrium over here. यहाँ पर you get the aortic curtain. Actually इसका complete name would be the aortic mitral curtain, AMC बोलते हैं, so known as the AMC, aortic mitral curtain, and basically it is lying between the aortic root of the aorta and the mitral wall. उनके बीच में जो एरिया होता है, what is the importance of this? Basically it is actually forming the fibrous skeleton of the heart. The fibrous skeleton of heart क्या होता है? Basically heart is totally a muscle, but there in the center of the heart there is fibrous skeleton which is forming the base of all the walls. सारी वॉल उनका बेस ही तो बनाना है कोलेजन से. That is basically fibrous skeleton. And between the aorta and the mitral wall there is a curtain known as aortic mitral curtain, AMC. Right, cusp of mitral and aortic. So what was the feedback we got from the students? बस को बोला था कि सर यहाँ पर arrow was between the aorta and the mitral. So probably it should be the aortic curtain if we go with the recalls over here. चलिए जी, और देखते हैं आगे. हाँ, this is an image over here. अब यहाँ पे clearly you can see over here, this is the AMC, aortomitral curtain over here, and this is the aortic valve over here. यहाँ पे सारा आपका aortic cusp दिख रहा है, यहाँ पे आपका mitral leaflets हैं, आगे pulmonary valve दिख रही है. That all we can see. Right? Pulmonary valve यहाँ पर आगे है. अब कभी कभी confusion ना हो, then let me tell you, because right ventricle is more anterior देन लेफ्ट वेंट्रिकल, इसलिए सबसे पहले यहां से निकलेगी पल्मोनरी ट्रंक ही, बट पीछे से देन यहां से एओर्टा आता है, एंड देन दिस पल्मोनरी ट्रंक बाइफरकेट्स एंड देन इट गोज बिहाइंड. सो द बिगिनिंग ऑफ द पल्मोनरी वॉल, बिगिनिंग ऑफ द पल्मोनरी ट्रंक विल बी एंटीरियर बिगिनिंग, बट देन इट गोज पोस्टीरियरली. क्यों? क्योंकि उसे जाना है लंग्स में, राइट. दिस इज द थिंग ओवर हियर. तो दिस वाज एक्चुअली द क्वेश्चन दैट वाज आस्क्ड. चलिए अगला देखते हैं. Oh, there was a cadaveric section over here, and probably a coronal section was given, and most of the students said that some area was marked which was probably subthalamic area over here, right? A part of the functional part of the basal ganglia and anatomical part of the diencephalon. We all know. So, ये coronal section की कोई image है यहाँ पर. You can understand this area is basically the thalamus over here, and obviously below thalamus over here somewhat you have the subthalamic nucleus over here. Now, subthalamus was probably marked. Right, when the question was probably marked over here, so there must be an arrow in the exam, but probably it is subthalamus. And then they ask you कि उसका function क्या है? Subthalamic nuclei का function क्या है? As I told you, functionally we have done in the classes also. It's a part of the basal nuclei या फिर basal ganglia बोल दो आप. And we all should be knowing there is two pathways, the direct and indirect pathway. And basically there are two things which I have repeated again and again. हमारे ब्रेन में ऐसी दो स्ट्रक्चर्स हैं which are helping the motor system. One is the basal nuclei and second is the cerebellum. So obviously subthalamic nucleus, which is related to the basal nuclei functionally, is associated with the motor system over here. Motor system. और कौन सा pathway? Basically indirect pathway. Right? So आप याद कीजिएगा उसमें we have done both the pathways. So this subthalamic nucleus basically directly, so subthalamic nucleus directly goes to GPI. GPI क्या है? Globus pallidus internus. Right, the most medial part of the whole lentiform nucleus. So it is a part of the indirect pathway. So motor to thoda sa it inhibits or it decreases down the unwanted actions. Right. So subthalamus was probably marked over here, and function if they would have been a motor. अगर कुछ और marked था, say some students were saying so hypothalamus marked था. Hypothalamus has a lot of functions, we all know. There are multiple nuclei in hypothalamus. So function वहाँ पे बहुत ही varied है. It is controlling the endocrine system, it is controlling the motor system, it is controlling so many systems. आपके भूख प्यास, hunger, thirst, आपका body temperature, आपका पूरी body homeostasis is all under control of hypothalamus. ठीक? So remember that also. If it is probably subthalamus, then motor over here would be the answer. और भी options देख लो. देखो reward punishment basically would be basically a function of the limbic area, right? हम पढ़ते हैं इसको limbic area, the ring-shaped structure, cingulate, gyrus, hippocampus, all of that is basically this. Memory we all know, again hippocampus का काम है. Judgment we all know, the frontal lobe basically is mainly involved for the decision making or the judgment, right? So therefore we can go with the motor over here. चलिए एक question again, what I can say, easy question only. The tributaries of IVC. Now, IVC we all know is the basic vein in the abdomen, present on the right of midline. अब लेफ्ट गोनेडल वेन है, राइट? अब देखिए ये मैं दो वेन बना रहा हूँ, एक थोड़ी लंबी वेन, एक थोड़ी छोटी वेन है. आइडेंटिफाई कीजिए. दिस मस्ट बी द लेफ्ट रीनल वेन एंड दिस मस्ट बी द राइट रीनल वेन, है ना? दिस इज लेफ्ट रीनल, दैट इज द राइट रीनल वेन कमिंग फ्रॉम द हाइलम ऑफ द किडनी. अब जो फर्स्ट द लेफ्ट गोनेडल वेन है, दैट बेसिकली एंटर्स वेयर? इट एंटर्स इनटू द लेफ्ट रीनल वेन. सो लेफ्ट गोनेडल, व्हेन वी से लेफ्ट गोनेडल वी मीन टेस्टिकुलर ओवेरियन बोथ. अब सर याद कैसे करें? रिमेंबर द वेरिकोसील, है ना, मोस्टली ऑन द लेफ्ट साइड. तो ये तो देखिए ट्रिब्यूटरी डायरेक्ट है नहीं. राइट असेंडिंग लंबर वेन ये क्या बनाता है? रिमेंबर, राइट असेंडिंग लंबर वेन प्लस राइट सबकॉस्टल वेन. हम वी हैव डन सो मेनी टाइम्स इन आवर क्लासेस एंड इन आवर ऐप आल्सो. क्या बना रहा है? फॉर्मिंग द जाइगस वेन, राइट? इट्स फॉर्मिंग जाइगस वेन. सो दो इट इज कनेक्टेड टू द आईवीसी, नो डाउट अबाउट इट, क्योंकि राइट साइड में है, असेंडिंग लंबर वेन है, बट बेसिकली इट इज फॉर्मिंग अ ट्रिब्यूटरी टू द जाइगस वेन. And then the left renal, देखिए left renal तो directly I also showed you कि सीधे घुसनी है where into the IVC. ये तो IVC में जानी है. Let me show you a couple of images also. IVC की image देख लो. Here what you are seeing, you can see very well, see the left renal vein. ये दिख रही है आपको left renal vein going in front of aorta. याद रखिए nutcracker syndrome. अब जो भी सवाल पूछे गए हैं for NEET PG, याद रखिएगा, टॉपिक्स पकड़ कर रखिए, इनमें सवाल आने हैं. And then you can see the left testicular ovarian vein कहाँ जा रही है? Into the left renal vein, right? And the ascending lumbar vein, let me show you this azygous vein वाला image. In thorax we study, this is the ascending lumbar vein. किसके साथ मिल रही है? Right subcostal. क्या बना रही है? Azygous vein. Azygous present where? In the thorax region, posterior mediastinum, draining the posterior intercostal veins. So सब क्या drain करती है? All the posterior intercostal veins. Okay, so therefore answer fourth option I am not sure. आपको याद हो तो can write in the comment box क्या options क्या थे, or is there any change, any difference, but you should be sure कि सर ये नहीं यही पूछा गया था. I am 110% sure. बिल्कुल comment box में लिखिए and then we will have a discussion on that also, but you should be sure. चलिए आगे चलते हैं. अगला क्वेश्चन देखें. मसल एक्शन, I was told कि एक क्वेश्चन आया था मसल एक्शंस में से. अपर लिम्ब का क्वेश्चन, ब्यूटीफुल आई वुड से ब्यूटीफुली फ्रेम्ड एनाटॉमिकल क्वेश्चंस, बट यस जिसकी एनाटॉमी मतलब बेस अच्छा है फॉर देम गुड, जिसका बेस उतना अच्छा नहीं है फॉर देम मे बी आई होप कि बाकी सब्जेक्ट्स अच्छे कर रखे होंगे. सो यस, मसल एक्शंस. अब देखिए, दीज ऑल मसल्स आर नॉट एनी स्मॉल मसल्स, दीज आर मेजर मसल्स. बड़े बड़े मसल्स हैं ये. सो बेसिकली वी शुड बी नोइंग देयर बेसिक एक्शन. अब lot of times people ask me कि sir, being an anatomy faculty, sir, how to remember the action of the muscles? Basic question. You enter the first year, आपका पहला सवाल ये होता है, आपने पहला प्रॉफ दिया, आपने पहला इंटरनल पार्ट वाइवा दिया, क्वेश्चन इज सर ये एक्शन याद नहीं हो रहा है. आई ऑलवेज से कि एक्शन याद करने बैठोगे नहीं होंगे. याद करना क्यों है, ये इतना बड़ा ब्रेन क्यों है, समझो उसको कि अगर मसल कॉन्टेक्ट करी तो मूवमेंट क्या होगा. अब लैटिसिमस डोर्सी कहाँ है, इट इज अ लोअर बैक मसल, इट इज अ लोअर बैक मसल इंसर्टेड वेयर इन फ्रंट ऑफ ह्यूमरस. यहाँ पर आगे इंसर्ट हो रही है, a lady between two major. तो व्हाट वुड बी द मेन एक्शन ऑफ द लैटिसिमस डोर्सी? एक्शन क्या होगा? विल इट कॉज फ्लेक्शन और एक्सटेंशन? भाई ये कराएगी एक्सटेंशन. ओके फाइन. विल इट कॉज मीडियल रोटेशन और लेटरल रोटेशन, या फिर बोल दो इंटरनल रोटेशन और एक्सटर्नल रोटेशन? ये क्या कराएगी लैटिसिमस डोर्सी? इट विल कॉज द इंटरनल रोटेशन. लिख दो जी इंटरनल रोटेशन, राइट. It is causing extension, it is causing internal rotation. ये सब चीजें पता होनी चाहिए. And then it is pulling the humerus, or it is pulling the arm medially. It also causes adduction. Basic actions. अब देखिए infraspinatus है. Now it is coming from the scapula below the spine. कहाँ insert हो रही है infraspinatus? SIT, remember, greater tubercle. तो insert हो रही है on the posterior part of humerus. तो infraspinatus निकली scapula के पीछे से निकली, पीछे insert हो गई. क्या actions होंगे इसके? Which rotation will it cause? हमने एक बार निमोनिक बनाया था LRTI, अगर आप लोगों को याद हो क्लासेस में. लेटरल रोटेशन T था यहाँ पर टीरियस माइनर और I था यहाँ पर इंफ्रास्पाइनेटस. देखिए इतना निमोनिक यहाँ पर यूज हो जाएगा. बिल्कुल, इट इज कॉजिंग इन लेटरल रोटेशन एंड स्लाइट एडक्शन, बट मेन काम इसका लेटरल रोटेशन है. Okay, then the supraspinatus we all know. Initiation of abduction 0 to 15 डिग्री पढ़ते हैं तो ये हमारा करा रहा है abduction करा रहा है. I was told कि there were 5 options, मैच करना था इसमें, right? So we go with the options. P major तो पता होना चाहिए, it is present anteriorly. तो क्या करा रहा है? flexion, medial rotation, adduction, famous muscle. So ये कराएगा हमारा basically flexion, medial rotation, adduction, all these are. But yeah, बेसिक सवाल ये है. इफ यू गो टू डिटेल्स ऑफ पी मेजर हैज डिफरेंट पार्ट्स, उसके अलग अलग पार्ट के अलग अलग एक्शन. बट यार बेसिक अगर दिस कॉमन नॉलेज इज दिस, यू कैन चॉक इट आउट कि हाँ यार इसमें क्या क्या ऑप्शंस दिए थे, हैव आई मार्क देम करेक्ट और नॉट. ओके चलिए, तो मसल एक्शन सवाल आया, नाइस टू सी. हाँ, वन क्वेश्चन दिए अगेन, एवरग्रीन क्वेश्चन, ट्रेंडलेनबर्ग गेट. वी ऑल नो स्ट्रक्चर इन्वॉल्व. तो क्या क्या स्ट्रक्चर इन्वॉल्व होते हैं इसमें? आई वाज नॉट गिविंग द पर्टिकुलर, यू नो द टॉपिक केम. सो वी ऑल नो इसमें यू हैव द सुपीरियर ग्लूटियल नर्व इंजरी, एक कॉज ये हो सकता है, राइट. मसल्स कौन सी जाएंगी? ग्लूटियस मीडियस एंड ग्लूटियस मिनिमस, ये चली जाएंगी. देयर विल बी व्हाट? देयर विल बी अ लॉस ऑफ एबडक्शन एट विच जॉइंट? एट द हिप जॉइंट, ये होगा. ये गेट और किस में मिल सकता है? ये गेट मिल सकता है आपको, आपका यू माइट हैव द फ्रैक्चर हो जाए, किसका? नेक फीमर का फ्रैक्चर हो जाए. और यू माइट आल्सो हैव द डिसलोकेशन हो जाए हिप का. There are multiple cases now. You can chalk it out कि हाँ यार एग्जाम पूछा क्या गया था. So अगर इसमें obviously बेडलिंग गेट होती है, the side of the pelvis which is falling down, वो साइड ठीक होती है. दूसरी साइड, अपोजिट साइड, on which the whole weight, अगर राइट पैर से बंदा चल रहा है, राइट पैर जमीन पर रखा, लेफ्ट साइड पेल्विस की टिल्ट वो नीचे जा रही है, then राइट साइड सुपीरियर ग्लूटिनरी इंजरी है. ये बात याद रखनी है, हर बार बताया जाता है, वेरी वेरी इंपॉर्टेंट, और बार बार पूछा भी जा रहा है. सो नथिंग लाइक दैट. सो आई होप आप सबने आंसर सही किया था. एक और क्वेश्चन रिलेटेड टू यही था आपका, एक इमेज थी उसमें यहाँ पर आपको फिबुला में एक एरो होगा, यहाँ पर बताएगी यहाँ पर इंजरी होगी तो क्या होगा. नाउ वी ऑल नो दैट द नर्व व्हिच पासेस फ्रॉम हेयर, यहाँ पर कौन सी नर्व कर्व डाउन करती है? वी ऑल शुड नो नर्व इज द कॉमन पेरोनियल नर्व, CPN. The CPN gives rise to which two other nerves? Superficial peroneal and deep peroneal nerve. This supplies the anterior leg, ये कर रही है lateral leg. तो CPN इंजरी में क्या होगा? If the anterior leg muscles are gone तो क्या होगा? There will be a foot drop. तो गेट कैसा? हाई स्टेपिंग गेट होगा, राइट. लाइक यू हैव रिस्ट ड्रॉप इन रेडियल नर्व इंजरी, यू हैव फुट ड्रॉप. तो यहाँ पे आप हाई स्टेपिंग गेट आ जाएगा, है ना. वेडलिंग गेट तो में पढ़ा भी है. सुपीरियर ग्लूटिनल नर्व इंजरी है, यहाँ तो नहीं है ग्लूटिनल नर्व. हियर वी हैव द कॉमन पेरोनियल नर्व. क्रॉस लेगेड का अलग है, वो ऑपरेटिव नर्व की यहाँ पे स्पाज्म हो जाएगा, वहाँ पे क्रॉस लेगेड हो सकता है. So here the answer will obviously be the high stepping gait, common peroneal nerve injury, right? तो याद रखना आपको ये बेसिक चीजें हैं. एंड रिपीटेड, ऐसा नहीं है कि एक बार रिपीट हुआ है, ये मल्टीपल टाइम, मतलब 8-10 बार आराम से रिपीट हो गया होगा इफ यू टेक आउट द प्रीवियस ईयर क्वेश्चंस. चलिए और देखने क्या सवाल था. एक क्वेश्चन यहाँ पर अगेन 3 point bony connection. We all know 3 point है आपके lateral और medial epicondyle and the tip of the olecranon process. Here they are showing in the flexed elbow and in the extended elbow, है ना. तो in a flexed elbow you make sort of equilateral triangle over here. In the extended एक लाइन में आ जाता है. Question was कि is not lost. जो 3 point जो है ये equilateral triangle जो बन रहा है, isosceles triangle बन रहा है, कि किसमें लॉस नहीं होगा. तो देखिए वी ऑल नो कि ऊपर से ह्यूमरस एंड देन वी हैव बोथ ऑफ दीज कॉन्डाइल्स, पीछे ओलेक्रोनॉन है, यहाँ पे तो कॉन्डाइल हो गए, नीचे यू हैव द रेडियस ओवर हियर एंड हियर यू हैव द अल्ना जिसका यूज ओलेक्रोन प्रोसेस. ऑप्शंस, दिस अगेन दिस इज एन ओल्ड क्वेश्चन, लेट डिलीट सम, पहले बहुत पूछा जाता था ये. इफ यू हैव अ सुप्राकॉन्डाइल फ्रैक्चर, अगेन दैट विल बी आल्सो डेल्ट इन ऑर्थोपेडिक्स आल्सो, वहां भी आपको ये बताया जाएगा. इफ यू हैव अ सुप्राकॉन्डाइल फ्रैक्चर यहाँ है तो इस 3 पॉइंट में तो कुछ फर्क नहीं पड़ रहा है. There is no problem in it. So supracondyle में it will not be lost. Fine. अगर medial epicondyle, lateral epicondyle और elbow का ही पूरा dislocate, अब elbow is what? Elbow is junction or the joint between the humerus and the ulna. अगर वही dislocate हो गया तो साइड से बात है इन तीनों में it will be disturbed. So obviously supracondyle fracture it is saying I'm above the condyle. और the 3 point जो bony relation है that is at the level of the condyles and below it. तो condyle के ऊपर है तो मतलब नहीं है. सुप्राकॉन्डल फ्रैक्चर में दिस बोनी रिलेशन विल नॉट बी लॉस्ट. याद रखना इस चीज को, ठीक. इमेज आई होप वाज नॉट देयर इन द एग्जाम और इट वाज देयर, आई कैन फिगर इट आउट. चलिए अगेन अ क्वेश्चन फॉर एम्ब्रियोलॉजी, ब्यूटीफुल क्वेश्चन आई वुड से. क्वेश्चन है व्हिच ऑप्शन इज इनकरेक्ट. क्वेश्चन ऐसा कुछ था एंड ऑब्वियसली यू कैन सी द इमेज. दिस इज सैक्रोकॉक्सियल टेराटोमा. दिस सैक्रोकॉक्सियल टेराटोमा क्वाइट कॉमन, नॉट वेरी कॉमन बट स्टिल क्वाइट कॉमन. क्या गलत है इनमें से? इज इट अ बेनाइन ट्यूमर ऑफ कॉक्सिस? देखिए इट कैन बी अ बेनाइन और इट कैन बी मैलिग्नेंट आल्सो. ऑब्वियसली कॉक्सिस भी कह सकते हैं बिकॉज़ इट इज नियर द कॉक्सिस द रीजन ऑफ टेल. तभी तो बोले सैक्रोकॉक्सियल टेराटोमा. ऑप्शन ए को रखते हैं अभी. प्रेजेंस ऑफ टीथ एंड यस टेराटोमा, प्लूरिपोटेंट स्टेम सेल्स. देयर आर हेयर्स, देयर आर टीथ, देयर आर द मसल्स आल्सो कैन बी फाउंड इनसाइड इट. टेराटोमा है. एनी ऑफ द 3 जर्म लेयर्स कुछ भी डेरिवेटिव हो सकता है, राइट. ट्रांसलोकेशन ऑफ प्राइमोर्डियल जर्म सेल्स, वन ऑफ द मोस्ट इंपॉर्टेंट कॉजेज ऑफ इट. or translocation of epiblast cells or some problem in the say primitive streak आपको याद हो when we study the 3 germ layers or the 3 weeks in general embryology, the 3rd week में from the caudal line there's a primitive streak. So उसमें कोई problem आ जाए तो these are the common reasons for development of the teratoma embryologically. Precaudal plate and precaudal plate. अब देखिए precaudal plate, if you remember that disc जो हम image बनाते हैं, that disc की image जो बनाते हैं with the, and there is precaudal plate on the cranial aspect, right, on the cranial aspect where you have the fusion of epiblast and hypoblast. ये कहाँ पर this from which part embryologically or in adult ये क्या चीज बनाता है? It is close to which part? It is close to the mouth oropharyngeal area. अब यहाँ पर sacrococcygeal है, बात precaudal plate की यहाँ हो रही है. Obviously that would be the answer. अगर ये ऑप्शन था then this would be the incorrect statement. सो ऑप्शन ए अगर देखें बिनाइन भी हो सकता है, मैलिग्नेंट भी हो सकता है. ओके, सो ऑप्शन नंबर डी वुड बी द आंसर. प्रीकॉर्डल प्लेट का कोई लेना देना ही नहीं है रिगार्डिंग दिस आवर टेराटोमा सैक्रोकॉक्सियल पर से, बिकॉज़ इट इज इन द ओरोफैरिंजियल मेम्ब्रेन. क्लियर? सो ये क्वेश्चन है, अच्छा क्वेश्चन था, इट्स अ वेरी वेरी गुड क्वेश्चन, स्टैंडर्ड क्वेश्चन. Then there's one more question, which of the following is derived from the arrow district. Now arrow was somehow told to us was placed on this area. अगर दूसरा कलर दिखाऊं, on this area. यहां पर आपका एरो प्लेस था, ये क्वेश्चन था. Now we should know, knowing क्या है ये, क्या बनाया उन्होंने. देखिए we all should knowing ये है क्या. This is paraxial mesoderm. I am sure अगर आपको बेसिक भी अगर आपने इमेजेस पलटी हैं, if you have just gone through the images of the embryology, इमेज आई होगी. Paraxial mesoderm close to the axial. Axial नहीं है, axial mesoderm क्या है? That is notochord. तो बीच में जो दिख रहा है आपको, that will be basically neural tube. जो ये यहाँ पर दिख रहा है, this will be the neural tube. Below it you have a notochord over here. Then you have the paraxial mesoderm. उसके साइड में over here what is this? This is intermediate mesoderm. And बाहर क्या जा रहा है? Lateral plate mesoderm. So you have 3 basic types of mesoderm, from medial to lateral, paraxial, intermediate and lateral plate. अब the arrow, as the students told, was placed on the paraxial mesoderm. तो इसका derivative क्या है? Now we all should be knowing. I am saying should be knowing. Basic चीज है, this forms somites. ठीक है जी. Somites from what? Somites from sclerotome. अच्छा, और it also forms dermomyotome. अच्छा, now sclerotome and dermomyotome. Dermomyotome means dermis and muscles. Dermis कहाँ का? Post body wall की dermis, and generally most of the muscles are formed from the myotome over here. Sclerotome क्या बनाएगा ये? Now as it is close to this neural tube कहाँ है? Neural tube obviously brain बनाएगी, spinal cord. So it will be covered by what? It will be covered by vertebrae. तो ये जो area है यहाँ पर, that is basically the vertebral area. समझी बात को? And therefore, what is attached to the vertebrae are the ribs. So basically the sclerotome from here is going to basically form, क्या बनाने जा रहा है? It is going to form, याद रखिए, axial skeleton. This we have told a lot number of times, except sternum नहीं बनाता ये. Sternum comes from the lateral plate mesoderm. तो ribs और vertebrae यहाँ से आ रही है. अब देखिए बस क्वेश्चन आसान हो गया. ribs आपका पहला ही ऑप्शन है, काम खत्म. So which is derived from the arrowed structure? As the arrow was on the paraxial mesoderm, answer would be ribs. अगर ribs ऑप्शन है, बेस्ट आंसर ही है. उसका और ऑप्शन देखिए, parietal pleura. अब देखिए, the parietal and the visceral pleura, they are coming from the lateral plate mesoderm. इनके बीच में कैविटी दिख रही है, that is a pleural cavity or peritoneal cavity. Kidney and spleen are also mesodermal, but kidney is basically coming from which part? It is coming from the intermediate mesoderm. We all know metanephros, metanephroblastema, वही सब है. Spleen comes from the again mesogastrium, dorsal mesogastrium. Dorsal mesogastrium. Why? Sir, spleen तो abdominal organ है, so endoderm होना चाहिए. No. Spleen is basically lymphoid organ functionally. ये आती है mesoderm से. Right? Therefore, जो हमारा यहाँ पर sclerotome है, somites है, gives rise to ribs, definitely, right? So these are the probable recall questions. I know there is a scope for improvement. कुछ और options add on हो सकते हैं, कुछ और statement बनेगी. But yeah, for the immediate recall, this was the best possible. And I hope you like the session, or like तो छोड़िए, आपके अच्छा जाना चाहिए क्वेश्चन, एग्जाम्स अच्छा जाना चाहिए. ऑल द बेस्ट फॉर द रिजल्ट. रिमेंबर, टॉपिक आप पढ़ के रखो, और एनी अदर चेंजेस इन द क्वेश्चन ऑप्शंस, most welcome. Comment box, we are ready to go through it, and we will obviously try to make it up more close to the actual exam. That's all. Thank you from my side, and all the best.
Good evening, ladies and gentlemen. This is your friendly neighborhood ophthalmologist Ashwat Ray from the Allen's Table, welcoming you a very warm welcome to the ophthalmology recall session of the INI-CET November 2023. A warm welcome, and it is a fairly warm night in November from Delhi. And we go to this. Remember, these are recall-based questions, which is obviously not perfect because after the INI-CET exam, many of the students cannot even recall their own names. Forget about the questions. So these are necessarily approximations. So you are welcome to give me the questions at my email ID if you find them better, and you can recall them at your leisure. But till then, this is what we have. And look at the first question. Is the following investigation used for measurement of? You have a picture here, and many of you may not have this picture, but actually it's a very well-known thing. This is measures the choice A, proptosis, B is diplopia, C is squint, and stereopsis. The answer is, ladies and gentlemen, is going to be proptosis, because this is what is this? It is nothing but your Hertel's exophthalmometer. Okay, this is called an exophthalmometer, which is the most common exophthalmometer when you want to measure exophthalmos or even enophthalmos. Please remember the difference between exophthalmos and proptosis. You might remember, and if you have attended my classes, I always say that exophthalmos is and proptosis is the same thing, except that exophthalmos is a term used when we use the pathology is endocrine, okay? So for thyroid. But if there is a tumor pushing the eyeball out, that's proptosis. If there is any other mass pushing the eyeball out, that's proptosis. So when the cause of the proptosis is endocrine, then we call it as exophthalmos. So what we do here is called an exophthalmometer, called the Hertel's exophthalmometer, which looks like this, and it is spelled something like S-E-R-T-E-L, Hertel's exophthalmometer. And you see here what we do. This is an instrument which is placed at the two orbital rims. So what it does, it measures basically the distance in millimeters from the lateral orbital rim to the corneal apex. Okay, so from the apex of the cornea to the lateral orbital rim, it measures the distance, and usually it can be anything between 10 to 21 millimeters. Okay, so we do it for both eyes and compare the distance. And if it is more than 21 millimeter, then this is called as exophthalmos or proptosis. Okay, and suppose it is, how do I make out the difference between the two eyes? Suppose one is proptose and the other is normal. Remember, a difference of 2 millimeters between the readings, more than 2 millimeters between the two readings, is a sign of exophthalmos, that one eye is protruding. Okay? Or absolute if it's more than 21 millimeters. So what you do, it measures basically the reflection is seen in these are mirrors here, built on mirrors here, and you can see the reflection of the cornea on the mirror, and this coincides with a scale which you can read off directly, which should be between 10 to 20 millimeters. So what is measuring distance between the orbital apex or the orbital rim, beg your pardon, to the corneal apex? So that is what is the Hertel's exophthalmometer, and this is the instrument which has been shown to you. So this should not be a very difficult question if you have seen the instrument. However, if not seen it, then of course that's not going to be so easy. The second image is, again, of late they have been asking this question too many times in the last few years. So students are well advised to watch this image. Again, what it says the following image shows, so you see this bluish thing, and what the question we've got is in various ways. You know, some said they have asked the filter also, some asked the pathology, and some asked the stain. So I'll tell you all of them. As I said, since we are not very sure of the question, let me tell you all about it. So the first choice is lissamine green for corneal ulcer. Second says rose Bengal stain for corneal opacity. Third choice fluorescein stain for corneal ulcer. And fourth is rhodamine stain for corneal scar. So the answer here, as most of you will know well by now, is a fluorescein stain of a corneal ulcer. Okay, now this is the correct answer. And let's talk in case we are missing. And the filter, sometimes some of the questions that have filtered down to us ask us the filter also. The filter is the cobalt blue filter of the slit lamp. We have these multiple filters in the slit lamp. You have a cobalt blue, you have a red free filter, which we can see. So see what happened. This is what look is this. Now this is a corneal abrasion. It could be corneal ulcer. See, basically fluorescein stain is what? It's an orange colored dye. Fluorescein stain is a dye actually. We call it stain. It's an orange colored dye. And this fluoresces. And fluoresces means that it absorbs a certain wavelength and emits it as a certain higher wavelength. Okay, so a lower wavelength light is absorbed and it is re-emitted as a higher wavelength. So that is why you cannot see the orange colored dye here. Okay, so what the filter is a cobalt blue filter, so it converts the normal light of the slit lamp into the bluish filter, and this stain, it absorbs the blue light and re-emits as a greenish dye. That is why you see the stain in green, and that is why you use the blue filter. So we are able to allow the stain, the fluorescein dye, to absorb the blue light and re-emit it as green, which is what we see. And remember, this fluorescein stain is useful because it stains not the epithelium but the stroma. So if you have a normal epithelium like this area, see this is normal epithelium, so there is no staining here. But any area the epithelium is denuded and making the stroma is bare, it will stain that. So remember that fluorescein stain stains all kinds of epithelial defects, epithelial abrasions, epithelial ulcers, corneal ulcers, abrasions, defects. Okay, this is called fluorescent staining. Very useful thing sometimes because you tend to miss these stains, these defects when you see it with normal slit lamp. And so this is the fluorescent stain and the corner. What about the lissamine green? Remember, lissamine green is a dye which is used to stain the conjunctiva in dry eyes. Please remember the different pathology. Not the cornea. Fluorescein is for the cornea, lissamine green is for the conjunctiva, and the pathology is for dry eyes. Rose Bengal, the second is also same. The rose Bengal also stains the conjunctiva and it is also for dry eyes. So we have two different stains for the same pathology. But you might answer, why do we require two different stains for the same pathology? Well, you see, Rose Bengal used to be the original one that we used to, but this Rose Bengal, and remember, it's got nothing to do with Bengal, okay? So Rose Bengal, remember, is the original dye, but it's a little irritating. And often you have the patient winces, in irritation because when you stain the cornea. So this was the initial dye would do stain the dry conjunctiva. So lissamine green is a better dye because it's not so irritating and it stains the conjunctiva equally well. So remember, if you have a dry eye, the conjunctiva is dry, you can use either Rose Bengal or lissamine. Which is preferable? Lissamine green is preferable. So remember, in dry eyes, we can use, for dryness of the conjunctiva, we prefer the Rose Bengal or the lissamine. And if it's more advanced dry eye, suppose dry eye is more advanced, from the conjunctival dryness, it goes to corneal dryness, okay, then we use a fluorescein stain. So kindly remember the difference. Lissamine and Rose Bengal are for conjunctival staining in dry eyes, and fluorescein is for corneal staining, either in dry eye or in an ulcer. So that is the difference. So this is also, I would like to add here for future MCQs. Of course, remember we are talking about the subject now. There's now something with fluorescein which is also called as negative staining. Okay, this is called negative staining. This is completely different from positive staining. This is a positive stain, is this one, this green area that you see, which tells us this particular area of the cornea is defective, is corneal, is positive staining. Negative stain will not show you like this. Negative stains are exactly the opposite. Negative stain is seen when there's an elevation of the cornea like this, okay? Remember, this is not an elevation. A positive stain is seen when there's a defect, so which means the epithelium is missing. So there is excavated area, a defective area of the epithelium which is missing. It is staining the stroma. A negative stain is completely the opposite when there's not a defect but an elevation. An elevation, so what the dye does, it runs off the elevations and creates a darkish spot. It does not fluoresce brightly green like this. It shows a dark area of the cornea. That's called negative stain. It's very useful to pick up elevations of the cornea which are normally not visible, like in certain dystrophies like epithelial basal membrane dystrophies and all, okay, where the elevations are not particularly clear. So that's about your fluorescein staining. Then we come to an old question, particularly a favorite of mine because I keep talking about it. The prescription glass shows a -1 with a -2 at 180. What kind of astigmatism it is? So we have mixed astigmatism. Incorrect. Choice B, simple hypermetropic, completely incorrect. C, compound myopic with rule, confusing. D choice, compound myopic against rule, again a little confusing. And so let's stick with that. First of all, to diagnose this question, remember, we have to see the number of signs, okay? You have -1 and a -2 diopter cylinder advantage. So we have 2 minus signs. Remember, when you have 2 minus signs, it becomes compound myopic. Okay, when you have 1 minus sign, like what? Like -1 diopter cylinder at 180 degree. Now you see there is a minus, there is only one single minus sign. So this would be a simple myopic. Okay, let's look to simple first. When you have two minuses, it becomes compound myopic, right? Now compound myopic, but we have two different choices. It could be with the rule, it could be against the rule. And remember to just go over the definition with the rule. Remember, with the rule astigmatism just states that it is a curved surface where the vertical curvature is more than the horizontal curvature. Okay, so this is what it looks like. It looks like an American rugby football. Okay, look at that. You have this curved surface like a football here, isn't it? Something like this. And here the vertical curvature is simply more than the horizontal curvature. We call this with the rule. Why do we call it with the rule? Because it is much more common. Okay, it's much more common seen with the rule. Curved surface is much more commonly seen in nature. Younger people up till 50 years of age, which means all of us, is with the rule astigmatism. It's called with the rule because simply it's more common. And against the rule astigmatism is again a curved surface, but this time it's different. Here the horizontal curvature is more curved than the vertical surface, which is flatter. Okay, so remember, with the rule the vertical is more steep, against the rule the horizontal is more steep. Okay, so that's the definition. And it's called against the rule again. First, it is less common, and second, it's seen, remember, in older people above 50 years of age because of the flattening the cornea develops against the rule mostly. Now, by looking at the prescription, how do we find that out? By looking at the prescription, how do we find out whether it is with the rule or it is against the rule, isn't it? So let's look at that. Remember that with the rule, if you have, I'll first tell you how to memorize it. So with the rule, we call it WTR, is memorized that you place a plus cylinder at 90 degree or a minus cylinder at 180 degree. Okay, or you just reverse the opposite. So if it's that is plus at 90 or minus at 180, this is with the rule. Similarly, against the rule astigmatism, it will be exactly the opposite. Will be any minus cylinder placed at 90 or a plus cylinder placed at 180 degrees. Okay, first let's memorize this, then I'll tell you why it is so. Okay, so with the rule again, remember, it's very simple. With is more common. Remember, with is we are with it, you are with the times. Okay, we have to with it. Okay, so that's why plus at 90 or minus 180. And against the rule, you simply reverse the signs. If from plus it becomes minus, so minus at 90, and minus becomes plus, minus 180. Okay, so now let us look at that. So if you have a prescription, we have this minus 1 with a minus 2. Look at the sign. This is a minus 2 at 90 degree, at 180 degree, sorry. So minus at 180, remember, we just said is with the rule astigmatism. So the answer here, ladies and gentlemen, is choice C, which says compound myopic with the rule astigmatism. Because again, remember, just take a look at that, what I just said. I just said that is plus at 90 or minus at 180 degree. So you can clearly see that what we have here is a minus at 180. We have a minus 180, so minus 180 is a with the rule. Okay, so this opposite against the rule. But tell me, why is it so? It is so, you see, let's talk in terms of minus cylinders. It was easier to explain. Remember, because it is a with the rule astigmatism, it is, remember I just told you, the vertical surface is more curved and the horizontal surface is less curved. So what we do when we place a minus cylinder at 180, look at that. Okay, I'm looking at the minus cylinder form. In with the rule, why we give it a plus at 90 or minus 180 is that if I place a minus cylinder at 180, remember what it does, it increases the elevation of the flatter curvature to make it equal that of the vertex. Remember, the vertical was more curved, the horizontal was less curved. So by placing a minus cylinder at 180, what we are doing, we are making the horizontal curvature, which is flatter, we are elevating it to become equal with that of the vertical curvature, and that is how it corrects it. Okay. Similarly, for against the rule, why we use a minus at 90 is, remember, against the rule states that the vertical curvature is flatter and the horizontal curvature is more curved, is it not? So what we do, we are placing a minus at 90, what we are doing, we are increasing the elevation of the flatter axis, which is the vertical one, is it not? So by placing a minus cylinder at 90, so what we are doing at the 90, which is flatter, we are elevating it and became equal with the horizontal, which is more curved. So that is the logic, why plus at 90 or minus 180, or y minus 90 or plus 180. So kindly remember, do not forget this. This is always asked and this is a compound myopic astigmatism with the rule astigmatism. Very well. Now, a 21-year-old boxer wants to get rid of spectacles. Which refractive procedure should be avoided? Now remember, dear me, first of all, a 20-year-old boxer, if you are into boxing, you should preferably avoid all refractive procedures, is it not? You should. But however, this is an MCQ theoretically, and I must tell you, what he should definitely avoid is a RK, which is a radial keratotomy. Radial keratotomy, because it makes the cornea very weak. So radial keratotomy is like this. What we place radial cuts like this. There are 8 radial cuts at 90% depth, so it weakens the cornea. So what it does, see, this is the cornea like this. So by placing these cuts radially at a depth of 90%, going right up to the Descemet's membrane, we are weakening we are flattening the cornea, correcting the myopia, but also weakening the cornea. So if you are a boxer, you should definitely not undergo RK. That is absolutely Second is LASIK. LASIK should also be avoided. Please remember, those of you into contact sports, or any kind of sports for that matter, remember, any of you, those of you have active lifestyles. See, most of us are doctors and most of us patients, we are not active lifestyles anymore, okay? Active means that you're running around, you're jumping, you're bungee jumping, playing football, you're boxing, you're jogging. Even in these cases, LASIK would not be a great procedure, okay? So, RK and LASIK are definitely contraindicated. And if you are a boxer, the only thing that you can do is PRK. PRK stands for photorefractive keratectomy, and this does not weaken them because we do not make a flap. Unlike LASIK, we do not make a flap. So, PRK is reasonably safe. Even for a boxer, I would say PRK could be dangerous. But however, if you have to choose one of them, we would choose a PRK is the only safe option in a boxer. So, those of you at active lifestyles, running and jogging and playing soccer and football or badminton, this is the surgery of choice for you. LASIK is great, LASIK is wonderful, LASIK is tremendous. You open your eyes and you see very clear vision. But remember, LASIK weakens the cornea a little bit. So it's okay for people, couch potatoes like most of you, lying down and reading. Okay, doctors, the only exercise they do is climb up the stairs or climb up the elevator, that's all. So it's open people, LASIK is good for people who are fairly, who do not have very active lifestyles. However, if you have an active lifestyle, a PRK is better. Okay. What about SMILE? SMILE is also okay in a person, but not in a boxer. Okay, not in a boxer. So in this case, the answer would be all 3 will be avoided: SMILES, a LASIK, and a RK. The only thing that is not avoided would be PRK. Okay. However, I have to tell you that between SMILE and LASIK, remember the SMILE procedure, because it does not create a flap, so it does not weaken the cornea, the biomechanical stability of the cornea remains okay. So a SMILE can theoretically be performed on a boxer also. Theoretically performed on a boxer, but in a practical situation, I would not like to advise it. So ladies and gentlemen, here the answer that we only have should be avoided as definitely LASIK avoided, RK avoided, and even SMILE should be avoided. The only thing that can be done is a PRK. Okay, very well. And then we have this question. We do not have too many questions, remember, in this short time today. As I told you, most of the students were not able to recall their own names, so they were unlikely to recall all the MCQs also. So this is the last question that I have, and this says a 50-year-old diabetic patient with a history of diabetes since 20 years. That's quite a lot. And fundus exam shows NPDR, which is non-proliferative diabetinopathy. You know that there are 2 stages: NPDR, where there is no new blood vessels, and PDR, when there are new blood vessels. Which of the following would not be observed? Would not be observed. So let's start from the bottom. Venous bleeding will be observed. Soft exits will be observed. Retinal hemorrhage, like flame-shaped hemorrhage or Doppler blot hemorrhage, can be seen in NPDR. But which cannot be seen is disc neovascularization. This is NVD, and this immediately means the patient is not in NPDR, he comes into PDR. Is it not? In proliferative diabetinopathy, we have 2 different things. How do we know the patient is in proliferative diabetinopathy? First, he has neovascularization of the disc, we call NVD. Second would be NVE, which is neovascularization elsewhere. Elsewhere means neovascularization anywhere on the retina apart from the disc. And third, he could have pre-retinal hemorrhage. He could have a hemorrhage also, pre-retinal hemorrhage. All these things will be told us if you are in PDR. So we have venous bleeding is possible in NPDR, soft tissue is possible, but not a disc neovascularization. This is not possible. So this is the answer, because which is not an NPDR. This is a sign of PDR, is it not? So ladies and gentlemen, that is all that I have for you. I may have missed some questions. I am sure that I have missed out some more questions. But if I have, please write to me at this email ID that I am provided to you. It's DR. You can write to me, and if I have missed out, and I think I have missed out quite a bit, I will come back to you again very soon. So this is DR for doctor. I happen to be a doctor, though it doesn't look like it sometimes. SHASHWATRAY@gmail.com. Kindly write to me if there are some missing questions or there are some doubts if you have, and get back to you shortly as fast as I can. Normally I'm very fast at this. It takes about 3 weeks to answer. Well, not really, but I try my best. Thank you very much, ladies and gentlemen, and all the best. And may I say that I'm so glad that I did not have to take this exam along with you people. Thank you very much, and all the best.